Sir, Dr. Ranjit Unnikrishnan is here. Dr. Unnikrishnan. Hello. Hello. Hello.
Sir, he is probably not here.
So there are only 2 speakers.
3 speakers. I think he will join in few minutes.
Okay.
Should we start the talk with Dr. Jay Kumar to be punctual, sir?
So should I start?
Yes, sir.
Yes, sir, start.
Okay. So good afternoon, ladies and gentlemen. I welcome you all in this session where we are going to discuss a very important topic, but yet very less discussed, is the special type of diabetes. According to etiological classification, diabetes, there are 4 types of diabetes. As you all know, type 1, type 2, gestational, and other specific type of diabetes. This group of diabetes, that is other specific type, was previously known as secondary diabetes. So in this group, the pathological mechanism may be either there is loss of function of beta cell without the presence of markers of type 1 diabetes, or there are some conditions which can develop the insulin resistance because of some endocrinopathies. So these type of diabetes are called as special type of diabetes. Now, when to suspect about this condition and how to proceed in this type of diabetes, what are the investigations to be done, and what are the other special and more common type of diabetes in this subgroup. Actually, this subgroup of diabetes constitutes about 1 to 2% of total diabetes, but because of the lack of facilities available, it is many times it is not diagnosed and treated like other diabetes. So we have so many questions regarding this topic. We have 3 eminent speakers with us today: Dr. R.V. Jayakumar from Kochi, Dr. Sunil Kota from Behrampur, and Dr. Ranjit Unnikrishnan from Chennai. So I asked Dr. Avinash Mehta to introduce the first speaker and start this scientific session.
Thank you, sir. Thank you for the opportunity. As such, Dr. Jay Kumar does not need much introduction, but to complete the line of formal introduction, I will go through. He is a senior endocrinologist at Aster Medicity Coaching. He is also a senior endocrinologist at Caritas Hospital, Kottayam. He has been the founder president of the Indian Thyroid Society. He is the past president of the Endocrine Society of India. He is the past president of RSSDI, and he is HOD Medicine, Trivandrum and Kottayam Medical College. And formerly, he is the professor of endocrinology at Amrita Institute of Medical Sciences. With this introduction, I would request Dr. Jay Kumar to deliver his talk. Thank you, sir.
Thank you. Go. Movie then.
Good evening. Am I audible?
Yes, sir, you are absolutely loud and clear.
Okay. I welcome all my dear friends. At the outset, let me thank the organizers for inviting me to give a talk on secondary diabetes, when to suspect. And if you look at the topic, the secondary forms of diabetes include those diabetes or glucose intolerance that develops in association with the other disorders or factors. The prevalence is around 1 to 2% of all diabetes. The extent of glucose intolerance in patients with secondary forms of diabetes can vary widely, presenting as overt diabetes, that is insulin requiring a type 1, or non-insulin requiring type 2, or as milder forms of as such as impaired glucose tolerance or minimally abnormal glucose tolerance. Another complexity in the evolution of the secondary diabetes is that an underlying coexisting predisposition to primary diabetes might be unmasked, not an uncommon occurrence considering the relative high prevalence of diabetes in various populations. If you look at the pathogenesis of the secondary diabetes, it may be an endocrine cause of diabetes, like that a result of an excessive hormone that are counter-regulated to insulin, like growth hormone or cortisol, or it may be by inhibiting the insulin secretion or action by the endocrinopathies. Or when that's diabetes is secondary to a pancreatic disorder, particularly when beta cell mass is greatly reduced, as in malignancy or pancreatectomy. There is a second talk on this topic alone. And when the diabetes is due to a chemical agent toxic to the beta cells, such as pentamidine or alloxine, overt diabetes will often result depending upon the extent of beta cell loss. And numerous mutations affecting the glucose sensing receptors, glucose insulin synthesis, insulin action, insulin receptor, all can predispose to secondary diabetes. So far identified these mutations involve those involving the insulin gene, insulin receptor gene, and other candidate genes such as glucokinase, insulin receptor substrate 1, and mitochondrial DNA gene. The most common cause of secondary diabetes are in this four groups mainly: the disease of pancreas that destroy the pancreatic beta cells, for example, hemochromatosis, pancreatitis, cystic fibrosis, pancreatic cancer, or it may be hormonal syndromes that interfere with insulin secretion like pheochromocytoma, or it may be hormonal syndromes that cause peripheral insulin resistance, for example, acromegaly, Cushing syndrome, pheochromocytoma, or it may be drugs like phenytoin, glucocorticoids, or estrogens. So now we will start the discussion with a case. So here is a gentleman who is 33 years old, male, working in Dubai. He was diagnosed to have diabetes at the age of 25 years. Initial blood sugars were around 450. And when he was admitted initially, he had urine acetone positive, ABG, arterial blood gas showed metabolic acidosis, diagnosed and treated as diabetic ketoacidosis with the IV fluids and insulin infusion. Since then, he was treated as a type 1 diabetes with multiple doses of insulin, but he had a poorly controlled blood sugars, and he had multiple episodes of diabetic ketoacidosis requiring admission over the past 8 years, 5 to 6 episodes. And the last admission was in July 2021. When the final diagnosis was made, it was with the diabetic ketoacidosis again. Weight was 84 kilos. Height was 172. Funny thing, very obese guy with a diabetic ketoacidosis. Was on Glargine 36 to 32 and Novorapid 32, 32, 30 and metformin 1 gram daily. And during this hospital visit, the doctor saw him without a mask. And then he noticed that there is a change in the facial appearance as compared to the last 2 years. And if you then took the whole history again, and there is a history of gradual onset of increase in size of hands and feet for the last 9 years, including the wedding ring become tight, changes in the facial features in the form of frontal bossing and increased malar prominence, history of abnormal sweating and joint pain. He had hypogonadal symptoms like sexual dysfunction, reduced growth of body, and facial hair. And when he was biochemically evaluated, the IGF-1 was shown to be 820 nanogram per ml, very high, and serum testosterone was very low at 1.54, and the serum prolactin level was within normal limits of 10.9. Serum cortisol level was 8.8, low normal, and his fasting C-peptide was 1.75, and his urine microalbumin was 2.7, and his TSH was 0.16. and the serum creatinine was 0.86, and the hemoglobin A1C was 10.1. All shows that uncontrolled sugars with a reasonable fasting C-peptide and then a very high elevated IGF-1 level and low serum testosterone, and the lipid profile was normal. So an MRI pituitary showed the cellular lesion 15 into 15 into 13 millimeters as suggestive of pituitary macroadenoma, and modified Wilson-Hardy criteria grade 0, and nose grading was stage 1. So so the final diagnosis was pituitary macroadenoma, acromegaly, and hypogonadism. Secondary diabetes mellitus uncontrolled with a recurrent diabetic ketoacidosis. And so the follow-up, he underwent the endoscopic endonasal approach, and excretion of the pituitary microadenoma was done, was on hydrocortisone, tapered and stopped over 1 month, had transient postoperative diabetes insipidus, which was resolved. Repeat CT scan brain post-surgery did not show any abnormal enhancement. Insulin doses were reduced and stopped post-operatively. After discharge, blood sugars were managed with metformin and bildacaptan 50/500. 2 months later, of OHS, his blood sugars were normal, and hemoglobin A1C was 5.8%. That is 2 months after the surgery. So that is the story. So we'll go to the discussion part of this. This is a story of secondary diabetes due to acromegaly. Now, if you look at the pancreatic group of diabetes which can produce secondary, one important thing is after pancreatectomy, a pancreatectomy state provides a unique model of insulin deficient secondary diabetes. The insulin withdrawal in such patients compared to the patient with type 1 diabetes leads to lower and less severe ketoacidosis, despite comparable rates of lipolysis, supporting the role of pancreatic glucagon in the induction of ketoacidosis, because pancreatic patients will not have glucagon. So even though they will be off insulin, their ketoacidosis will not be very significant. Then another group which can produce pancreatic diabetes is pancreatitis. Compromised blood flow to the islets from fibrotic scarring, exocrine pancreas appears to play a major role. Insulin and C-peptide secretory responses to various secretagogues are impaired, and these abnormalities are correlated with the magnitude of exocrine pancreatic dysfunction. And glucagon levels are markedly increased in the acute pancreatitis, both in the basal stage and following stimulation. But in chronic pancreatitis, basal glucagon may be normal or elevated. The other condition is malnutrition-related diabetes. The World Health Organization has identified 2 main subgroups: protein-deficient pancreatic diabetes or J diabetes, and fibrocalculous pancreatic diabetes. And the etiology of both forms of malnutrition-related diabetes and their relationship, if any, remains enigmatic. And one possibility is that protein deficiency might render these beta cells susceptible to damage by toxic, viral, or autoimmune factors. It is endemic in areas where cassava tapioca is a staple food, and cassava 95% starch, which contains a cyanogenic glycoside. And the other important pancreatic cause of secondary diabetes is due to hemochromatosis. And hemochromatosis, one of the most commonly inherited metabolic abnormalities in white population. It is an autosomal recessive disorder. Iron deposition primarily occurs in parenchymal cells of pancreas, adrenal, anterior pituitary, myocardium, and skeletal muscle. And the classical triad of hepatomegaly, diabetes, and skin pigmentation, so-called bronze diabetes, once considered common, is now not a frequent association. Presence of symptoms usually correlate with the severity of iron accumulation. Then hepatocellular carcinoma develop in about 15 to 30% of patients, despite successful iron removal. Hemochromatosis can also result, even if it is a genetic disorder, it can also result from a number of secondary causes, including sideroblastic anemias, then chronic hemolytic anemia, multiple blood transfusions, porphyria cutanea tarda, and medical iron load condition, and also iron-rich beer. If you look at the endocrinopathies responsible for secondary diabetes, first important thing is acromegaly, which I all showed the case. Acromegaly represents a prototype of diabetes and glucose intolerance, secondary to an endocrinopathy. And glucose intolerance is prevalent in acromegaly in 60 to 70% of patients. However, overt diabetes requiring treatment occurs only in 10 to 15%. And the other condition which can produce diabetes due to endocrinopathy is Cushing syndrome, and the glucocorticoids and growth hormone are the main insulin antagonist hormones in the body. And insulin resistance induced by the chronic administration of moderate dose of glucocorticoids in normal humans is usually compensated by the augmented insulin release, resulting in minimal changes in glucose levels. The spectrum of glucose intolerance in patients with Cushing syndrome largely depends on the endogenous beta cell reserve. Glucose intolerance occurs in 75 to 80% of patients with Cushing syndrome, but only in 10 to 15% of patients develop overt diabetes. Nearly all patients, however, manifest basal and stimulated hyperinsulinemia and insulin resistance. The other is a primary hyperaldosteronism, which is a triad of hypertension, hypokalemia, and glucose intolerance. Cone syndrome occurs in 2% of patients with hypertension, and glucose intolerance previously thought to be present in 50% of these patients is considerably less common and is usually mild form. And isolated growth hormone deficiency can also be associated with secondary diabetes. It has been long appreciated that growth hormone has a cytotropic effect on the beta cells in vitro. So the model of diabetes supports the role of growth hormone in sustaining beta cell growth and maturation during the infancy. The pheochromocytoma is another endocrinopathy which can be associated with diabetes. Here the mechanism is slightly different. Catecholamines acting via adrenogenic receptors affect insulin secretion and produce anti-insulin effects at several loci in the intermediary metabolism. Glucose intolerance occurs in 30% of patients with pheochromocytoma. It can result from multiple mechanisms, including alpha-2 adrenogenic inhibition of insulin secretion, beta adrenogenic stimulation of hepatic glycogenolysis and gluconeogenesis, and enhanced lipolysis. Overt diabetes and ketoacidosis are distinctly unusual. Hyperthyroidism, a common condition which we come across on many days, can also be associated with aberration of carbohydrate metabolism. One of the mechanisms is that the metabolic clearance of insulin is increased by 40% in the presence of hyperthyroidism. And the other mechanism are increased oxygen consumption, rapid gastric emptying, and increased lipolysis and ketogenesis. An increased incidence of glucose intolerance, which usually mild to moderate severity, has been documented in 30 to 50% of patients with hyperthyroidism. Other endocrinopathies is tumors of endocrine pancreas and gut, and the glucose intolerance of overt diabetes is frequent component of non-beta cell tumors of endocrine pancreas that secrete glucagon and somatostatin. These tumors are often malignant and quite large when diagnosed. Other clinical features of glucogonoma include a characteristic skin rash. Mild glucose intolerance has been occasionally been described in patients with non-islet cell tumors like lipoma and with carcinoid tumors of pancreas or gut. Polyendocrine autoimmune syndrome, insulin-requiring diabetes has been observed in 50% of patients with the polyendocrine autoimmune syndrome type 2, and characteristically multiple generations are affected. In type 1 syndrome, the affected relatives are siblings in a single generation, and there is no increase in HLA, DR3, and DR4. These patients may have insidious onset of diabetes years after the onset of initial endocrinopathy, such as Addison disease or thyroid disease. And POEM syndrome is another rare endocrine condition which can be associated with the glucose intolerance. Sometimes insulin requiring has been reported. The full form of POEM syndrome is polyneuropathy, organomegaly, endocrinopathy, monoclonal gammopathy, and skin changes. It is a rare form of plasma cell disorder. Now coming to the drugs, chemicals, and toxins associated with secondary diabetes. The most important is diuretics and beta-adrenergic antagonists, and the diabetogenic effects of diuretics, particularly the thiazides and chlorothalidone and beta-adrenergic agonists, have been well recognized in clinical practice. The other drug-induced secondary hypertension possibility is diphenylhydrandoins. They have directly inhibitory effect on beta cell secretion. This appears to be the dose-related, and there are occasional cases of hyperglycemic non-ketotic coma precipitated by dilantin. And then the glucocorticoids, oral contraceptives, and progestins are a group of hormones drugs which can also produce secondary diabetes. Glucocorticoid-induced glucose intolerance is characterized by insulin resistance and hyperinsulinemia. The effect of sex steroids on carbohydrate metabolism are somewhat controversial. The effect of oral contraceptives on carbohydrate metabolism in young women are much more dependent on the formulations, particularly on the dose and relative potency of the progestin component of the pills. The incidence of overt diabetes is distinctly rare in individuals without a family history of diabetes. Pentamidine and Vacor, and these are all, pentamidine is anti-protozoal and Vacor is a nitriurea derivative pesticide. And these are all chemically resemble to streptozotocin and alloxin. And the sequence of events leading to diabetes with these agents is similar to that seen with streptozotocin due to beta cell lysis lasting for hours. And nicotinic acid causes glucose intolerance by inducing peripheral insulin insensitivity. However, significant hyperglycemia or deterioration of glucose intolerance may result in patients with limited beta cell reserve. Cyclosporin, an increased incidence of diabetes has been reported in renal transplant patients treated with cyclosporin, particularly in the Black population, in whom a 20% incidence of post-transplant diabetes was reported. Direct inhibitory effect of cyclosporin on beta cells are the likely explanation, although effect on muscle glucose transport is also possible. Opiates, hyperglycemic effect of morphine and other opiates has been recognized. Beta endorphins and enkephalins are produced in the human islets, which are diabetogenic. Now coming to the other specific types, that is genetic and syndrome related one. See, genetic disorders of beta cell function, the whole group of MODY is based on this. And for example, MODY3 is based on HNF alpha gene mutation. And the MODY2 is based on glucokinase gene mutation. MODY1 is based on HNF4 alpha mutation. Others are there. Then also genetic defects of insulin action like type A insulin resistance, Rapson-Mendelssohn syndrome, lipoatrophic diabetes, and others are also related to genetic mutations. And genetic syndromes are sometimes associated with diabetes. For example, Down syndrome, Klinefelter syndrome, Turner syndrome, Wolfram syndrome, Lawrence-Moon-Beadle syndrome, Prader-Willi syndrome, and others are associated with diabetes. Immune-mediated diabetes is the Stiffman syndrome and anti-insulin receptor antibodies and others. Now the question is, secondary diabetes, when to suspect? That is the main topic. And so the most important thing is the detailed history and physical examination is the cornerstone in suspecting secondary diabetes and making a diagnosis. So when you take a history of abdominal symptoms, a history of recurrent abdominal pain, admissions, surgery in the past, in a type 2 looking patients, must give a clue that there may be a possibility of a pancreatic diabetes. So if there is any history of abdominal symptoms in the past, and also don't forget to think about pancreatic cause of that patient's diabetes, and do a minimum investigations like doing an abdominal ultrasound and a few blood tests will clear the doubt that whether this patient belongs to that group or not. Then a history of diabetes in 2 generations in a young or non-obese patient. For example, when a patient with 18 years, 19 years, 20 years coming, the question is whether it is a type 1 diabetes or a type 2 diabetes aware. But remember that if that patient is not obese, it can't be type 2 diabetes aware. Then you look at the history of 2 generations of family history of diabetes, then it gives a clue that it may be belong to the MODY group, and you can do the genetic studies. And the good physical examination of head to foot will remind you about the possibility of endocrinopathies. That you must remind you about acromegaly, about gigantism, about Cushing syndrome, all can produce secondary diabetes. And only if you do a physical examination, you will suspect these endocrinopathies in a diabetic patient. So finally, history and physical examinations together will give you a clue regarding the genetic syndrome, family history of mental retardation, short stature. All these will give you a clue to this absence of menstruation, to Turner syndrome, Klinefelter syndrome, all these genetic syndrome. That will give you only the physical examination and a good history taking will give a clue, and that will direct you to look for secondary causes of diabetes associated with these genetic syndromes. What about the investigations? There is nothing different. It is investigation depends upon what is if it is a pancreatic disease responsible for it, you go on that direction. It is an endocrine cause, refer to the endocrinologist to exclude the endocrine causes. If it is a genetic one, you'll have to do the gene studies and mutation studies to confirm or exclude this. So diabetes masking as an endocrine or pancreatic defect, the prevalence of secondary diabetes is increasing because the lengthening of life expectancy of people affected by genetic, acquired, dysmetabolic, and neoplastic pancreatic disorders. But these may remain unrecognized after a diagnosis of diabetes has been made. So even if a diagnosis of diabetes, don't forget about the associated possibilities of a pancreatic disease the patient having. Conversely, a correct diagnosis, secondary diagnosis is fundamental to ensure satisfactory glycemic control while avoiding hypoglycemic episodes as much as possible. Taken as such, 90 to 95% of diabetic patients will be diagnosed as having type 2 diabetic patients, but about 3 to 8% will have other specific type of diabetes. It may be secondary to endocrine, genetic, or environmental, or at other cause of defective glucose handling. So in conclusion, I must say that the category of other forms of diabetes, even though rare, is becoming more important because you should not miss it because there are facilities to make a diagnosis at this present. It is a challenge for the diagnostic and therapeutic skills of the diabetologists, endocrinologists, and the internists. The case I have presented, the first part, the acromegaly with diabetes, clearly shows how a patient dubbed as a type 1 diabetes with multiple ketoacidosis, going from hospital to hospital, taking multiple doses of insulin, is now walking around as a non-diabetic individual because a correct diagnosis, the physician happened to look at his face and it clicked in the physician's mind about the possibility that this looks little acromegaloid. So then going back and taking the history, it was able to make suspect the diagnosis. And once the diagnosis is suspected, because there is a protocol is there to follow to make a diagnosis of Cushing syndrome or diabetes, well-written protocols are there. If you do on that lines, you will be able to confirm it. And if you are able to confirm it, majority of endocrine problems, you can treat it. And that is why that patient is walking with a hemoglobin A1C of 5.8 and as a normal individual without any diabetic medications. And so they should be aware not only of the specific therapeutic requirements of this patient, but even more so of the necessity of suspecting that what might look like a mild diabetes may be associated with conditions for which an early diagnosis can have life-saving implications. So my take-home message is, think about secondary diabetes. When you are a diabetic patient, does not look like a classical type 1 or type 2 or looking a little funny. Think about their secondary cause and you will be successful. Thank you very much.
Thank you. Thank you, Dr. Jayakumar, for your excellent presentation and elaborate presentation on this particular topic. The question answer will be taken at the end of this session. Now I invite Dr. Sunil Kota. He is from Behrampur. The host, can you please show the CV of Dr. Sunil Kota, please? Yes, Dr. Sunil Kota is an endocrinologist at Diabetes and Endocare Clinic at Behrampur. He has lots of peer reviews and publications and 18 book chapters he has written. He has been awarded ESI award for most number of publication in IGEM, best letter to editor, and there are many other publications and awards in his name. And with this, I request Dr. Sunil Kota to start his deliberations, please.
Thank you so much, sir, for those kind words. As I'm sharing my presentation, just let me know once it is visible to all of you so that I can start.
Yes, it is visible.
Okay. So very good afternoon. Thanks to the organizers for inviting me over here, and thanks to the chairpersons for those very kind words. And after presentation by R.V. Jaikumar sir, who happens to be our teacher like,
meeting में हूँ.
so it always is a pleasure, and sir has almost covered most of the part that I'm going to talk to you about. And pancreatic diabetes is a type of secondary diabetes where the pancreatitis with exocrine dysfunction is associated with gradual onset of endocrine dysfunction, giving rise to imbalance in the glucose homeostasis. So I would be starting with a case of 57-year female with 9 years history of intermittent burning abdominal pain, which was getting radiated to the back. It was attributed to upper GI symptoms. It was also associated with steatorrhea and subjective weight loss. And there was no consumption of alcohol, cassava, gallstone disease, or hepatitis. And there was no family history of pancreatic disease or diabetes as well. Initially, blood sugars were normal, but on routine follow-up, she was found to have elevated fasting glucose of 328, A1C of 14.6. Started with oral hypoglycemic. Mind it, there were no osmotic symptoms, no vascular complications, no history of presentation with DKA or diabetic ketoacidosis. Later, she was changed to biphasic insulin 4 years ago due to poor glycemic control. And now she is doing good with 20 and 15 before breakfast and before dinner. She is lean, emaciated, mildly pale, not icteric, no peripheral stigmata of chronic liver disease or hemochromatosis. But the classical, here you can see the diffusely calcified head, body, and tail, typically the bag of stone appearance, which is very much classical to pancreatitis. And on examination, you find microcytic hypochromic anemia with iron deficiency anemia. Alkaline phosphatase was marginally elevated. Serum protein was low. Thyroid lipid profile was normal. You can see ACR was mildly elevated at 30.39. So based on the findings, the diagnosis of SCPD was made, and definition, SCPD is a case of secondary non-alcoholic chronic pancreatitis of uncertain etiology, which is found predominantly in tropical countries. Treatment is based on glycemic control, management of pain, supplement of pancreatic enzymes, and we have to monitor the exocrine and endocrine functions of the pancreas. And on subsequent follow-up, she had her BMI improving to 19.7 with good glycemic control and is currently free of pain. So with this brief preamble, I'm going to take you through my presentation proper. First of all, I would be talking to you about the overview and classification. As Jaikumar sir has already stated, the most common forms are type 2 to type 1. And as per this article, around 1 to 5% of cases are due to disorders of pancreas endocrinopathy. And if you recollect the tabular representation of classification of diabetes, type 3C is the one which is associated with disease of exocrine pancreas. It is generally, there is a generalized pancreatic dysfunction, there is a structural and functional loss of glucose, normalizing insulin secretion, and commonly, as Jaikumar sir has stated, it is misdiagnosed as type 2 diabetes. It is also labeled as pancreoprivic diabetes, which is associated with inflammation and fibrosis mediated progressive and irreversible destruction of both exocrine and endocrine tissues, and there is loss of both insulin and glucagon secretion, and the requirement for the patient is much more than the standard patients they require. Taking you through the etiology and prevalence, you can see the type 3C, light green is representing around 9.2% cases, as it is roughly estimated to be to the tune of 10% currently. And if you talk about all the causes that are associated with pancreatic diabetes, 79%, it is stated around 25 to 80% of cases are due to chronic pancreatitis. We have a number of other causes like hereditary hemochromatosis, pancreatic cancer, post-pancreatic resection, and cystic fibrosis as well. And chronic pancreatitis, the prevalence of it contributing to diabetes is somewhere between 25 to 80% because it depends on the duration of chronic pancreatitis and other factors coming into the picture. Look at the graph at the bottom, it says it is 1985. 1959, the fibrocalculous pancreatic diabetes was first time diagnosed in Indonesia. It was taking the backseat, and in the year 1985, WHO recognized these two terms, the malnutrition related diabetes mellitus and protein deficiency diabetes mellitus. But in 1997, these were segregated into causes due to pancreatic origin as per the ADA. FCPD, it is unique and found in tropical countries like India, non-alcoholic and young individuals. And there is a group of people who do not have diabetes, which is a pre-diabetic phase. It is also known as TCP or tropical chronic pancreatitis. And you can see the prevalence, which is going up from 32% in 2002, followed by a study which was done in 2008. It came down to 3%. And unfortunately, in Asian population, we do not have much data to quote about the exact prevalence of pancreatic diabetes. And the causes, it is congenital or acquired complete absence pancreatic agenesis, or as Jai Kumar sir was alluding to, pancreatectomy. And also the chronic pancreatitis can also be a very significant cause associated with around 25 to 80% of cases of pancreatic diabetes. The causes can be alcohol, gallstone, hyperparathyroidism, hypertriglyceridemia, autoimmune destruction, pancreatic stones. And we have to also think of some of the genetic disorders, especially whenever the pancreatitis is familial in nature. Basically, we try to look at the SPINK gene, the SPINK, the PSSR gene, and the CFTR, which is associated with cystic fibrosis. And if there is any congenital abnormality, and there are some bacterial infections, especially mumps and the miliary TB, and there are some parasitic infections as well, schistosomiasis, hydatid disease, and drugs as well, especially as we all must be using the incretin mimetics, estrogen, thiazides, and corticosteroids. So these are some of the common causes of chronic pancreatitis. Also, we have a number of infiltrative disorders like hemochromatosis, pancreatic adenocarcinoma, and also acute pancreatitis. To talk about the pathology, the basic pathophysiology is the insulin deficiency, because there is a relative reduction in number of active islets. And apart from that, whatever islets are left, they are not functionally adequate thanks to the sclerosis and fibrosis that the pancreas undergoes. There is inflammation, and that is mediated by immune dysfunction, giving rise to cytokine-mediated inflammation. There is hepatic insulin resistance as well. The pancreatic stellate cells and the pancreatic cancer cells secrete something which give rise to hepatic insulin resistance, but because the patient is lean, the peripheral insulin resistance is not that much observed. And lastly, you can see because the patient is having impaired nutrient absorption, there would be reduced incretin response to meals as well. And the basic mechanism is the acinar cell injury due to autodigestion by trypsin, and also the trypsinogen gets prematurely activated to trypsin because of some of the genetic mutations. Some of the mutations like SPINK1, CFTR, and PRSS1 is one which we have already discussed about. And there are studies from Bangladesh and India which has thrown light on high association of SPINK1 gene with N34S mutations. And to talk about FCPD, it is again the same. There is some sort of defective beta cell growth and repair. There is stone formation, duct obstruction giving rise to acinar and beta cell damage, which can give rise to both exocrine and endocrine dysfunction. Add to it, we have malnutrition, excessive oxidants, and dietary toxins as well. Cystic fibrosis related diabetes is also one of the very common type, which is seen in around 20% of adolescents and 40 to 50% of adults. And once the diabetes is there, you can see there is a worse nutritional status, more severe inflammatory lung disease, and greater mortality. And here also the insulin insufficiency is the primary defect. Starting from age 10 years, the person has to be screened for blood glucose once in a year, and insulin is the main form of therapy. Coming to the clinical presentation, the classical presentation is that of abdominal pain, steatorrhea, maldigestion with nutritional deficiency and glucose intolerance. Here I'm going to quote one thing. I still remember where I was examined at the CMC Vellore, I had a case of FCPD. And having read from Hyderabad, I didn't have an exposure, but then I could find some subtle manifestations because there is fat soluble vitamin malabsorption. There is ADEK. There were some petechial spots at the back. So you can see some subtle manifestations of vitamin deficiency, especially the fat soluble ones. And also we have patients may also present with only maldigestion or abdominal pain. And very, very importantly, the diabetes is very brittle with marked glycemic lability and frequent hypoglycemia. What you find is that Along with this, the classical finding is that there would be markers of pancreatic and exocrine dysfunction, absence of autoimmune markers, which is classical to type 1 diabetes. You can see radiological manifestation of pancreatic damage, and because of insulin deficiency, you would require much more than requirement, which is much more than the usual presentation. And if you look at the FCPD, the triad is that of abdominal pain, pancreatic calculi, and diabetes, which is severe, fasting more than 200, patient is lean, usually non-ketotic. Again, there are 4 reasons attributed to it. It is stated, though there is insulin deficiency, the insulin deficiency is not complete. There is still some residual insulin. There is deficiency of glucagon also, because alpha cells are also damaged. So glucagonemia, hyperglucagonemia would not be there, which will not be giving rise to ketosis. The patient is lean, so adipose tissue giving rise to free fatty acid is also less, and also there is reduction in carnitine, which make them less susceptible to ketosis. Calculi are there, usually require insulin for control, and unfortunately seen in poor people, and they have a very high predominance towards development into pancreatic adenocarcinoma, and predominantly seen in places like Tamil Nadu and Kerala as far as India is concerned. And what about the manifestations in FCPD? It is stated that in 1981, there was a beautiful paper which says that type 1 diabetes do not have much of microvascular complications, because at that point of time, once diagnosed, there were not much of treatment options. The patients are dying early. Nowadays, that the patient's longevity has increased, we have papers which say that yes, microvascular disease, the complications are seen with increased frequency, but then macrovascular complications are seen very less often, because the patient is lean, the patient doesn't have much of hypercholesterolemia, and patient is also young. So this is actually, it can be TP, that means diabetes has not set in, it is only a tropical chronic pancreatitis. TCP, IGT, where impaired glucose tolerance is there. Then we have FCPD without complication, and also FCPD with complication. And we have studies now, though I have quoted 4 reasons why they would not be having ketosis. They can also be ketosis prone, as per this wonderful article in Journal of Applied Medicine. And I'm not going to read out the entire slide for you. You have a heterogeneity in form of symptoms, carbohydrate intolerance, beta cell reserve, response to therapy. Some respond to diet, some respond to oral agents, some responding to insulin, ketosis, exocrine dysfunction, histopathology. So you have a whole gamut of changes which can happen if the patient is having FCPD. And how it is misdiagnosed, this was a wonderful article in 2008 Diabetes Care. I'm just going to tell you the crux of this wonderful study. It states that around 10 to 40% of patients who are initially labeled as type 1 or type 2 diabetics have some sort of pancreatic exocrine dysfunction. So keep your eyes wide open to have a possibility of this thing. And the test, basically the stool test, the pancreatic exocrine insufficiency, we try to look at the fecal elastase in microgram per gram of feces. Normal more than 200, moderate exocrine pancreatic insufficiency is between 100 to 200, and severe exocrine pancreatic insufficiency when it is less than 100. Radiological investigations, I'm not going to list out all those, but then presence of calcification and ductal dilation by X-ray, ultrasound, or CT scan, we have a diagnosis of FCPD. Then the diagnostic criteria, which was first time published in European Journal of Internal Medicine in 2013, and subsequently we had this diagnostic criteria quoted in one of our API chapters as well. The major criteria, all of them should be fulfilled. Presence of exocrine pancreatic insufficiency according to monoclonal fecal elastase 1 or direct function test. Secondly, pathological pancreatic imaging by the modalities available. We have to ensure absence of type 1 diabetes associated autoimmune markers. Then there are some minor criteria. First of all, you have to demonstrate impaired beta cell function by HOMA beta. There is no excessive insulin resistance, which is characteristic of type 2 diabetes measured by HOMA IR, impaired incretin and pancreatic polypeptide secretion, and as I've already stated, deficiency of A, D, EK, which are fat soluble vitamins. Clinical characteristics, the slide looks busy, but I'm going to tell you the crux of the things. Look at the age of onset and pain abdomen, pancreatic insufficiency, and pancreatic polypeptide response. These are the things which should somehow point you towards occurrence of pancreatic diabetes. And chances of DKA is almost not there at all. And the diagnosis of FCPD, there again is a criteria which says that it should be occurring in a tropical region or a country. There should be diagnosis as per the WHO study group criteria. Evidence of chronic pancreatitis with pancreatic calculi as visualized in X-ray abdomen or unequivocal pancreatic ductal dilation as visualized in USG or CT scan, or at least 3 of the following: ultrasound showing abnormal pancreatic morphology, chronic abdominal pain since childhood, steatorrhea, and abnormal pancreatic function tests. And you have to always rule out other known causes of chronic pancreatitis, predominantly alcoholism, hepatobiliary disease, and primary hyperparathyroidism. Now coming to the complications, there can be endocrine dysfunction. Predominantly, it is a type of brittle diabetes. It goes haywire. As I've already stated, microvascular complications are being seen commonly nowadays because of the increased longevity and better delivery of care. Macrovascular complications, not that much there, especially if the patient is young, but the exocrine deficiency like steatorrhea, fat soluble deficiency, and there is because of vitamin D deficiency, there can be pancreatic osteodystrophy, and it always is it can always give rise to pancreatic cancer. Lastly, I will talk to you briefly about the management because it is very haywire. The target is to control diabetes and also screen for occurrence of pancreatic cancers. Chronic pancreatitis associated diabetes, especially it is stated that life expectancy is not that good. You try to control the sugars in order to get them rid of any chances of short-term complications. Long-term complications, we do not have much of studies, but for pancreatic cancer, we do not have good number of studies which tell us how do we go forward apart from maintaining the sugars. So prevent extremes of blood sugars, prevent malnutrition, malabsorption, and the comorbidities. And regular meal pattern is very important. Do not skip meals, take small frequent meals so as to avoid hypoglycemia. Glucose levels have to be very commonly tested. Avoid alcohol and smoking has to be avoided. Ensure adequacy of pancreatic enzyme replacement therapy. Minimize obviously high sugar or high glycemic index foods. And fat has to be avoided as far as possible because it can sometimes initiate a process of inflammation-induced fibrosis and damage to the pancreas. And obviously exercise, we do not need to do, we do not want it to be missed. It is always a must accompaniment for all of those, and minimum 6 to 10 times blood glucose testing occasion per day. This is as per this wonderful article in Diabetes Care. So more number of times is required if the patient is having more brittle type of diabetes. And management, metformin is the one because it takes care of the hepatic insulin sensitivity. But again, if it is failing, yes, you have to go on to insulin, but insulin, because of the higher chances of hypoglycemia, try to use analogs. If hyperglycemia is mild, metformin alone. If hyperglycemia is not getting control with metformin, you have to go for insulin. Sulfonylureas, it is stated that the ripaglinides, natiglinides can be used because they are not associated with hypoglycemia. Alpha glucosidase inhibitors can also be tried, but again, the pancreatitis patient will have gastric irritation, and if you add metformin and AGIs, you are going to make things probably worse. So you have to judge all those things. And thiazolidines, it is stated because of the pancreatic dysfunction associated with vitamin D deficiency, there can be subtle bone disorders. So thiazolidines better avoided. We do not have much of studies on gliflozins, but then the incretin-based therapies are apt to be avoided. And there is place of supplements, especially lipase. The starting dose is 500 to 1000 lipase units per kg of body weight with each meal, up to maximum 2500 lipase units. And fat soluble vitamin supplements should always be there because of malabsorption of ADEK. And then there are a number of options for the pancreatic calculi treatment. So I'm not going to delve into much. It is definitely recommended, especially whenever there is intractable pain and there are a number of procedures. It is generally the pancreatojejunostomy of longitudinal variety is a preferred procedure. So that brings me to the end of my presentation. It is a separate entity. Jai Kumar sir has clearly told us when do we suspect presence of secondary diabetes. So the treatment modalities are different. We went through a wonderful case of acromegaly giving rise to hyperglycemia. So the treatment modality differs. It is stated the recent studies 5 to 10% are now type 3C diabetes. So high index of suspicion is required. chronic pancreatitis is very, very important, and it should be screened for HbA1c. And mostly exocrine deficiency often predates the pancreatic diabetes, and young individuals living in tropical countries, FCPD is a real threat, real common diagnosis. And defective pancreatic polypeptide response is an early marker of pancreatic diabetes, as it indicates presence of exocrine dysfunction. And adequate glycemic control, pain relief, management of macro and micronutrient deficiency and pancreatic failure are important. And as the diabetes is very brittle in nature, we have to be very careful in titrating the dose, and also have to be telling to the patient that, yes, you need to be aware of these all possible complications. And also chronic pancreatitis is and FCPD are considered to be pre-malignant conditions for pancreatic carcinoma. So we need to keep these two things in mind as well. Thank you all for the patient listening. Now it's over to the chairpersons.
Thank you. Thanks for the excellent talk delivered. Very much detailed. I really appreciate the talk. Forward to Dr. Sen Gupta, sir. Kindly take over, sir, and introduce the third speaker. Dr. Sen Gupta, sir, are you there? Hello. Hosts, are you there?
Am I
Yes,
audible,
sir.
sir?
Yeah, please take over, Dr. Sen Gupta, sir.
Yeah.
Please.
Please, the host, please show the CV of Dr. Ranjit Jaikumar. Meanwhile, I welcome Dr. Ranjit Unikrishnan. He is our third speaker for this topic today regarding his academic career. He is the vice chairman at Dr. Mohan's Diabetic Specialty Center at Chennai. He has credit of publishing more than 100 peer-reviewed journals, and he has been awarded as the best doctor award by Tamil Nadu Dr. MGR University in 2012, and he has also been given Dr. Coelho Memorial Lectureship Award in Epicon 2015. So with these words, I invite Dr. Ranjit Unikrishnan for his talk on this particular topic.
Thank you, sir. Thank you for the kind words of introduction. At the outset, let me thank the organizers of RSS Day 2021, particularly Dr. Banshi Sabu, for inviting me to this conference and giving me the opportunity to speak on this very interesting topic. Now, with your permission, I will try and share my slides. So are my slides visible?
Yes.
Yes. So I've been asked to speak on how to approach a case of familial diabetes in a young individual. And I have no conflicts of interest relevant to this particular talk. And we all know that the prevalence of diabetes in young individuals is increasing by the day, not only in India, but in the rest of the world as well. And when we talk about diabetes in youth, we should realize that we are not talking about a homogeneous entity. There are a number of conditions that can present as hyperglycemia or diabetes in young individuals. In contrast to elderly individuals, middle-aged individuals in whom 95 to 98% of cases will be type 2 diabetes. In younger individuals, we have this wide variety of conditions between which we have to make our differential diagnosis. Of course, you have type 1 diabetes. You have type 2 diabetes in the young, which is increasing in prevalence. We have monogenic forms of diabetes, including the so-called MODI. We have fibrocalculous pancreatic diabetes, which the previous speaker has alluded to in detail in his talk. We have the various forms of endocrine diabetes, which Professor R.V. Jaikumar has talked about in his talk. We have some rare genetic syndromes, and don't forget gestational diabetes, because young women do get pregnant. So if you look at the proportion of cases contributed by each of these entities to the entire entity of young diabetes, and this is data from the ICMR Young Diabetes Registry. It's from all over the country. It's a voluntary registry. And we find that still the most common form of diabetes in the young continues to be type 1 diabetes. Around 2/3 of individuals with young diabetes below the age of 25 years have type 1 diabetes. But around a quarter have type 2 diabetes. Maybe around 3 to 4% have gestational diabetes or monogenic diabetes, and all the others put together come to around 2%. So this is the distribution. And among these different conditions, there are only a few that have a familial basis. And these include early onset type 2 diabetes, various forms of monogenic diabetes, including MODY 1, MODY 3, and MODY 2. And the test you can utilize the family history to come to an accurate diagnosis. Now, the first case is a 12-year-old girl who came from Sri Lanka, and she was diagnosed to have diabetes 6 months prior to her index visit to our center. Naturally, when somebody of this age develops diabetes, the first tendency for any physician would be to diagnose type 1 diabetes, and which is the right approach as well, because making a mistake there can actually kill the patient. So naturally, when somebody was diagnosed with type 1 diabetes, you put them on insulin. And the diagnosis, what was made was absolutely right, because her HbA1c was very high, sugars were high. So she was put on insulin. She was given insulin 2 times a day, a premix insulin. Now we all know that's not the ideal treatment for type 1 diabetes, but something is better than nothing. But even with this sort of regimen, the blood glucose levels were not controlled, and she came to us for a second opinion. Actually, they wanted to know whether the insulin could be stopped, which is always a question in the minds of parents of kids with type 1 diabetes. So when we evaluated her, we found that she was of normal weight. Her glucose levels had come down. HbA1c was still high, probably because insulin had just recently been started. All the other parameters were normal. There was evidence of acanthosis nigricans on the nape of the neck, which is a marker of insulin resistance. And we know that acanthosis nigricans is very uncommon in young children. So if you have acanthosis nigricans or skin tags in an obese individual, even if it's a child, you have to think of the possibility of type 2 diabetes. And here comes the importance of the family history. This is what is known as a pedigree chart, looking at 3 generations of both sides of the patient's family. And you can find that there is a history of diabetes on both sides of the family. Both the mother and the father have diabetes. And you can imagine if the child is 12 years old and she's an older child, you can imagine how old the parents would have been. They would have been in their 40s, early 40s, mid 40s, at the most late 40s. The grandparents also have. And of course, there are lots of people who don't have diabetes, but that could just be because they have never been tested for diabetes. Because we know that 50% of cases of type 2 diabetes in this part of the world remain undiagnosed. So with this background, we thought of the possibility of early onset type 2 diabetes, strong family history, and the presence of markers of insulin resistance. And so we did a C-peptide assay, which looks at the beta cell reserve of this patient, and found that she had a fairly good beta cell reserve, and the pancreatic autoantibody, that is a GAD antibody, was negative. So with this, we made a diagnosis of early onset type 2 diabetes. We gave her diet, physical activity. We withdrew the insulin, started her on sulfonylurea and metformin. The glucose levels came down very well. HbA1c came to 5.7. We were able to stop the glimepiride and just continue her on metformin. And now even after 4-5 years of follow-up, she continues to do well. So that's the first case. So the take-home message from this case is that not all young patients need to be type 1. Age alone is not the criteria for diagnosing type 1 diabetes. Complete evaluation should be done to arrive at a diagnosis. And a strong family history of diabetes, usually on both sides of the family, is a good pointer to the presence of type 2 diabetes. Look for signs of insulin resistance, obesity, acanthosis nigricans, skin tags, fatty liver, polycystic ovary in slightly older individuals. All these things will give you a clue that there is type 2 diabetes. And C-peptide assay and GAD antibody can help in distinguishing between these 2 types of diabetes. The second case, again, a 16-year-old girl. She's again thin, presented with severe diabetes. HbA1c was 10.4. Again, because of young age of onset, she was diagnosed to have type 1 diabetes. She also had to need lifelong insulin. 3 times a day insulin was given. She also came to us to see whether there was any chance that her insulin could be stopped. This is her family history. At first glance, it doesn't look too different from the family history of the previous patient. But if you look more carefully, you will find that diabetes is present mainly on the maternal side of the family. You can see the mother and several of the aunts and grandparents have diabetes. Diabetes is also present in the paternal side of the family. But if you look more carefully, you will find that all the individuals on the father's side of the family who have diabetes are not blood related to the patient. They are only relatives by marriage. So the transmission seems to be occurring from the mother's side of the family, and you have clear-cut 3-generation autosomal dominant inheritance. Again, C-peptide was fairly good, autoantibodies were negative, and because of 3-generation transmission and because the patient was lean with no features of insulin resistance, genetic testing was ordered, and this is what we found. We found a mutation in the HNF1 alpha gene, which is responsible for the condition known as MODY3. And you can see how beautifully it has come out. All the members on the mother's side of the family who have diabetes carry the gene. Those who don't have diabetes don't carry the gene. On the father's side of the family, irrespective of whether they have diabetes or not, they don't carry the gene. That means these individuals on the father's side of the family who have diabetes just have type 2 diabetes, normal type 2 diabetes. So the inheritance is totally from the mother's side of the family. And interestingly, this patient had a sister who did not even know that she had diabetes. Due to our screening, she found that she had diabetes and she found that she was carrying the mutation as well. And the importance of making this diagnosis is that these individuals are responsive to sulfonylurea. We started around glibenclamide. You can probably start glipizide or glyclazide as well. Excellent response. HbA1c came down to 6.8. Both sisters are still responding to sulfonylurea even after several years. So the importance of picking up this case is that we were able to avoid lifelong insulin therapy. This is life-changing for the patient. So this is another example from Dr. Hattersley's case series in which somebody was doing very well on sulfonylurea. This is a patient with monogenic diabetes being treated as type 2 diabetes, but we know for type 2 diabetes also people give sulfonylurea, isn't it? So one fine day, somebody decided that being type 2 diabetes, you should not give sulfonylurea, you should give metformin because that's a first line agent. So they stopped the metformin, sulfonylurea, started metformin, HbA1c shot up and it remained high for 3 years until somebody else had wiser idea and restarted the sulfonylurea. And the HbA1c came right back to where it was before the sulfonylurea was stopped. This is an ideal example of precision medicine or precision diabetes. But that does not mean that every case of monogenic diabetes or MODY will respond to sulfonylurea. There are certain types which do and certain types which don't. The two most common forms of monogenic diabetes that respond to sulfonylurea are MODY1 and MODY3, HNF4 alpha and HNF1 alpha mutations. MODY12 due to ABCC8 mutation and MODY13 due to KCNJ11 mutation may also respond to sulfonylurea. Many others, like for example, the HNF1 beta mutation, that is MODY5, do not respond to sulfonylurea because they are also associated with pancreatic agenesis. And there is another category known as MODY2 or glucokinase mutation, which does not need any treatment at all until and unless the patient is pregnant. So just making a diagnosis of monogenic diabetes doesn't mean that you can switch somebody over from insulin to sulfonylurea. You also need to know which is the gene involved and which is the mutation involved in that particular gene. The third and final case, this is a baby born of consanguineous virus, very interesting case. He was managed on insulin, but because of familial inheritance, somebody started this patient on sulfonylurea, thinking that it is monogenic diabetes or neonatal diabetes, and the patient developed hepatitis. And the pediatric gastroenterologist, because of his sulfonylurea that got hepatitis, stopped the sulfonylurea. Sulfonylurea was stopped, insulin was started. Patient's hepatitis resolved, but the sugars were not under control. Even with sulfonylurea, it was not under control. But again and again, the patient was going on getting hepatitis. And you can see the OTPT levels going up to 700, 800 like that. And acute renal injury every now and then, which resolves. Patient also has seizure disorder. But what actually opened our eyes was that they gave the history of two of the sisters having the same phenotype. One of them died at age 4 and the other 20 days after birth. Actually, somebody had published these cases earlier when the child died. But unfortunately, they did not have facility for genetic analysis and so they died without a diagnosis. So we find that the patient is stunted. He also has dysmorphic features, and this is the result of the skeletal survey. You can see dysplastic phalanges here. Proximal metaphyseal cupping is there. Platyspondyly, you can see the flattening of the vertebral bodies, and these are typical of a condition known as Walcott-Rallison syndrome. And that is a genetic report which we got in the EAF2AK3 gene, which is the causative mutation for Walcott-Rallison syndrome. And the parents were heterozygous. Because of the consanguinity of the marriage, the child became homozygous and manifested the disease. So these are all the features of Walcott-Rallison syndrome. So when a multi-system involvement is there, and the prognosis is poor even with treatment. Now you might ask, what's the point in making this sort of diagnosis? Because it won't help the patient. But at least you can tell the parents. In fact, the parents came to me and asked me, can we have another child? Because 2 children already died. Third is like this. can we have another child which might be normal? I said your strike rate is 100%. So it's very unlikely that your next child also is going to be normal. You might as well adopt a child, not going for some other methods of reproduction. So for counseling as well as for anticipating the complications that may arise. What about the other forms of diabetes? Now, type 1 diabetes does have a genetic basis. All of us know about the HLA involvement and all those things. But it's very rare to have somebody with multiple members of the family involved with type 1 diabetes. We all have 1 or 2 families in our clinical series. We all know some families where there are multiple members involved, but generally there is no family history involved in type 1 diabetes. Similarly, FCPD. Although we talked about the SPINK gene and the PRSS gene and so on and so forth, it is very unusual to have FCPD in more than 1 member of the same family. It is usually sporadic. In both these conditions, it's probably because even though there is a genetic basis, the environmental influence is essential for that genetic basis to translate to disease. Certain other forms of monogenic diabetes, for example, you have neonatal diabetes, that is diabetes presenting before the age of 1 year. Even though it is monogenic, usually the parents will not have a history of diabetes. That is because the mutation is sporadic. It happens in the germ cell. But now with increased survival of these children, more and more of them are getting pregnant and they are transmitting their gene to their children. So now probably in future, you might find neonatal diabetes as one form of familial diabetes, in addition to MODY and type 2 diabetes. So I will conclude by showing you this algorithm, which emphasizes the importance of family history. And remember, taking a family history doesn't cost anything. It is free. All you need is a piece of paper, a pencil, and some time. So first and foremost, when you have a young person with diabetes below the age of 25 years or even below the age of 35 years, look at the family history. The family history is positive, especially if there are multiple members of the family who have had young onset diabetes. Think very carefully before giving a diagnosis of type 1 diabetes. It is more likely to be a type 2 diabetes or a monogenic diabetes or a MODY. And how to differentiate between these two? Actually, you need to do genetic testing. You can only get clinical suspicion, but confirmation has to be done by genetic testing. But you might say genetic testing is difficult, it's not available. It's available. It's available in our centers, available in other centers in India as well as in abroad. But even if you do not have facility for genetic testing, do not worry. Because even if you diagnose monogenic diabetes as early onset type 2, still the patient may end up getting the right treatment. Because first you will give metformin. If it doesn't work, what do we give in India? We give sulfonylurea. So the patient ends up getting the right treatment by default. What you should not do is mistake or confuse between type 1 diabetes and monogenic diabetes, because there the treatment is absolutely different. If the family history is negative, then you can think of other conditions like type 1 diabetes or FCPD or endocrine types of diabetes and so on and so forth. So I hope that in the last 10-15 minutes, I've been able to enlighten you about the importance of family history. I thank you for your attention, and I hand the mic back to the chairperson for the question and answer session. Thank you.
Dr. Mehta, will you conclude?
Question answers. Any group discussion is coming on?
Meanwhile, there is no question, or we are waiting for any question. Can I ask one question to Dr. Jayakumar, please?
Yes, I'm here.
Yeah. Sir, you have told about the drugs and toxins who are producing secondary diabetes. But one of the most important drugs nowadays we are using almost 70-80% of cases, that is statin, which is producing diabetes in our patients. But in your lecture,
What is it?
statin,
What is it, right?
Statin.
Statin.
Yeah, you have not mentioned statin. And
yes.
another thing that those drugs used for HIV.
Yes,
HIV.
so many. Yeah.
these
But
two
I think,
important group of
so
drugs
it's,
probably somehow we are missing in your lecture.
okay. The thing is that I was mainly concentrating on the endocrinopathies and all those things. Second is 20 minutes. The time overshooting is very important. About statins, that is a good point. I'll raise it. This is a very important topic because many of us, including doctors, are taking statins and all.
Yeah.
See, it is well known that statin therapy produces diabetes in a small percentage of people. The percentage will be around 7 to 8% of people taking statins can develop glucose intolerance. And those who are diabetic, about 10 to 15% will have worsening or the requiring higher dose of tablets to control blood sugar. So difficult to control in people already who are having diabetes because of statin effect, and newly appearing diabetes in around up to 5 to 8% of patients who are on statin. So will you give statins to a guy who is not diabetic just because his cholesterol is high? You are going to produce him diabetic. The question is that the other side of the coin is that if you don't give statins to a guy who has got hyperlipidemia in the with what is called the score, the chance of scores are very high.
ASCVD scoring.
And also all these
Atherosclerotic
scores are
cardiovascular
high.
disease scoring.
And if you don't give statins, that 100 people, 10 to 14 persons can get a heart attack. Ischemic heart disease. But if you give statins, only 5 to 8% can develop diabetes. So the balance is that this 5 to 8% diabetes we can treat and control and all those things. But 10 to 14, suppose he gets a sudden attack, attack and a sudden death, we will be losing the patient. So weighing these two options, we agree that it can produce diabetes, but the chances you are going to produce a disease which is treatable, which is manageable, and you are on the outlook for reducing a patient or preventing a cardiac death in 10 to 14% of the people who, if you don't take statins. So that way you can see. I am also taking statins. I am a doctor. But luckily, diabetes we can treat. Suppose there are some reports saying that it can produce dementia, all these things, mental, that will be more problem because the treatment of those things is very difficult. Where treatment of diabetes is much more easier and simpler. And we are anyway going, many of us in our lifestyle disease, we are going to get it at some point of time also. There is a family history.
Sir, if you can elaborate slightly on the pathological or the biochemical mechanism by which this statin produce diabetes.
That is, it is the action on the liver. Statins mainly act on the liver to produce, get the hyperlipidome, that is to stop the enzymatic synthesis of cholesterol. It acts mainly in the liver. And liver is the main source of all the metabolism, especially the carbohydrate, protein, and fat metabolism is the hub of all this metabolic activity. So it is on that effect of altering the pathogenesis of the carbohydrate, fat, and protein metabolism within the liver. That is how it produces. And it is, the other thing is there must be a family. It is more on people with a family history of diabetes, so that there is already some inborn. As you know, you will agree with me that there are so many chromosomes are for type 2 diabetes. This is the one, that is the one, nobody knows where it is. But like that, because of hundreds of chromosomal abnormalities and some enzymatic problems can predispose diabetes. So if you are having a family history, some of these problems will be still there. On that guy, the liver, the statin going and acting, producing the metabolic abnormality is the one. That is what I understand it. There is no specific site saying that statin goes and act on that site and produce diabetes. See, if you can glucokinase, if you say MODI 1, 2 and all, it goes and act on the glucokinase gene, and sensing is not taking place. Whereas this one is not like that.
Thank you, sir.
Thank you. No question to Ranjit?
Sir, you can ask if you want.
No. See, the case I presented is a case which was diagnosed in Dubai and going on with type 1 diabetes. Luckily, when he was admitted here, we happened to see his face because it's all covered face. Then only it does not look like a classical type 1 because he is getting multiple ketoacidosis. Then only when the mask came down and he happened to see his face, he was acro, looks like an acro. Then the history taken, we found tumor getting out. So like that, it is all the clinic, and the guy is so lucky because if we have missed here also, it would have been going for another 5 to 10 years before you would have made a diagnosis. Like that, Modi, your main study is on Modi, is not so? You are in Madras, you are concentrating on
All
Modi.
types of monogenic, sir, including neonatal.
Yeah.
Ranjit sir, I have a question for you.
Yes, sir.
Sir, how often do you find this familial pancreatitis due to SPINK1 mutation?
We haven't actually found any because we actually don't get too much of FCPD nowadays. In fact, we would consider it a good year if we had 3 or 4 new cases coming in. Of course, all the old ones are still coming in.
Absolutely.
But the numbers have dropped drastically, maybe because of improved nutrition, we do not know. I don't know what's the situation in Odisha. It's still commonly seen there, or?
No, sir. No, we don't see.
I think that this is the one thing. All these theories comes and goes. This FCPD, pancreatic diabetes. See, when I was an MD student in 1971, 1970s, we are having all these things, and now even after 50 years. Yes.
ये है साईं कल्याण हॉस्पिटल नियर गायत्री नगर नियर जगन्नाथ मंदिर.
ठीक है सर, मैं कल सुबह आता हूँ.
कितने बजे?
टाइम कोई 11 बजे.
अच्छा, ठीक.
Okay. I think FCPD is one entity where theories it will be difficult to put theories now because, as Ranjit has said, the number of cases is coming down. So very difficult to do studies and all those things. And I think, and good old days, because I happen to work with the Professor Givergis in early 1970s and all those things. So we used to have a good collection at that time, and Dr. Givergis used to do biopsies and all those things. Even post-mortem, we used to take the tissue out and do all these things. And nothing has come out finally. It is still anybody's guess.
Ranjit sir, what is the cost for this neonatal diabetes panel?
Actually, we are doing it neonatal. We are doing it free of cost because we do have some funding from the central government. In fact, you might be interested that just today we inaugurated a Center for Monogenic Diabetes.
Yes.
Our minister, health minister, inaugurated today at 11 o'clock, and we do neonatal diabetes screening free. The other Modi gene, we see whether the patient is affordable because it is costly. The entire panel costs around 13,000 rupees. So it's around 2,000, 1,500 per gene, and we are doing the entire panel, 16, 17 genes. So that, depending on the affordability of the patient, we charge or we do it free. But neonatal is absolutely free because we feel that these people should not go around undiagnosed.
There is a question from me that is there any intervention sort of thing by which FCPD can be treated, like ERCP and then removing the calculus from the pancreatic duct?
Yes, sir. Actually, if there is a component of pain associated with this FCPD, there are procedures by which you can actually do it. And especially if there is intractable pain, surgery is recommended. And I have gone through few of the literatures. They say longitudinal pancreatojejunostomy is a preferred procedures. And some studies have also shown that probably extracorporeal shock wave also can be used. But then it is not that much useful. Most of the times, in case of intractable pain, surgery is recommended. And early on, as you rightly stated, ERCP can also be of help.
I think in good old days in our place, Dr. Matthew Varghese, surgeon, was doing a lot of things. See, even finally we went for only sphincterotomy because removing originally, initially they used to do laparotomy and remove all the organs, all the stones and all those, which is not possible. So now then they decided to go for sphincterotomy so that the bigger bones and remove few bones and the rest will go through automatically. But in the end of the day, some people got some pain relief, but there is recurrence and there is no complete cure. So different, this pancreatitis, this all this being tried. But now, as you know, the number of patients are so few. So there is not, and pain is not a big problem. Nowadays, the pain clinics are there. They will do block the nerves and make them blocks are nowadays more done for this pain problem. Good old days, the surgery was done and all those things. Nowadays, I think the pain clinics and doing all these blockings, the number of surgical procedures have come down. I think we can. Is there no further questions? Can we wind up?
Yeah. If sir, Dr. Mehta sir, are you here? Sir, if there are no more questions from audience, then I thank all the speakers. They have done the excellent job regarding this secondary diabetes or the special type of diabetes. We have become more wiser after hearing the lectures of these eminent speakers. I thank you, all of you, and thanks a lot, sir. So with this, I close this session.
Thank you, sir. Thank you, sir. Thank you, my
Thank you.
co-speakers. Thank you.
Thank you, sir.
Thank you.
Institution. Just.
Hello. Hello. All right.
Hello, Dr. Chitra.
Hi, I'm here,
Yes,
Dr.
hi, how are
Rahul.
you? Yes, Dr. Rutul, yes. So we have 5-10 minutes more to start
Yeah.
your lecture. So we'll be starting after 10 minutes. Okay.
Perfect. All right. I'm going to get myself a drink of water and I'll be back soon, but I'm logged in, okay? Yeah. All
Yes.
right. Yeah.
Okay.
Thanks.
Good. Thank you. Yes. So should we start? Dr. Chitra, you there?
Yes, I'm here.
Yeah. So, hello everyone. Good afternoon. I'm Dr. Rutul Goklani, and I'll be chairing the next session. This is on diabetes and women. So our first speaker for the topic is Dr. Chitra Silvan. She is Associate Professor Endocrinology at MS Ramaiah Medical College, Bangalore. She has done her MBBS 2004 in 2004 from Bangalore Medical College. She has done her MD Medicine in 2009 from Madras Medical College, DM Endocrinology in 2014 from IP Jipmer, Kolkata, AV Gandhi Award for Excellence in Endocrinology in 2015, and she was awarded with RSSDI Young Investigator Award in 2017, and she has more than 30 publications in national and international journals in her name. So over to you, Dr. Chitra, for your talk of do we need a gender-specific approach in management of diabetes?
Thank you so much, Dr. Rutul, for that kind introduction. And it's my absolute honor and pleasure to be here at the RSSDI 2021 conference, sharing the stage with an absolute galaxy of women with amazing achievements. And I know I'm speaking for many, many women who are passionate about improving health access to women with diabetes. So the topic that I've been assigned is to talk about whether we need gender-specific approach in the management of diabetes. And I'll go right into the heart of it as to why it's important to spend an entire 3 hours discussing management of diabetes in women. How different could it actually be from men? Although the prevalence of diabetes is greater in men, over the years in Southeast Asia and globally, the mortality rates are higher in women with diabetes. This is a slide from the 2015 IDF Atlas, and you can see how we are losing more women to diabetes than men with diabetes. And if you're wondering if it's any different in the 2019 IDF Atlas, you do see that while the mortality rates might be equal up to 60 years of age, beyond 60 years, it exponentially rises amongst women with diabetes as compared to men with diabetes. So if there is one reason why we should be speaking about this, it is absolutely this. So what is gender and what is sex? Why can't we just talk about biological differences, and why should we talk about gender sensitive approach? Sex or biological sex is a physiological or biological difference between the two sexes, attributable to chromosomes, to genes, to hormones, and their expressions and their effects on disorders. Whereas gender is a construct which goes beyond biological differences to include the societal norms which have been imposed on one sex of the species, which has repercussions on the economic access, the behavioral changes, or also the environmental factors which might be unique to the gender normative behavior attributable to that gender. And we will talk about how this could alter disease. And why should we talk about gender and not just biological differences? Because this alters both the behavior of the patients and doctors. It alters the disease perception by the person who's affected by the disorder. It also can affect help-seeking behavior, use of healthcare or access to healthcare, which is the theme for this year by the IDF. Also, could it potentially interfere with the decision-making of healthcare workers and also therapeutic response? So this is exactly why we should be paying more attention to a gender norm in the context of the illness of diabetes, which is all pervasive. This is the outline of the talk that I'm going to go about today. So this is a very comprehensive review which was published a few years ago to talk about the gender differences in metabolic disorders. While at younger age group, there are more men who are obese. As we age closer to 40 years of age, the proportion of women who have BMIs greater than 25 or 30, again, rise exponentially. Why are we talking about obesity when this talk is about diabetes? Because the relationship between BMI and type 2 diabetes is completely different between men and women. If you take a look at the green dots on the bar, the rise in the incidence of type 2 diabetes occurs at a much lower BMI and also climbs up exponentially in women as compared to men. Of course, this is data which is out of India. How is this relevant to our lives in India? Very recently, the National Family Health Survey 5 was done, and the results of this was released recently. There hasn't been a national-wide assimilation of all the findings, but this is data from Karnataka, the state that I'm from. And if you take a look at the proportion of women and men who have BMI greater than 25 kg per meter square, it's at a whopping 30%, but it seems to be equal between men and women. But this survey is unique and different from the previous surveys because we also managed to measure waist to hip ratio in this survey. And what we found here was that up to 45% of women had a BMI which was greater than 0.85, which essentially means that every 1 in 2 women in Karnataka has visceral obesity. So if you're going to try and flatten the curve of projection of increasing prevalence of diabetes worldwide, and if there is one vulnerable population that you should be looking at, it should be women who present with obesity. Do they present with obesity and insulin resistance to us? Yes, they do in many, many forms. Anybody who's having a clinic do know that there are many women who walk in with this very common condition called polycystic ovary syndrome, which we tend to deem it as a reproductive disorder, but the seeds of insulin resistance are already at play over here. And if anybody is taking a gender sensitive approach to prevention of diabetes, this is probably the cohort that we should be targeting right from the start. Because not only is it a reproductive disorder, it is actually a metabolic disorder with reproductive manifestations in this stage, which could potentially translate into greater metabolic risk, which we can all alter by implementing changes. Of course, this we seem to completely miss through our fingers. And here is a slide to show you that as the amount of androgen level rises in women who present with PCOS, the number of components of metabolic syndrome keep progressively increasing, highlighting the fact that this is there are already features of metabolic syndrome here. But let me move on to, whenever we talk about women, we only want to think about pregnancy. What proportion of pregnant women do you think have hyperglycemia? Let us say in Southeast Asia. Up to 27% of women in pregnancy have hyperglycemia. That's every 1 in 4 pregnancies in our area is complicated with hyperglycemia. And we have amazing speakers coming in to talk to us about how hyperglycemia in pregnancy has long-lasting effects, altering the metabolic milieu in which the fetus grows, thereby increasing their risk of adult metabolic disorders. And if this is not motivation for us to take care of our women with diabetes, I provide more reasons for you as we move about. Is it only pregnancy, or is there anything else in the life cycle of a woman which could alter the risk of metabolic disorders? This is a paper which was done amongst Chinese women to document that greater the number of pregnancy that a woman went through, greater the chances of type 2 diabetes. Pregnancy is a stressor on your beta cells. So with every increasing pregnancy, your chances of type 2 diabetes increase. So do we ask for the number of children when we check at follow-up of women who present with GDM to quantify their risk for type 2 diabetes? Not really. This is another study which tried to look at the age at which the menopause was attained and the risk for type 2 diabetes. So for every drop in standard deviation of the age of menopause, the risk of type 2 diabetes increased. So there seems to be a tight interplay between reproductive transitions and metabolic disorders. This is again another slide to show you that the progression of NAFLD or fatty liver disease, which is now deemed to be the 6th component of metabolic syndrome, progresses faster around the time of menopause by itself. So, and it is now a very well established risk factor for NAFLD. So around around menopause, are we looking out for progression of fatty liver disease? When we have a blanket screening protocol for everybody, we are likely to miss out these nuances of treatment. And why is it important to do this? Because even at the same BMI, women tend to have a greater waist-hip ratio as seen physically by the National Family Health Survey. But here we have documentation to suggest that they have greater visceral adiposity as compared to men at the same BMI. So what about differences in consequences of diabetes in women? We have two fantastic professors talking to us, going into the nuances of the microvascular and macrovascular differences between complications. Women do have a greater prevalence of diabetic neuropathy and nephropathy, but probably I want to pause here in the difference in macrovascular complication, because this is the major cause of mortality amongst women with diabetes. While diabetes increases the risk of cardiovascular disease in men by twofolds, in women with diabetes, the risk of cardiovascular disease is increased 4 to 5 folds. Of course, one might want to say that this was a study which was done in the 90s, where comprehensive diabetes care was not the regular routine care. Now it might not be so. So let me show you recent evidence. This is a large meta-analysis conducted by Peter San and group. They did two separate meta-analyses, one to look at diabetes as a risk factor for coronary artery disease and one for stroke. And what they found was this, that the relative risk of incident CHD was 44% greater in women with diabetes as compared to men with diabetes. And a similar study done to evaluate the risk for stroke also showed that women who have diabetes have a greater risk for stroke as compared to men. While traditionally, whether we like it or not, we're likely to hold on to a bias which says that stroke and coronary artery disease are less likely in women, but diabetes seems to still be a risk factor which demolishes all the protection offered by the estrogen status. So when you're trying to look at where is this gap happening, when did this change? The presence of diabetes seems to increase a clustering of various parameters which could overall increase your risk for cardiovascular disease. So this was a study done amongst Japanese women. They looked at both women and men with diabetes and without diabetes, and they looked at the common cardiovascular risk profiles. And they found that amongst women with diabetes, there was a greater visceral obesity, greater blood pressure levels, greater LDL cholesterol levels. And what this is called as risk factor clustering. So if you want to select one vulnerable cohort of people with whom you want to do minimal intervention and get maximum results, that would be a woman with diabetes. So are there any other risk factors for coronary artery disease or cardiovascular disease which we are missing, which are specific to women? This is a study which showed that presence of PCOD increases the risk of cardiovascular disease. We have Professor Sarita Bajaj and Professor Mala Dharmalingam talking about this, about the effect of GDM and non-communicable disease, but also pay attention to the fact that if you have preeclampsia or pregnancy-induced hypertension, it could increase your risk of cardiovascular disease in your perimenopausal or postmenopausal windows. Do we ask these questions to the women whom we treat with diabetes? I don't think so. This is again another study published very recently, 2020 May, which looked at parameters which: did you have a preterm birth? Did you deliver a baby who was small for gestational age? Do you have vasomotor symptoms now that you're perimenopausal or postmenopausal? And then they correlated these 4 factors with your ASCVD risk score. And guess what they found? People who are likely to have vasomotor symptoms now, perimenopausally, or who have a past history of delivering a preterm child or a small for gestational child, had a much higher score for risk for CVD than the others who didn't. So there's very little that we've understood about the reproductive transitions, especially menopause and its effects on cardiovascular disease. But key factors which are specific to women, which we probably need to pay attention to more, is presence of PCOS, the transition of menopause, presence of GDM, PIH, and preeclampsia during pregnancy. Maybe we could add to that having preterm delivery or small for gestational age, which probably could serve as surrogates of vascular insufficiency or maybe preeclampsia, which wasn't picked up or treated well. Psychosocial well-being and diabetes is something that we always associate with women. But before we go on to a pause, it's very important to acknowledge that there is no such thing as a downtime for a woman's mind. There is 3 to 4 additional hours of household and childcare chores per day. If you do 3 to 4 extra hours of work, I don't think you can have any downtime. And so I'm not surprised that the prevalence of depression or anxiety is higher in women. But the point as to why, as doctors who are taking care of diabetes, need to acknowledge this is this. This is data from the Nurses' Health Study, which looked at a large group, 80,000 and odd women, and looked at self-reported depression and looked at their mortality rates and all-cause mortality over 6 years of follow-up. And this is what they found. When they broke them down into 4 groups, the groups which had both depression and diabetes had the highest all-cause mortality as compared to groups who had diabetes with no depression or depression with no diabetes, right? So that's exactly why it becomes absolutely our business to ask, how are you doing? How is your mood? How are you feeling? Those are questions that we definitely need to roll into the consult. Of course, the connection between depression and diabetes, many involving both hormonal and sympathetic system involvement, but it's the thing that is there. I do not even have the time to talk about the prevalence of sexual dysfunction, but there is strong correlation now between sexual dysfunction and emotional well-being and depression. And take a look at the column. The prevalence is anywhere ranging between 20% to 77% amongst women with type 2 diabetes. Do we have a screening program? It is recommended, but do we screen? Not really. This is a paper to show that just the diagnosis of diabetes in individuals with breast cancer just worsens prognosis and outcomes. So do we regularly push our women to screen for breast cancer? Do we have a protocol? Not really. Is there a treatment bias? I'm turning the mirror towards us doctors, by healthcare professionals towards women. This was the study which was called rightly the inertia study, which looked at whether a woman or a man was receiving statin or escalating therapy after an ischemic heart disease. And it was found that there was some inertia while starting statins or escalating therapy in women as compared to men by doctors. And these are people who already have ischemic heart disease, right? So this is something that we need to think about. So much so that now something called as the Yentl syndrome has become part of folklore in cardiology. Yentl is a movie in which Barbara Streisand pretended to be a Jewish boy so that she could learn the scriptures from her father, right? So she acted or cross-dressed like a boy throughout the movie. And now it is clearly understood that when women present with angina, you're less likely to receive a complete evaluation, you're less likely to receive a recommendation for an angiogram, and you're also less likely to receive complete and intense treatment for the cardiovascular disease as compared to men, which in turn translates into worse outcomes for women. And now this is a recognized entity now, and this is there's no escaping now, right? So we definitely need to go back and reflect on our own practices. So moving forward, Lancet 2020 had an entire issue on gender norms and its repercussions on health, and it called out for standardizing recruitment of people for clinical trials, because there's always been underrepresentation of women, and nobody's quite really looked at women-related factors or women-related adverse events or women-related responses to medications. And of course, changes in practice guidelines, and probably holding more seminars and summits like the one we're doing to bring focus to the differences between the two gender. So quickly to summarize, we will always need to talk about a gender-sensitive approach as long as there is inequality in gender roles in the society. Obesity seems to be rising disproportionately in women than men, even in India, especially visceral obesity. And we need to address this because BMI seems to correlate strongly with women for the risk of diabetes as compared to men. Up to 1 in 4 pregnancies in Southeast Asia is complicated from hyperglycemia. Multiparity, menopause are all risk factors for future risk of diabetes. Menopause is a window of transition which could increase the risk of cardiovascular disease and FLD. We are losing more women with diabetes than men with diabetes. And one of the important causes is the fact that they are at greater risk for stroke and coronary artery disease. Screening for depression is something which needs to be added. We need to acknowledge that there seems to be some therapeutic inertia coming from our ends and design future clinical trials which will represent women. This is a photograph from Sunita Williams on a spacecraft. Notice that her legs are flying in the air, but there's a blue bar for you to fix your foot. If she fixes her foot there for stability, she loses sight of the window through which you watch out for any debris which is flying in space. The man, on the other hand, has his foot fixed on the blue bar and is still able to look out of the window. As long as we are making spacecrafts designed only for men's health, we will need to continue to fight for a gender-specific approach for the management of women with diabetes. Thank you so much for the honor, and I hand over to the chairpersons. Thank you so much.
Thank you very much, Dr. Chitra. That was a wonderful talk. And we'll take the questions after the session, right?
Sure.
Yeah. So we have next talk of Dr. Mala Dharmalingam. Can I have the CV? Okay. Dr. Benny Neglu will be talking now.
Wrong CV.
Okay. Mala ma'am is there, I guess.
Yes.
She's here.
Yeah. Okay, great. So welcome, ma'am. So Dr. Mala Dharmalingam will be talking on gestational diabetes mellitus, window of opportunity for prevention of cardiovascular diseases. She is professor and HOD at MS Ramaiah Medical College and Hospital. She is director at Bangalore Endocrinology and Diabetes Research Center, Bangalore. She has been awarded with 11 awards, including Dr. BC Roy Award, Epicon Vocational Excellence Award, MGR University, and Academic Excellence Award. She has delivered 13 orations, including MS Ahuja, PN Shah, in ESI, Sam GP Moses oration, JS Bajaj oration in NAMS, and a presidential oration at Karnataka RSSDI. She has published more than 134 articles in national and international indexed journals, and she's member of CDSCO DCGI Ethical Committee ICMR. She's in expert group and telemedicine subcommittee ICMR. So over to you, ma'am, for that wonderful topic of gestational diabetes.
Thank you very much, and a very good afternoon to you. Just give me a moment to share my slide. I think, Chitra, you have to not stop sharing so that I can share.
She has already stopped sharing.
Yeah.
Okay, ma'am. Your slides are visible.
So after the talk on the gender differences, I'm going to take a step back to gestational diabetes and an opportunity of prevention, mind you, not type 2 diabetes, but CVD. So with that, the agenda of my talk will be just to give it a platform. What are the different forms of gestational diabetes? What are the risks in gestational diabetes? What are the common risk factors and pathogenesis in GDM and CVD? And then looking at what happens to CVD in mothers who had gestational diabetes and what happens to children of mothers with gestational diabetes as far as the cardiovascular risk is concerned. So we do know that there are different forms of gestational diabetes. It could be autoimmune, that is type 1. It could be type 2, which is a background of insulin resistance. It can also occur in genetic mutations or pancreatic or endocrine function problems like pancreatitis. However, 80% of gestational diabetes occurs in a background of type 2, where we have beta cell dysfunction and chronic insulin resistance. This also has reduction in glucose utilization and increased production, not only of glucose, of also free fatty acids. And we do know free fatty acids are a risk for CVD. The beta cells deteriorate due to this excessive insulin production or because of the resistance. And because of this and the energy consumption, the beta cells exhaust over time, and then frankly, diabetes may happen. So this is the risk of gestational diabetes. People with gestational diabetes have a 3-fold increased risk of type 2 diabetes. The yearly conversion to type 2 diabetes is about 2 to 3%. And they also have a risk of metabolic syndrome, which is not just diabetes, but all the other factors like blood pressure, lipids, as well as cardiovascular disease. Now, once a lady has gestational diabetes, the vasculature of these women is permanently altered, predisposing them to cardiovascular disease. And this is why we say that they have an increased risk of CVD, but we look at some data. Now, this was a follow-up study of gestational diabetes. This was a very elegant study done way in Denmark. One study was done way back in 1978 and followed until 1985, where around about 241 women who were treated with diet alone were followed up and seen what happens. What happened over the 6 years period? 18% became diabetic and 17% had pre-diabetes. So that was the first 6 years. They followed up for another 13 years, which was a median of 19 years. And what they found is 37% of these 151 which were left had diabetes and 29% had pre-diabetes. Only 1/3 was normal. So the same group did another study, same in Denmark, between 87 and 96. And what did they find for a median of 7 years? And but there, 41% already had diabetes and 26% had pre-diabetes. That means there was a threefold increase between the earlier study and a later study. And the only difference between the two groups was weight. Like Chitra was saying, that obesity is a huge confounder that we need to address so that we can prevent this progression. Now, what are the common risk factors of gestational diabetes and CVD? We all know overweight, obesity, gestational weight gain, what they gain during the period of gestation, westernized diet, ethnicity, certain genetic polymorphisms, advanced maternal age, the intrauterine environment, the family history, and associated disorders like the polycystic ovarian syndrome, which we are increasingly seeing in our endocrine practice. Now, what is the major problem of gestational diabetes and insulin resistance? As you can see in the right side upper hand corner, the insulin, this is normal, that is the first stage where they don't have, that's before pregnancy. During pregnancy, the insulin resistance increases, the IRS1 receptor becomes, there is a lot of insulin resistance over there, that's peripheral insulin resistance. And after delivery, the hyperglycemia may come down, but the insulin resistance and the certain damage remains. Now, apart from that, and we all know all the other factors which causes increase in blood glucose as well as insulin resistance, but added to that, we also have the placenta causing insulin resistance by increasing placental leptin, pro-inflammatory cytokines, and the placental transport of free fatty acids, and the fetal growth itself may cause insulin resistance and hyperglycemia. So there is an abnormal metabolic risk profile in gestational diabetes. This could be due to epigenetic factors of maternal hyperglycemia at the skeletal muscle and the subcutaneous adipose tissue, and these have been confirmed or got from epigenetic analysis. Now, what happens? Let's say the patient was having diabetes or had diabetes but didn't know about it. And here, the parameters that are important are, of course, ethnicity, physical inactivity, obesity, dietary composition, and polycystic ovarian syndrome. And what they do, they cause the insulin resistance, while which all the inflammatory factors like the tumor necrosis, alpha increases, the placental lactogen, growth hormone, estrogen, progesterone, cortisol, all of this increases, causing increased glucose levels. And there in the mother, they have persistent hyperglycemia, we do know, but they also increase triglyceride and increased amino acid turnover, which leads to the substrate for the fetal growth and the enhanced fetal growth and the hydrolysis to free fatty acids in the placenta. So we look at what all this does in the child and in the mother. So there have been certain pathogenesis for CVD and gestational diabetes. One of it is diet. So overweight and obesity overwhelm the beta cell insulin production and the signaling pathways. And they have seen that diets rich in saturated fats, especially in gestational diabetes, cause more of the insulin, interfere more with the insulin signaling. And increased fiber is important, and it improves the insulin sensitivity. Processed meat can be responsible also. It increases nitrates, which increases beta cell toxicity and amino acid production, which is a substrate for HGP and hepatic lipotoxicity. It also induces inflammation and endothelial dysfunction. Both are the pathogenic factors in both GDM and CVD. And of course, if N3 polyunsaturated fatty acids have anti-inflammatory properties. Now, birth weight. The birth weight of the mother also has importance, because they have found that if the birth weight is less, that is also a problem. If it is more, that is also a problem. So if the birth weight is low, the fetus will compensate for this undernutrition by altering the expression of genes in fat storage and utilization and appetite regulation. And this is associated with decreased number of beta cell in the pancreas. These alterations persist after birth, and this is called developmental programming. And this contributes to obesity, metabolic disease, and CVD, or what we generally call endomorphic fat obesity. This overnutrition in the womb, if there's more nutrition, can also result, like I said, the fetal overgrowth. The hyperglycemia causes beta cell fatigue even before birth, and after birth, it predisposes them to hyperglycemia, especially in stages of metabolic stress, even the next pregnancy, if that is a girl. So that is why it's a vicious cycle. So the first of its study was done way back in 2005, which was published in JCEM, looking at what are the common factors between CVD and the GDM. And what they found was all the inflammatory markers were increased, like you see, whether you see CRP, PAI, interleukin-6, or adiponectin was, of course, the adiponectin is protective. If you see that in gestational diabetes, it was quite high as that in people with subclinical vascular dysfunction. So this said that in people with GDM, they have subclinical inflammation by inflammatory markers. Now, this was another early study, that is in 2016, where the interest started about cardiovascular events in women. And again, a large number of people were studied. And in this, about 62,000 women had gestational diabetes. And what did they find? After adjusting for age, diabetes, obesity, and hypertension, they found that they had a higher risk of CVD with an odds ratio of about 1.25, angina pectoris odds ratio 1.68. That means they are double the risk of angina and a myocardial infarction, and hypertension was almost 3 times. But this study did not show any association with increased risk of stroke. Another study was done. This is the same study, which looks at the significance, and you can see here, and this is a very small slide. I mean, it's a very busy slide, and I will just tell you, but what was significant in all of them was hypertension, angina, and myocardial infarction, both acute and repeated myocardial infarction through time when they studied over a period of 7 years. Apart from that, the cardiovascular risk profiles itself, if you look at the cardiac output, the stroke volume definitely was significantly reduced in patients with GDM compared to the normal people. So it was just not the ischemic heart disease, but even outflow or the cardiac function was also affected in this manner. So now they concluded for the first time that GDM is an independent risk factor for CVD in the 7 years following delivery, and suggested that effective management should be done. So that was the first study. This was another study somewhere around around 2006, which came out, which said those women who had GDM, but also had a family history of type 2 diabetes, were more highly prone for cardiovascular disease. So here again, blood pressure was significant. And if you see the fasting plasma glucose and the metabolic syndrome was significant. And again, coronary artery disease showed a trend, and CVD was significant, but stroke did not show much of a difference. So both the studies go on to say that gestational diabetes is a risk. So again, this is a study which showed that in patients without GDM and with GDM, even if you adjust for age, you can see whether it's total CVD, myocardial infarction was trending, coronary revascularization or heart failure or even cerebrovascular stroke was significantly more in persons with GDM compared to people who did not have gestational diabetes. This was another study among elderly Chinese, which is called the reaction study, which again showed that, of course, gestational hyperglycemia, you will get diabetes, but the odds ratio of increased risk of CVD was about 2.88. This is a very recent study, which was published in August 2021. And even hypertension risk was as high as 3.98. That is almost 4 times more than non-diabetic pregnancies. So this was another study which actually when Dr. Chitra showed, but she showed an older study which looked at, I don't think it looked at gestational diabetes, which looked at diabetes itself in women, but this was one which looked at the gestational diabetes and what happened when they followed up and looking at the coronary artery calcium during midlife. And what they found was the coronary artery score was present in 25% of women with gestational diabetes compared to only 15% with no gestational diabetes. And the hazards ratio was about 1.54 for those who had no gestational diabetes but became pre-diabetic later, and 2.17 if they had GDM and went on to have incident diabetes later. So yes, we are worried about it and we are looking at prevention. So there have been studies which have looked at preventing cardiovascular disease in gestational diabetic women in the later stages, but unfortunately we don't have too good data. We have Upbeat study which showed that did not have any use. Then there was the DALI study which looked at vitamin D and lifestyle. There was a 33% reduction in CVD in GDM, but it was not significant. This was a radial study by the Finnish group, which did show that there was an improvement by 39%, reduced incidence of diabetes as well as CVD, but it should be replicated because there's a lot of critical analysis on this saying the population was not well represented. So we need more data. Now let's look at what happens to the fetus. Now, in the long term, babies that are born of gestational mothers are increased of risk of obesity. We know that type 2 diabetes and also CVD. So it's not just an opportunity to prevent CVD in the mother, it's also an opportunity to prevent CVD in the infant of the mother who has gestation diabetes. So the children born to mothers have double the risk of childhood obesity compared to their non-diabetic counterparts who were delivered from non-diabetic mothers even after adjusting for confounders. Females are therefore more likely to have a GDM as a vicious cycle from the child again becoming having gestational diabetes in her pregnancy. So this was another study which was published in BMJ in 2019, looking at offspring. This was a very good study which looked at 40 years of follow-up. They looked at about 1,100 offsprings of mother with diabetes and also about 91,000 offsprings of mothers who did not have diabetes and seen what happens to the cardiovascular risk. And what they found was there was a 29% overall increased risk of people, of children, of offsprings of mothers with diabetes to get CVD compared to the other counterpart. And if there was pre-diabetes, there was a risk was 34% and gestational diabetes was 19% for CVD, not particularly heart failure, hypertensive disease, deep vein thrombosis, and pulmonary embolism. This increased rate was pronounced if the mother had diabetic complications, it was even more. And if they had comorbid CVD itself, it was about 73 times more than that of the person, 73% more than that of the other control group who did not have diabetes. So this was something which was very, very shocking. And this is the same study. And you can see as time goes over 40 years, how the risk for the exposed has exponentially gone up compared to the unexposed. So what are the clinical perspectives of all this? So the clinical perspective is women with no history of gestational diabetes, progression to impaired glucose tolerance or over diabetes within 15 years was associated with a graded increase in relative risk, just like everybody else, of coronary artery calcification. But women with history of gestational diabetes the relative risk of coronary artery calcification midline was twofold higher for those with normoglycemia, impaired glucose tolerance, or overt diabetes within 15 years. Here you see, even if they remained normoglycemic later, or they had impaired glucose or became diabetic, the risk was almost the same, twofold increase just with the history of gestational diabetes, irrespective of what happened in the later stages. The clinical implication of this is, even if we keep normoglycemia in women with previous gestational diabetes, can we reduce atherosclerotic cardiovascular disease? This seems to at present suggest no, it may not completely reverse. This history of gestational diabetes may entail underlying vascular changes which adversely affect the cardiovascular disease and the pathways of insulin resistance, which are common and promote atherosclerotic plaques independent of dysglycemia later. And this is the mounting evidence which says that we have to screen women for gestational diabetes, not only screen, stratify them, risk stratify them for better treatment for early atherosclerotic cardiovascular disease and prevention. So to conclude, gestational diabetes has a marked impact on the future health of both the mother and the offspring. The prevalence of gestational diabetes is increasing in most populations and definitely in the Asian Indian community. And it's likely that it's going to play a huge role, not only in people becoming more diabetic, which we can ill afford, but also getting coronary vascular disease or cardiovascular disease. So we need to have effective interventional strategies for preventing and reducing these metabolic derangements in the mother prior to pregnancy, during that, and even after delivery. And it should be implemented by all of us in a war-footing manner so that we can prevent this condition of cardiovascular disease, which is again going so high in our country, so that we can achieve a better care for our women. Thank you very much for a patient hearing. I'm stopping sharing now. Yes.
Thank you very much, ma'am, for wonderful talk. And our next speaker is Dr. Benny Neglur, whose topic is managing diabetes before pregnancy and during lactation. Can I have the CV of Dr. Benny? Yes. Dr. Benny ma'am is director and diabetologist at Dr. Neglur's Diabetes Specialties and Center, and consulting diabetologist at Jupiter Hospital, Thane. She is honorary visiting faculty and diabetology fellowship program of D.Y. Patil University. She is teaching faculty for the PHFI, as well as she is teaching faculty for fellowship in obesity, MUHS, that is Maharashtra University of Health and Sciences. She is founder member of Association of Diabetes Educators of India 2006. She is founder president of Women and Diabetes Super Forum since 2017, and scientific chairperson for RSSDI Maharashtra chapter in 2005. She has MedInspire multidisciplinary conference at D.Y. Patil University. She is organizing chairperson of annual conference of women and diabetes in Mumbai 2017, 2018, and 19. She is also an editor of Awakening newsletter for patient education and ex-associate professor in Department of Medicine in Terna Medical College since from 1994 to 2015. Over to you, ma'am.
Thank you so much. I want to share the screen. You cannot share. Yeah.
Now you can share, ma'am.
Yeah. Yes, thank you so much, Dr. Rutul and RSSDI team for this very important session. And this is one of my favorite topics of diabetes and women. Now, ma'am already spoke about what happens during pregnancy and the future of the babies born to them. I will talk about managing diabetes before pregnancy and immediately after delivery, that is lactation. So we call this a pre-gestational diabetes. Pre-gestational diabetes is anyone who has type 1 diabetes or type 2 diabetes or any other type of diabetes who wants to get pregnant. It is also a GDM diagnosed in an earlier pregnancy that has progressed to type 2 diabetes between the pregnancies, or it is a diabetes treated with lifestyle modification alone or with oral agents or with insulin, or diabetes with or without complications. And there is no difference in the perinatal outcomes in type 2 or type 1 diabetes, pre-gestational who are going into pregnancy, and both need to be handled with equal seriousness. You've just heard what happens in pregnancy, progressively increasing insulin resistance, and there is also a diabetogenic stress of the placental hormones, which actually gives rise to total dysglycemia and worsening of sugars, giving rise to worsening of complications and maternal and fetal consequences, and also nocturnal hypoglycemia, ketoacidosis, and increased risk of childhood obesity and diabetes in the offspring. Pre-gestational diabetes complicates 1 to 2% of all pregnancies, and about 13 to 21% of diabetes in pregnancy is pre-GDM, with the remainder being GDM. Pre-GDM is gradually on the rise. And why is this so? On one hand, there is a delay in the childbearing age of all women, especially in women of type 2 diabetes. So they deliver somewhere in the late 20s or early 30s or even late 30s. So the childbearing age is going up. On the other hand, we are seeing younger and younger women with diabetes. And so diabetes age is going down. In addition, there is obesity and physical inactivity with perpetuates. And then we have the full picture of a kind of a sick population who is getting pregnant. And therefore, there is a need to understand the risk associated with diabetes and pregnancy and see which is the ideal candidate for pregnancy, and also understand the management strategies to improve outcomes. So any woman of reproductive age who is not actively using reliable contraception may become pregnant, in inverted commas. So it means that anywhere between menarche to menopause, women can get pregnant, either first pregnancy or the second pregnancy, which means anywhere between the age of 15 to 51. And it was seen in this study, James and all, which was a prospective study of 66 women, that only 26% of diabetic pregnancies were planned, which means 75% almost are unplanned, and therefore addressing pregnancy planning in women with diabetes has to be looked into. When you do that, the periconception glycemic control, as we know, is the single most influential factor in embryonic development. And the higher the HbA1c, the more is the risk of congenital malformations in the fetus. And if you look at this graph, you'll see that in that square on the left-hand side, anywhere between 5.5 to 6.5 is the ideal HbA1c that a woman needs to keep in the planning stage of pregnancy if they need to get pregnant, to decrease the risk, because an HbA1c less than 8% will give rise to a 5% increased risk, and a HbA1c more than 10% will give rise to a 25% increased risk of congenital abnormalities like sacral agenesis and congenital heart disease and neural tube defects. Also, there is a perinatal mortality, which is increased twofold, and also an increased risk of sudden unexplained intrauterine fetal death. The complications are not only on the fetal side, but you get on both. On the maternal, you see there's an hypoglycemia is common, infections, ketoacidosis, there's a deterioration in retinopathy, increased proteinuria and edema, abortions and miscarriages and preeclampsia, and increased rate of cesarean section. These women, compared to women with GDM, have an increased insulin requirement. On the fetal side, I just told you the congenital abnormalities, caudal regression syndrome, and then there is spontaneous abortion, macrosomia, shoulder dystocia, polyhydramnios, stillbirth, neonatal hypoglycemia, and intrauterine growth retardation. And therefore, if we want to decrease this problems in pregnancy, we need to plan the pregnancy earlier. And therefore, it is important that all women who desire to become pregnant, who are diabetic, have to be informed and cared for and advice given to them in the preconception period. And this can happen anywhere from adolescence at every time they visit the consultant. The initial discussion, of course, will be on the role of diet and exercise, which I'm sure they should do and they are doing, but more emphasis on diet and how to take care of, how to manage their sugars in pre-pregnancy will help them how to do it in their pregnant state. I want to emphasize on the body weight. As the younger and younger population is getting obese, and you just heard about the alarming rise of PCOS and obesity, the obese women who are getting pregnant have more of a problem with all this inflammation and all the consequences that Mala ma'am just spoke about in her lecture. We need to review the medications because all these women have to be taken on insulin for their glycemic control. Metformin can be used as an adjunct to insulin, but the rest of the medication should be discontinued if pregnancy is to be planned. Need to explain to them the risks of hypoglycemia and hypoglycemia unawareness, especially that happens in pregnancy, and nausea and vomiting that can affect their blood glucose control. Discuss with them the increased risk of having large for gestational age babies, risk of neonatal hypoglycemia. And what I want to stress most is that monitoring is the mainstay of discussion where you have to spend a lot of time, because it is monitoring that will help them to normalize their blood sugars and keep them on target. Discussing contraception is an essential component of diabetes education for women starting from adolescence. Choice of the contraception should be based on their own preferences, the comfort of the doctor, the comfort of the patient, and their risk factors. But contraception has to be done till target levels are reached. At the same time, we also must tell them when to stop. Oral contraception, combination category 2, we have to evaluate for their comorbidities for this, but progesterone contraception is also category 2. There's limited evidence suggests that they have little effect on short and long-term diabetes control or the lipid markers. We also need to screen them for all their comorbidities, and especially diabetic retinopathy. A dilated eye examination has to be done before pregnancy and of course every trimester during pregnancy, because retinopathy can worsen. And not only that, the abrupt increase in blood pressure that occurs with maternal expulsive forces during delivery may also cause acute retinal hemorrhages in mothers with pre-proliferative retinopathy. And therefore, we have to take the assistance of an eye care surgeon who will look after these people who already have retinopathy in the pre-pregnant state. Every woman, diabetic woman who plans to get pregnant must be screened for microalbuminuria and a complete renal screening to prevent the increased risk of developing hypertensive complications like preeclampsia that develop in 50% of the women with nephropathy. 25 to 30% of these pregnancies are delivered preterm. There's also an increased risk of fetal distress and intrauterine growth retardation in 20% of pregnancies. And therefore, these patients have to be monitored if they already have a decreasing GFR or a microalbuminuria before pregnancy. Autonomic neuropathy involving the GI system may be difficult to determine, as nausea, vomiting, and constipation are common symptoms of normal pregnancy. But gastroparesis can be associated with increasing hyperemesis, with irregular absorption of nutrients and inadequate nutrition, and also causing a very erratic blood glucose control. It is also associated with increased risk of severe hypoglycemia, and therefore we need to screen and inform and ask the patient to be aware of that. In women with diabetes and chronic hypertension, aggressive control of hypertension should be initiated preconceptionally. Need to maintain a blood pressure below 130/80 to optimize the pregnancy outcomes. If the woman is on ACE and ARBs, both these have to be discontinued, and it is better to the preferred medications would be nifedipine, labetalol, alpha adrenergic blockers, methyl dopa, and diuretics. Women with diabetes have a threefold increased risk of CVD and heart failure, more so in those who have pre-existing coronary artery disease. We just heard from Mala ma'am the consequences. But women with type 1 and type 2 diabetes may be prone to heart disease also if they have a long duration of diabetes associated with hypertension and dyslipidemia. The pregnancy summary of evidence and consensus recommendation advises a resting ECG for women with diabetes who are more than 35 years of age, and a stress ECG or echocardiogram for women having diabetes more than 10 years if clinical signs are present. Remember that we have to, all lipid-lowering drugs, especially statins, must be discontinued. We also need to review all the other concomitant medication. Insulin, as we know, is the drug of choice in pregnancy. It is also the drug of choice in the preconception phase because we have to train them to use insulin to the withdrawal of other OHAs. Metformin and glyburide are approved in pregnancy in various countries, but it is best to change oral drugs to insulin in the pregestational stage itself. Metformin, however, may be used as an adjunct to insulin if there is difficulty in controlling the blood sugars. All other oral blood glucose lowering agents should be discontinued before pregnancy. Almost all conventional insulins are safe. Analogs like Aspart and Lispro are approved for pregnancy. And basal insulin, Detamir, is the only one that is approved for pregnancy right now. We have to achieve an HbA1c pre-pregnancy much below 7%. But during pregnancy, the target is fasting of 95, 1 hour postprandial is less than 140, and 2 hour postprandial is less than 120, with an HbA1c of less than 6. So the best HbA1c in the planning stage or the pregestational stage would be between 6.5 and 7. We have to strongly advise women with diabetes whose A1C is above 10% not to get pregnant because of the associated risks. Women with pre-existing diabetes should test. Monitoring of blood sugar should be done as many times as possible. We need to test fasting, preprandial and postprandial glucose has to be done at least in a day. 3 to 4 times is the minimum that women have to test their blood sugars. Although standard of care is 7 to 8 times, we know that most of our women even do not do their blood sugar even thrice, but as many times as possible should be encouraged. Traditional SMBG targeting, pre and post targets, is to be also added with continuous glucose monitoring. For that will reduce the macrosomia and neonatal hypoglycemia in pregnancy complicated by type 1 diabetes. But CGM metrics is only to be used as an adjunct and not a substitute for self-monitoring of blood glucose if we need to achieve optimum glucose control in 24 hours. When a pre-GDM woman gets pregnant, this is the frequency of their tests. HbA1c every 4 to 6 weeks, blood glucose, home monitoring is the best, 4 to 8 times a day. Urine ketones during period of illness, when any blood glucose is more than 200. Proteins, a dipstick at every office visit, and especially if the patient has nephropathy, you need to do their serum creatinine every trimester and also their GFR. Thyroid function test, a baseline TS measurement is mandatory, and an eye examination by a retinal specialist. There are also contraindications to pregnancy in pre-GVM. Ischemic heart disease, active proliferative retinopathy, which is untreated, renal insufficiency with a creatinine clearance less than 50 ml per minute, or a serum creatinine more than 2 milligrams, or heavy proteinuria more than 2 grams in 24 hours, or hypertension more than 140/90 despite treatment, then that's a contraindication to pregnancy. And also severe gastroenteropathy may also cause severe nausea, vomiting, diarrhea, and interfere with pregnancy. So it becomes a relative contraindication. So who will be an ideal candidate? One who is well controlled with no wide swings of sugars. They have a normal HbA1c between 6.5 to 7. They have absence of vascular disease. They have taken preconception folic acid 5 milligrams a day at least 3 months prior to conception and continued until 12 weeks of gestation, normal renal function, and the ability and willingness to closely monitor blood sugar. This would be an ideal candidate, and we should keep most of our patients at this level. Post-delivery or postpartum, pregnancy hormone levels drop. We need to give them almost less than 30% of the pre-delivery doses of insulin for the first 3 to 4 days. But the rule of the thumb is 30% of pre-delivery insulin dose or 60% of pre-pregnant insulin dose. However, you have to monitor, you have to adjust the insulin according to the SMVG. Ideally, an HbA1c less than 7 and blood glucose between 70 to 180. Do we give metformin in lactation? We said that insulin is the drug of choice even in lactation. But metformin has been shown to be a very small quantity in breast milk, about 0.13 to 1.2 milligrams. And therefore, the relative infant dose is 0.5 to 0.6% of mother's weight-adjusted dose. It is excreted into the breast milk, but the amount is clinically insignificant and so can be given. The woman has to resume their healthy diet using the same caloric allotment as pregnancy for breastfeeding as well. And it is more valuable to evaluate the blood glucose with regular diet that patient will be eating at home rather than using a hospital carbohydrate controlled diet. This is the most difficult. As much as possible, the BMI has to go back to the pre-pregnancy levels. And for that, the woman has to work hard, not only taking a healthy diet with less calories, but at the same time seeing that the baby is also fed well and staying active, about 30 to 60 minutes of walking per day. What about contraception during lactation? WHO says that it is category 1. There is no contraindication to any type of contraception, but combined oral contraception, there is conflicting data with breastfeeding and therefore must be avoided. There's also inconsistent data on progesterone alone contraception. Not only will it disrupt the glycemia and lipids, but it might also interfere with breastfeeding. However, contraception should not be taken at least 4 to 8 weeks after delivery to reduce the incidence of thromboembolic phenomena. And this is something very recent, FOXY position statement. COVID vaccination for pregnant and breastfeeding women. Right now, Covaxin is approved for breastfeeding women and pregnancy. This is what was already spoken by ma'am. You will see that a woman who has diabetes will produce a dysglycemic environment to the fetus. And if the fetus is a female fetus, their ova also bathed in a malnourished environment, which will give rise to the birth of the baby, produce childhood obesity and metabolic syndrome and insulin resistance. And this girl will then become pregnant and the whole cycle will be perpetuated or continued, giving rise to, I think, a sick population, which has to be avoided. And therefore, pre-pregnancy planning is very important. And after delivery, Pre-pregnancy for the second child is important, and interconception strategies have to be followed. There has to be proper birth spacing. WHO says that the birth spacing ideally is 24 months, but most of the gynecologists and obstetricians say even up to 18 months is okay for the second pregnancy. The pre-pregnancy BMI is also important because a lot of weight gain happens in the first pregnancy, and therefore we have to take care of the second pregnancy, correct the micronutrient deficiencies, look at the chronic disease and comorbidities. Tobacco use and drug use should be withdrawn. The mental health is also important in the mother. She has to be prepared for the pregnancy, and all infectious diseases have to be treated. Even if the mother gets dysglycemia during pregnancy, at least she will tell all her friends and relatives to prepare and plan their pregnancy. And so the word will be spread to generally women in the population to have a pre-gestational planning and a proper advice before pregnancy. One. So in summary, the management of diabetes in pregnancy standard of care in diabetes 2021 recommends that starting at puberty and continuing in all women with diabetes and reproductive potential, pre-conception counseling should be incorporated into routine diabetes care. And family planning with effective contraception should be prescribed and used until a woman's treatment regimen with an A1C is optimized for pregnancy, the ideal A1C being less than 6.5 to reduce the risk of congenital anomalies, preeclampsia, macrosomia, preterm birth, and other complications. Thank you so much.
Thank you very much, ma'am, for the wonderful talk. And we will move forward to the next session. The next talk is of Dr. Nandita Arun, who will be talking on CV risk in women health and diabetes. Is it so? Dr. Nandita, her CV is quite a big. She is MD, FRCP Glasgow, FIMSA, and PG Diploma in Diabetes. She is Director, Consultant Diabetologist at ARH Diabetes Hospital, Chennai. She is Founder Director of India Diabetes Research Foundation, Chennai. Dr. Nandita Arun is Director and Consultant Diabetologist at ARH Hospital. She did her undergraduation in Sri Ramachandran Medical College, during which she has attained gold medal in preventive and social medicine, and post-graduation in MD General Medicine at Sri Ramachandran Medical College, Chennai. She underwent a training for research at the prestigious University of Cambridge, UK, training for diabetes at Christian Medical College, Wellow, and diploma in diabetes from Cardiff University, UK. She has also, to her credit, conferred fellowship by Royal College of Physicians, that is FRCP Glasgow, and fellowship in International Medical Science Academy. She underwent training for healthcare management at Indian Institute of Management at Ahmedabad. Dr. Nandita Arun is member of several diabetes and medical societies and has been organizing member of many international conferences and has several international publication and presentation to her credit, and is co-investigator in many drug trials, is also advisory board member for various committees. Over to you, Dr. Nandita. You're not audible.
How about now? Am I audible now? No?
Yes. Now audible.
Okay, great. Thank you,
Yes.
Dr. Ritul. It's okay. My apologies for sending in such a long CV. I should send in
No,
a.
that's okay. Perfectly okay.
But thank you so much. I think we'll move on for short of time. So, with your permission, I'll go ahead and start.
Yes, of course. Please.
Thank you so much. So, very good evening, and I'm so happy to be part of the RSSDI 2021. Is my first slide visible? Just to confirm that I'm sharing properly. Is it seen?
Yes, it is visible. Yeah, visible.
Thank you so much. Thank you. So I bring greetings from Chennai, where after a bout of darkness and rainfall today, we see bright sunshine. So anyway, so good evening to everyone. I'm so happy to be part of this particular symposium with women with diabetes. And it's been a pleasure to listen to the previous talks as well. I'm going to be further discussing what has already been previously discussed by Dr. Chitra in her talk. I'm going to be discussing cardiovascular risk in women with diabetes. Is it more than what we think? And are we, as clinicians, guilty of not taking it too seriously? So I want to start off with a case study, which is, I think, my usual approach to this particular topic that I usually try to, because I think this is what sort of makes it relatable for many of us as clinicians. So this is a 51-year-old lady who is a farmer, who's a wife of a farmer, and she's a mother of 3 living in a village. She's a known case of type 2 diabetes since 13 years, and she's on medication for her diabetes. She's on a sulfonylurea with metformin. She presents to a doctor with pain in her upper back and shoulders for the past 2 days. And the doctor prescribes her a set of painkillers and sends her home. Day 4, the pain still persists and she develops vomiting and returns to the clinic when the doctor decides to take an ECG, and then it turns out to be an evolved inferior wall MI. So this is a very common sort of clinical scenario that I think, which is probably a very sad story that I'm starting off with. But the sad truth is that women are often dismissed. And there is data to show that women in general are under-investigated for the presence of coronary artery disease. And it is quite sad that, but this is the stark reality of the world today. So moving on, what is the data that we have? The prevalence of diabetes globally, as we all know, has been increasing, but this is data, Indian data, where I'm showing you the prevalence of diabetes in the adult population in southern India, reported right from 1980s right up to 2016. And as you can see, there has been an explosion in the prevalence of type 2 diabetes over the years, and this is likely to probably keep increasing. What is alarming is that this has been increasing not just in the urban areas, but also in the rural areas. When we compare our data to that of global data to the other parts of the world, and when we tease it out further between men and women, the prevalence of the percentage of prevalence of type 2 diabetes comparing both men and women, as you can see, the blue, which represents the men, and the pink bars, which represent women, the blue bars are slightly higher in the western part of the world. But when we look at Southeast Asia, we find that women, the percentage of growth or the percentage of increase in the prevalence of type 2 diabetes, and this is data right from 1980 to 2008 by region wise, and in Southeast Asia, the percentage of increase in the prevalence of type 2 diabetes is actually higher in women as compared to men. So we are still probably, we should come out of that belief or the disbelief that women are less affected with non-communicable diseases or lifestyle disorders. This is data that we recently published. When we move on to, again, we looked at data from Southeast Asia. Now we're going to look at data from our own part of the world, from India, from Tamil Nadu, where we looked at the change in prevalence of type 2. So we had last published data on the epidemiology of type 2 diabetes and cardiovascular risk factors from Tamil Nadu last in 2006. So we wanted to go back and look at the trend of these risk factors, namely cardiovascular risk factors, both diabetes and prediabetes in the same population 10 years later. And we call this the so-called STRIDE study, looking at the secular trends in diabetes in India. And these were the results where we found that there is in fact a significant increase in the prevalence of type 2 diabetes in not just in the city and in the town, but also in the villages. And what I want to bring your attention to is that last bar that you see in the bottom, where you find that there is a significant increase in the prevalence of type 2 diabetes in women, again, not just in the city, not just in the town, but also in the villages. And this is how this becomes very relevant to that case that I presented to you earlier, where there is a woman with type 2 diabetes who presents to the OPD with a myocardial event. Moving on, when we also looked at the prevalence of prediabetes, similarly, we found that there is in fact a significant increase in the proportion of women with prediabetes. And this is again, not just in the city and in the town, but also in the villages. So what is worrying about this data that we're looking at here today is that we have a huge burden in the prevalence of prediabetes as well as diabetes. And what is so important about prediabetes is that these are women who are waiting, or a sort of like a ticking time bomb, who are waiting to convert to type 2 diabetes. And we all know that once they do convert to diabetes, it is almost considered as a cardiovascular equivalent. We also published the trend in cardiovascular risk factors, and this is what is even more striking, where we looked at data in the trend in CV risk factors among women, the same STRIDE study in which we looked at over the past 10 years, whether there is an increase in the cardiovascular risk factors. And we found that there is in fact an increase in the prevalence of dyslipidemia, again in the rural women as compared to the urban men, so 37% as compared to 29%. Again, there is also an increase in the waist circumference, and here you find both in the urban and in the rural, there is significant increase in the waist circumference in women in the rural population, a significant increase in the general obesity. And when it comes to hypertension, we found that there was a significant increase only in the urban, but not in the rural areas. So this is the burden of cardiovascular risk factors. And I presented to you data globally. I showed you Southeast Asian data, and right here in front of us, we are now looking at data from our own part of the world, Indian data of this latest data from 2016, where we find that there is a significant increase in cardiovascular risk factors among women. So this is very, very alarming and something that we really need to take very seriously. So is there, in fact, a higher cardiovascular? Now we looked at data to show us that there is an increase in the cardiovascular risk factor prevalence among women, but is the burden of cardiovascular mortality higher in women as compared to men? And this is a meta-analysis in which they have actually looked at all-cause mortality and cardiovascular mortality in women as compared to men. And this is a large number of subjects that they included, almost 23 studies and a huge number of subjects that were included in the analysis. And they looked at both cardiovascular and overall mortality and stroke mortality, and comparing that between women and men. And interestingly, when they looked at women with diabetes versus women without diabetes, they found that there was a 93% higher risk of all-cause mortality in women with diabetes versus without diabetes, as compared to a 74% higher risk in men with or without diabetes. Furthermore, when they analyzed the data between women and men with type 2 diabetes, they found that the all-cause mortality was 13% greater among women with as compared to men with diabetes. So this is what they found from the study so far. Furthermore, in the same analysis, they also found, when they looked at, so far what I showed to you was data from the all-cause mortality, but when they also looked at cardiovascular disease and cardiovascular mortality, stroke mortality, they found that there was a significantly higher mortality rate, both not just all-cause, but also cardiovascular mortality in women with diabetes as compared to men. So this just, the authors of this the analysis and this publication actually conclude by saying that we probably do need a gender-specific risk assessment, and also our interventions and our approach should probably be more gender-specific. This is a study in which, quite an interesting study in which they looked at the 2-year mortality rate between diabetic men and women after a first myocardial infarction. And they found that after the first MI, mortality at 28 days and then further mortality at 2 years was significantly higher among women as compared to men with diabetes. And they actually concluded that the survival at both 28 days and at 2 years was actually lower in women, significantly lower in women as compared to men. And the authors also concluded that diabetes and cardiovascular disease was probably more dangerous in women as compared to that of men. So why is this so? So far we've established that we do have a huge burden of cardiovascular risk factors, type 2 diabetes, women exploding to convert to from pre-diabetes to type 2 diabetes. And we've also now looked at data to show us that cardiovascular disease in women is probably more dangerous than even men. But why is this so? Are there differences in the risk factors and the pathophysiology? And this has also been briefly discussed in the previous talks, but the cardiovascular risk factors are slightly different, quite different in women as compared to men. And this is because there are diversities in biology. A woman goes through different changes throughout her life cycle. There are cultural differences, changes in differences in socioeconomic status, which also impacts the women's health. And overall, there is also differences in body composition, which also I'll be showing you in the next couple of slides. So other than the traditional cardiovascular risk factors, which would include diabetes, obesity, abdominal obesity, smoking, hypertension, dyslipidemia, and so on, women also have the unique gender-specific risk factors, which would include gestational diabetes, their polycystic ovarian syndrome, low socioeconomic status, more propensity for breast cancer, depression, and all these, of course, menopause, postmenopausal women, all these factors together, which are gender specific, also contribute to CV risk factors. And so the risk factors itself are quite different. There is also a difference in the fat distribution, and this is a cross-sectional CT that you see over here, pictures, films that you see over here, where we're comparing both. On the left, you have A and C, which are men with a BMI of 25 on top, and the bottom is a man with a BMI of 33. And on the right, you have the same BMI, but women. So as you can see, there is women, it is well known that they do have a different sort of fat distribution as compared to men, and more propensity for visceral adiposity, or the more sort of dangerous fat, and higher cardiovascular risk as compared to men as a result. We also know that, and this is data to show us, that men have an earlier cutoff of age and a BMI for diagnosis of type 2 diabetes. So in other words, men are diagnosed earlier as compared to women for type 2 diabetes, because they have this may also be, this could be because men have a lower age cutoff, men may have a lower threshold of BMI, lower threshold of insulin resistance, more because of the fat distribution differences. But this could also be because men have more health-seeking behavior, and men probably get tested more earlier or more often than women tend to. And as a result, women get diagnosed with type 2 diabetes probably at a later stage, and this indicates that women are at a worse starting point, or their starting point at which they are diagnosed with diabetes itself is a worse starting point as compared to that of a male who is diagnosed with type 2 diabetes. And we are probably starting off our preventive strategies for complications a little too late during the course of dysglycemia during a woman's life. So just to summarize what I've spoken about so far, there is an increase in the prevalence of both diabetes, pre-diabetes, and cardiovascular risk factors, including waist circumference and obesity in women in India. We know that cardiovascular risk and risk factors in women are quite different as compared to men. And we also know that menopause itself is one of the risk factors that increases cardiovascular risk in women. But if once a woman is diagnosed with type 2 diabetes, her premenopausal estrogen production is also probably lost. And we also have looked at data to show us that cardiovascular disease in women is probably more dangerous than that compared to men with diabetes. This is, I'm going to conclude my talk with this study, which I just included this morning in my slide deck. This is a review article that I quite enjoyed reading, which has been recently published in the Diabetes and Metabolism Journal just this year, 2020. And in this, this is a sort of a recommendation for management of cardiovascular risk factors or cardiovascular risk in perimenopausal women with diabetes. And it addresses, it's basically a call for clinicians to address or to sort of take women with diabetes more seriously. So lifestyle behaviors that are recommended is, of course, smoking cessation, weight reduction, physical activity at least 30 minutes a day, restrict salt intake, and increase your intake of fruits and vegetables at least 10 servings per day. Alcohol consumption recommendation is less than one or even up to one drink per day for women. Glycemic targets, of course, to be individualized and to use SGLT2 and GLP-1 or cardiac-friendly anti-diabetic agents when and whenever necessary. Blood pressure targets also to be individualized. Consider ACE and ARBs whenever possible, but contraindicated in pregnancy. Cholesterols, statins to be used in all women with diabetes. However, in younger women with lower cardiovascular risk or women with who are non-smokers and who are on intensive lifestyle modification and who are on good dietary regimes and who have low cardiovascular risk, as I mentioned, in such women we could consider not using a statin if not, and that is left up to the discretion of the clinician, but of course contraindicated in pregnancy. Antiplatelet therapy to be the role of aspirin is not indicated in the primary prevention of cardiovascular disease, but any women with established cardiovascular disease should be on an antiplatelet therapy as well. So in conclusion, women with diabetes probably do need more aggressive cardiovascular risk reduction. And I would like to conclude my talk by asking this question: do we need a gender-specific approach? And I think the answer to that at the end of this entire session at the RSSDI today should be yes. Thank you.
Thank you, Nandita ma'am. It was indeed a wonderful session that we were listening to. And I feel I've just jumped into the session, but it's been exciting to be a part of this diabetes and women session. Thank you, ma'am. I think we'll take the questions in the end. And thank you, ma'am. I take the privilege to introduce our next speaker, Dr. Sudha Vidyasagar ma'am from Manipal, who will be talking to us about complications of diabetes using the gender lens. Can we have her CV, please? Thank you, Abhijit. Oh, this is Sarita ma'am's CV, Abhijit. Yes, this is perfect one. Thank you, Abhijit. So Dr. Sudha ma'am is the HOD of Medicine Department, and she's been a good teacher in KMC for 7 times. She's the founder president for Associations of Physicians at Udupi Manipal chapter from February till today. She's the organizing chairperson of the Karnataka State Conference 2020, and she has a lot of research contributions. And it is indeed our privilege to be listening to her, wherein she'll be talking about complications of diabetes using the gender lens. Her CV goes on and on. She's been the PI for a lot of international and national trials. And let's hear more from her rather than from me. Sudha ma'am, all over to you.
मैम प्लीज स्टार्ट एंड मैम जब स्लाइड चेंज करनी हो तो नेक्स्ट बोलिए.
Sudha ma'am. Abhijit, can you call up Dr. Sudha ma'am once to make sure whether she's here or not? Or else if Sarita ma'am agrees, we'll... Sarita ma'am is not here yet.
Okay, ma'am.
Yeah, Sarita ma'am is also not here yet. Nandita ma'am, Beni ma'am, and Chitra ma'am, if you agree, we'll continue with a little discussion. In the meantime, the RX teams can resolve the issue of the next two speakers.
Purvi, if it's okay, you can finish our question answers if there are, so that
Yes, ma'am.
we can have utilized this time.
Yes, ma'am.
Yeah, sure.
Yes, ma'am. Sure. Ma'am, in our real world experiences as well, we see a lot of gender bias, not just in terms of, our social life, but in medical experiences as well. Could you all just, throw some light? You've talked about how it is different in terms of the CV risk, when we talk about pregnancy, the GDM part, or even, when we talk about gender specificity for diabetes. Are we at a place where you think we can make a difference when we pick up all of these subjects, or are we, just bringing it to light, but there is no action to the advocacy that is happening?
So thank you, Purvi, for this question. And actually, it is true that there is definitely a gender bias. I think partly we should make women responsible for their health. The women, by and large, don't take responsibility of their health. They are always someone's daughter, someone's mother, someone's wife, and very little time goes for their own health. So most of the times, they don't take care of their, whether it's their physical activity or diet. I feel a lot of counseling goes into this. And definitely the risk now we know is also much higher. And if you see, even right starting from the fetus to maybe polycystic ovaries, which is also becoming so common, which is a forerunner of gestational diabetes. And then we have data on women cardiovascular disease. I think it's been a continuum that is worsening, and we need to pick them up right at the younger age to counsel on obesity. And like Dr. Chitra showed, maybe an introspection of all women and all doctors treating women to see where things are going wrong is what is the requirement of the day. And a lot of counseling definitely would go a long way. There is discrepancy. We know it exists, both in their gender biases, whether it is environmental or it is genetic, we still don't know. But yes, we all need to work on all these lines.
Thank you, Mala ma'am. We agree there is a lot of evidence about the existing disparities also. But what I mean to ask is that we know about the Divas group, we know about the initiative that Usha ma'am, Beni ma'am, Nandita ma'am, yourself also ma'am, Mala ma'am and Chitra ma'am, all of you are doing something. Could you just, pinpoint to some of the action that we can take against the advocacy that we are talking about in this session? Rather than just counseling and education, what could be one thing, that we have to start implementing some guidelines wherein we talk about addressing the women more screening of postpartum gestational diabetic women, or even talking to the OBGYN, wherein, they can counsel the females for proper screening, or talk to the pediatrician wherein the females move on for vaccination of the kids. There, whether if they can be screened early for their type 2 diabetes, if they have a history of GDM, could there be any, concrete steps that can be taken? Like say 1, 2, 3, these are the steps that you have to do. What should we be doing?
Right. Everything is being done in very small personal things. It's not enough, just a handful, 10 people do it. Like you said, it has to come into an advocacy and maybe a rule, starting from, even what is taken for food, what is the canteens nearby, where is the shop which is a fast food corner, how close it is to the school. Starting from there, advocacy should start. After that, of course, looking at physical activity, and whether you want to give some bonus points for physical activity. Then, of course, definitely gestational diabetes screening. We know we all have to do universal screening. By and large, most of the gynecologists are doing gestational screening. But if, more reinforcement, not only for gestation, maybe now looking at other risk factors like cardiovascular, Benny was talking about retina and CV and kidney disease. So I think all of this should become a policy decision, not being done on an individual basis, like, okay, I also do it, and maybe Benny does it, or Usha does it, or Chitra does it, but possibly as a advocacy and should be done by everyone. Then only it will be followed universally.
Can I say
Thank
something?
you so much, ma'am. Yes, Benny, ma'am.
Yeah, actually it has to be done at two levels. One is we have to make the noise. And we are, I think, trying to do that in all conferences. We are having session on women and diabetes, which we never had in the past. And this noise will help us to form a group that will advocate more and more to the healthcare practitioners, just like they had the Go Red movement, where women had to collect together, make a noise, and then the awareness started. So we are already doing that now. But the second part is the advocacy, Dhruvi, as you have just said, and we are already in the process of doing that. Madam Usha has already started a group known as Didi, and Chitra is part of it, and Shalini Jaggi is part of it. I mean, they are the core team that is part of Didi, and I think most of the women practitioners here who are practicing diabetology and endocrinology and physicians, even Nandita, all of us are part of this group, and we are now in the process of making our advocacy group, and also I think Madam Usha is also in trying to change or modify guidelines with the Endocrine Society of India and the RSSDI. So talks are still going on. So movement is still there. And I hope it continues, and then we will make the change.
Can I come in, Dr. Dhruvi? Hello. So while we are addressing, as Dr. Benny has pointed out, advocacy and making noise to bring attention to the cause, it's also important that we push for further nuanced look at research, as Dr. Nandita has highlighted, right? To look at our specific factors in research, also look at our biases in research, focus on how education should now be, again, sensitive to gender differences between in all chronic conditions, right? Not just diabetes, right? That's also something that we need to look at. And then in the end, it should all culminate into change in clinical practice. And that probably will come down to guidelines. So these are all clocks which tick very slowly, but it definitely looks like it's ticking and moving. And I think all the work that has been done in this space for the last 10 years, led by Dr. Usha Sriram, is beginning to see changes, so much so that Lancet last year had an entire issue dedicated to appreciating the effect of gender and sex in all illnesses, not just non-communicable diseases. So I think we are making progress, but progress always is so slow that we sometimes might miss it while it's happening.
Ma'am, thank you, Benny ma'am, also Chitra ma'am also, and we all are here to support the same cause, and we thank all of you leaders for making it possible. I think we have Dr. Sudha ma'am now in the panel.
Yeah.
Hello, ma'am.
Yeah, I just
Yes,
logged
ma'am.
in. It's an unstable connection, so I thought I'll finish my talk. I don't know how long this will last.
No worries, ma'am. We understand.
Right. So shall I share my screen?
Yes, ma'am.
Okay. 1 minute. I think, thank you all for such a lovely discussion. And I think most of what I wanted to talk has already been talked about, because I had so many intelligent women talking before me. I have hardly any material to talk, and I was just thinking maybe my lecture would be a revision class rather than anything else. But because the topic does overlap, and most of them have done a fantastic job of collecting all the information that's around there on the net and otherwise. So this talk is on complications of diabetes using the gender lens. And the questions that we need to ask is there a gender difference? For which complications? What infections are more common? Are there any differences in acute complications? And does it impact management? So is there a difference? I think most of the speakers who talked before me have shown you all these data, saying that definitely there is a higher mortality due to diabetes in women than in men. And this risk mainly comes from the cardiovascular risk, which is much higher. And also there is not only cardiovascular risk, but there is increased risk of peripheral vascular disease, which is again very much connected to cardiovascular risk. We all know that people with peripheral vascular disease die of myocardial infarction rather than anything else. And so this connection has already been established, that women with diabetes definitely have a higher mortality than men. So that is underlined, I think, several times in this session. And I think, I don't know whether this slide also was projected, but you can see this forest plot, which is showing an increased relative risk in women for coronary artery disease, for stroke, for vascular dementia, for chronic kidney disease, and end-stage renal disease, all of them. Of course, it is talking of cancer and all, but our talk is mainly on vascular complications. So we know that women are at a higher risk of any of the complications that are mentioned here across several studies. So why is there a difference? I think this has also been discussed, that women have a higher prevalence of abdominal obesity, hypertension, and all the other risk factors, which actually go into the making of an increased cardiovascular risk. And there are differences in the endothelial function between sexes, and this is what translates into an increased risk, apart from all these risk factors that are mentioned. And increased vulnerability to the risk factors, apart from the prevalence of these risk factors, is what makes them more susceptible. Also, there is a disparity in the treatment and the treatment response to how we treat hypertension and dyslipidemia. Like we say, more metabolic deterioration is needed before women become diabetic. So as you can see in this figure, where the men become diabetic and where the women become diabetic, before the women become diabetic, they already have clustered enough risk factors. And so that is why when they come with the cardiovascular risk, they already have 4 or 5 risk factors before they become diabetic, which makes them more and more susceptible. Of course, there are women-specific factors apart from the general factors that we know, like polycystic ovary disease, reproductive endocrine disorders, menopause, pregnancy complications, GDM, all of which have been discussed earlier. So we know that each of them predisposes to one particular, or more specifically to one particular risk factors. Polycystic ovary predisposes to type 2 DM, and pregnancy-induced hypertension can continue like that. Eclampsia is known to continue. GDM can last for a longer time beyond the pregnancy. And of course, a preterm birth, which will also translate into diabetes in the next generation. So women-specific risk factors make them more susceptible, because apart from gender risk factors, these are also, it's like a double whammy for these women. Now, like we said, not only that they are susceptible to risk factors, but the effect of the risk factors is also compounded in women. And we know that even in the UKPDS, in diabetic women, the percentage of hypertension was much more than that of men. But a 10 millimeter increase in systolic blood pressure increases the cardiovascular disease by 30% in women as compared to 14% in men. So not only the prevalence is more, but the impact of the risk factor on cardiovascular disease is more. Same thing happens with the lipid profile, which is also skewed, especially in postmenopausal women, and the translation of obesity into various complications like gestational diabetes, hypertension, etc., all of which translate into a higher ASCVD risk and an increased stroke risk. This was already mentioned that menopause and early menopause is an important risk factor for the development of cardiac disease and also contributes to the cardiovascular death. So is there a difference in the micro and macrovascular complications of diabetes? Is there a difference between these two? If you ask this question, we know that the macrovascular complications are cardiac, strokes, and vascular disease. And cardiac complications has already been mentioned. There is a 5-fold increase in fatal MI as shown in the Monica and the Cora study. And we know that definitely women have much more cardiovascular complications than men. They've been underlined many times. Now, the InterHeart study is what began this discussion that diabetes and myocardial infarction among women compared to men, there was a stronger association. And like we said, not only premenopausal women, they lose the protection of the hormones when they get diabetes. Also, following an MI, there's a recurrence rate in diabetic women is much more, it's double than what happens in men. So that is why not only you get MI once, but you get MI twice, thrice if you're a woman. This was also being mentioned that because of the lack of hormonal protection, they get it earlier than in men. But what happens is many times the symptoms of women are ignored because they are quite atypical. Atypical angina is more common in women than in men. We had patients like this. Last week, I saw a 60-year-old lady who came with one vague chest pain and who was dismissed as nothing but psychosomatic, but turned out to be a coronary artery disease. So women are not taken seriously. The description of the angina in them is not typical. So sometimes ignored because one ECG is normal, everybody says you're normal, but the angiogram does show that there is a blockade. The response to antiplatelet drugs is also not as good as in women as in men. The incidence of peripheral vascular disease is more, and cardiac when you do the stress imaging, when you do the thallium, you find that the ischemic area is more in women, and the prevalence and severity of the coronary artery disease is more. And if you do a CCIMT for the carotids, again it is more. Like we said, because of the clustering of the metabolic syndrome risk factors, all these are more in women, but the recognition and the response and the associations are all much more severe in women. Cardiovascular syndrome X is what we call as microvascular angina. This is also mentioned. So women are the people who more often get microvascular angina with diabetes. Diabetes itself causes microvascular angina, but women and diabetes are a very good combination for getting this. Where you do the coronary angiogram and you find normal epicardial coronaries, but because of the small vessel involvement, these people get angina. This is common in peri and postmenopausal women. And Minoca, which is the myocardial infarction with normal coronaries, is also more common in women. And these people tend to have an MI without warning. This could be because of spasm or myocardial bridging and many other causes, all of which are more common in women. So the recognition of these, the presence of ischemic heart disease itself is difficult. The presentation is odd. The coronaries can be normal, like we said in Minoca and like we said in microvascular angina, all of which make it difficult for recognition and treatment. Plus, the response to treatment is not as good. Heart failure is another condition which is common in women compared to men in a ratio of 2:1. It's a double risk for a diabetic woman to have heart failure than for a man to have heart failure. Now, why is this common? Why is this happening? Because of various factors. We have the role of the genes, we have the role of the smaller anthropometry, the estrogen, the higher inflammation, and the risk factor clustering. All these translate into changes in the myocardial compliance. So that is why they are often prone to heart failure with preserved ejection fraction rather than reduced ejection fraction, and translates into cardiac metabolism problems where there is a prominent lipid metabolism and less apoptosis and LV mass is preserved. So there is a thickening of the LV mass, which is correlated with myocardial oxygen demand and CV death and cardiac failure, of course, and vascular dysfunction because, like we said, endothelial dysfunction and abnormal ventricular atrial coupling. So all these are microvascular dysfunction. So all of these, the myocardial structure, the cardiac metabolism, and the vascular dysfunction, all of them predispose to women having heart failure with preserved ejection fraction. This was also already told that women have a higher risk, 27% greater risk for stroke. And the UKPD has also found the stroke fatality to be twice, not only the prevalence, but the fatality to be higher in women. Several meta-analyses have confirmed this fact and showing an odds ratio in women to be much higher than an odds ratio in men. And possibly it's higher even in type 1 diabetes, apart from having type 2 diabetes also. So in summary, if you look at the macrovascular disease, for type 1 diabetes, we don't have much data except for the stroke. Definitely, the coronary artery disease definitely increased in women, and relative risk is there in women after adjusting for all risk factors, and it causes major cardiovascular events. And peripheral vascular disease is again an ignored complication, especially in Asian women, because these people have severe symptoms of PAD accompanied by uncontrolled risk factors. This is also common in women. And with the BMI and the systolic pressure being independent risk factors for peripheral vascular disease, peripheral arterial disease, and of course stroke. So all three complications, all three macrovascular complications are much more common in women. Now coming to the microvascular complications, it's a different scenario. Most of the microvascular complications like peripheral neuropathy are more common in men than in women. And it has also been said that in younger diabetics also, it was found that the male sex predisposes to more peripheral neuropathy than the female sex. So I think we can be happy that some complications are less in us than in the men. Though I wouldn't say that the men should have those complications, but anyway. But there are studies which do not agree with this concept that diabetic peripheral neuropathy is more common in men, and says that more studies are needed to answer this question. This is again a study which talked about peripheral neuropathy in men and women, and found not much difference. So going on to retinopathy, retinopathy is definitely more common in men than in women, especially when you have the diabetic proliferative retinopathy is much more, and suggesting that the male sex may be a definite factor. Even in an Indian study, it was found that males had more diabetic retinopathy than in females. When you come to the nephropathy, microalbuminuria is actually more common in women to begin with, and the decline in GFR is faster in women. But when you look at the death, okay, this is a study which talked about those who are on hemodialysis and peritoneal dialysis and whether they are diabetic or not. And when they looked at the cardiovascular mortality, we all know that people with CKD, we know through the involvement of the clotho and other factors, the FGF23, we know that the vascular disease is what is going to kill many people with CKD. And so again, women with diabetes and CKD actually have more cardiovascular deaths, which is in keeping with the rest of the CKD population also. But women do have more cardiovascular deaths, especially if they have CKD. So there is a difference here. And when you look at microvascular complications, again, this is another study which came out in 2020, showing that men tend to have more microvascular complications, especially microalbuminuria, and multiple microvascular complications are more common in men. And they said that probably there is not much deterioration in women. And this is another study which shows that women with type 2 diabetes are not disproportionately associated. So again, saying that we don't have a disadvantage here, that women do not have much microvascular complications as compared to men. So most studies say men either have more microvascular complications or we are almost equal to them. The recent studies have been telling that there is parity, but there is not an increased risk of microvascular complications in women, except for the CKD component. So summing up again, the vascular complications in type 1 diabetes, the microvascular complications, men have more neuropathy, more retinopathy, more nephropathy, but the deterioration happens in women and then they could die of cardiovascular disease. When you look at the microvascular complication type 2 DM, again more retinopathy, nephropathy, and neuropathy. But again, the end stage CKD, women have more cardiovascular mortality. So to sum it up, it's probably men have more microvascular or almost equal, and women definitely have more macrovascular. So here we are definitely at a big risk. Women have a big risk, but the microvascular is not so sure. And jury is still out on that question. One of the most peculiar complications that we get in diabetic women is the urinary tract infections, the genital infections, which are definitely more common in women, more prone in different stages of life, because in young women, the honeymoon cystitis comes in during pregnancy, and in the elderly because of prolapse. And at every stage of life, the woman is at a disadvantage as far as UTI is concerned, and monomicrobial infections are common in most of them. The predisposing factors are common in all diabetics: hyperglycemia, glycosuria, decreased humoral and cellular immunity. But the shorter urethra is where the woman is more predisposed. Reduced bladder emptying and autonomic neuropathy are again common in everybody. Now, UTI in women is a spectrum. We can get asymptomatic or cystitis or pyelonephritis, severe urosepsis, going on to emphysematous pyelonephritis, renal abscess, and septic shock. So you can begin at asymptomatic and end in septic shock. But all of them are definitely more common in women. So asymptomatic bacteriuria, the problem is that we should have in women 2 consecutive specimens of the same bacterial species of 1 lakh colony count. Only then we say that the patient has asymptomatic bacteriuria. And incidence of UTI as such is 15% greater in women than in men, and as high as 40 to 50% after the age of 80, which is probably in the very elderly. But what is definitely important to know is that bacteriuria, the growth of an organism, is definitely more common in women as compared to men, especially over the age of 60 years. And emphysematous pyelonephritis, we have seen so many cases because we work in a tertiary care institution. There are so many women who have come to us with emphysematous pyelonephritis. Previously, we used to do a nephrectomy or a drainage, but most of the time now we are able to manage with DJ stenting and antibiotics. So most of this is a women-centric disease. Asymptomatic pyelonephritis definitely occurs more in women in a ratio of 6:1. Blood culture is positive. This is where it goes wrong for most of the women, because they have an emphysematous pyelonephritis, but they come with sepsis and septic shock because they are automatically letting these organisms go into the blood, and blood culture positivity is almost 50%. So it's very, very high. And these patients come sick, they come with sepsis, septic shock, and this is definitely more common, especially in an elderly woman with UTI. This is one of the complications that we dread. And the prognosis depends on the stage. Right now, I think we have seen in the last 1 year, I would have seen about 5 to 10 patients with emphysematous pyelonephritis, out of which about 6 may be women. And many of them did well because of the higher antibiotics that we use, and we drain the pus through a DJ stenting. Sometimes we have had a nephrostomy done also. Now, asymptomatic bacteria is always a topic of debate because it's more common in diabetic patients, ranging from 8 to 26%. But we know that 2 to 7% of pregnant women also have asymptomatic bacteriuria. And as many as 70% of diabetic women have ASB and have accompanying pyuria. Now, pyuria doesn't mean an organism, so we cannot take the pyuria seriously, but the asymptomatic bacteriuria, we have to check whether we need to treat or not. Now, that's a question that's been gone back and forth over the years, over decades. But now it is known that diabetic women with asymptomatic bacteriuria up to 3 years found that the bacteria persists or recurs in most women. It is benign and you can hardly eradicate it. So many times we will find that people are treated for this asymptomatic bacteriuria, but when they do the culture again, it's again positive. So what do you do? How many times do you treat? So all the other studies have shown that people unnecessarily receive multiple courses of antibiotics, and this causes antibiotic resistance. So no need to treat except in specific situations, except in pregnancy in women. Now, in women, definitely ASB has to be treated. In fact, 1 urine culture is advised in most women in the 3rd month. And because if you do not treat this, most of them develop symptomatic UTI. There is an increased risk of pyelonephritis because of relaxation due to the estrogen and the tendency to accumulate urine. cholestasis is there, and it can cause preterm births, low birth weight, and treatment definitely improves outcomes. So you don't want this woman with pregnancy to deteriorate either into an UTI or a pyelonephritis, and you don't want the child to be affected. So that is why in pregnancy, there is no doubt that asymptomatic bacteriuria should be treated, but there is no evidence that other diabetic women who are having this should be treated at all. Now, vaginal infections are again more common in women, and most of the time the organisms are candida. Different types of candida are grown from the vaginal infections in diabetic women, and candiduria can come. Most often when we go to the ICUs, we find women who are on catheters, who have been there, and then you send a urine culture, it comes as candida. Now, many of the times it's a colonizer. Unless it is symptomatic, there is no need to treat if it is asymptomatic. But if it's symptomatic, then treatment with fluconazole is important in these diabetic women. Now, SGLT2 inhibitors, again, we have had patients, even when I've had experience with people who come back with, vaginal candidiasis, and then they close the door of the room and then slowly whisper in the ear that actually I have a candidal infection, I'm having itching in the perianal region, etc. And this is something that we should look out for all patients with on SGLT2 inhibitors, because there is definitely an increased incidence, and better to avoid once they get once, better to avoid it in future. And several studies have addressed this problem. This is a study which is talking about dapagliflozin and the presence of vaginal candidiasis, and definitely it is higher. So this is something that we should ask all our patients who are on SGLT2. Now, coming to the acute complications of diabetes, DKA, it is known that women have a higher incidence of DKA and higher incidence of eating disorders, both of which are more common in women than in men. But when you look at the non-cardiovascular deaths in diabetic women, it's mainly infections. It's mainly infections. So that's what we should remember. So when we look at the complications of diabetes through the gender lens, we have to look at vascular complications, we have to look at infective complications, and especially the urinary infections can be killers because they can break into sepsis and they can cause septic shock. Now, the ground realities of how we treat women and using the gender lens for this also, again, this was also projected and discussed by a previous speaker. This is a Lancet study which talks about sex disparities in diabetes and how to bridge the gap. We know that there are higher socioeconomic barriers, especially in India. I'm sure many women do not go to the doctor themselves. They have to be taken by the men, and the men have to find the time to take them, and these women will not complain. And so, and the money that is spent on a woman is accounted for very differently than the money that is spent on a man, especially in the lower socioeconomic status. So definitely there are socioeconomic barriers, and opportunities for physical activity tend to be less. When you ask the woman, do you go for a walk? You will find that many people say, no, I don't have the time, I'm doing housework. And they don't focus on themselves. They don't give themselves even 15 minutes of time to go for a walk. Especially in India, this is very, very common in all our practice. And of course, cultural factors, because some people say even going for a walk is considered something, culturally wrong. I have seen women who say that people will ask me, where are you going? This kind of thing. So in rural areas, this is a problem, because a woman walking without a direction is considered going in the wrong way. Now, access to healthcare is less screening, less access, poor adherence to therapy. Like we said, women treat themselves last, put themselves last on the priority list of any family. So they do not adhere to therapy. They forget their drugs. The monitoring is less frequent. The women don't monitor their sugar so frequently, nor for any complications. Worse consequences are there. So do the women get good care? After stroke also, there is an inferior health-related quality of life after stroke in women than in men. So putting together all this, if you look at this, do we treat them well? Let us start with a man and a woman starting with diabetes, not with diabetes, normal glucose tolerance, exposure to risk factors. Women may have a longer diagnostic delay than in men. Then annual screening of vascular complication, women will never come. You tell them, have you undergone a ECG? Oh, no, I have not undergone, only sugars. That's their usual answer. And the cardiovascular complications, unfortunately, are more in them. The primary prevention and secondary prevention are often neglected. People do not even take one tablet of aspirin, how much ever you tell them. And lifestyle and education is not really as good as in women as in men. And the pharmacological interventions are also not taken seriously, and sometimes they do not respond and they are less adherent. So putting together all this, women lose their hormonal advantage when they get diabetes, and so they are prone for all kinds of complications, more clustering of CV risk, more CV mortality. All macrovascular complications are more common. Infections, urinary and genital, are more common, and access to healthcare and utilization is poor. So I just want to end by saying there's a long way to go and a lot can be done. And I'm sure most of the women who are talking now are doing a lot for other women who have diabetes, and that's the way forward. Thank you all for a patient hearing.
Thank you so much, Sudha ma'am. A lot has been said in today's session about how we women are outstanding in a lot of ways and how we need special care as well. And all the speakers have pointed out as to, the importance of why we women are, special. Before we continue to our next speaker, Sudha ma'am, if you allow me, there's a question in the chat box for Nandita ma'am, if you allow me to take it up. Sarita ma'am is also here, ma'am. With both of your permission, if I can take up one question for Nandita ma'am, please.
Absolutely, absolutely.
Thank you, ma'am. Nandita ma'am, there's a question asking about the role of antiplatelets for women who are suffering from any kind of CV risk and established CV diseases also with diabetes.
Right. Thank you, Dhruvi, and good evening, Sarita ma'am, and thank you for allowing us to take the question in between. So yes, Dhruvi, I think I briefly did address that during my talk in the last slide, where I showed you a table from a publication, a review article just recently published 2021, in which the recommendations are that definitely aspirin or antiplatelet therapy does have a role in secondary prevention. That is, in women with established cardiovascular disease and diabetes, there is no question that they do have to be on antiplatelet therapy. But however, in women who do not have established cardiovascular disease, the role of aspirin and antiplatelet therapy is questionable because of the risk of bleeding, and especially GI bleeding as compared to the risk is more in women as compared to men. Having said that, the ADA guidelines do say that in women above the age of 50, since diabetes, as we all discussed so far, is considered as a cardiovascular equivalent, if a woman is above the age of 50 and has any one additional cardiovascular risk factor, like say, for example, dyslipidemia, hypertension, smoking, or a family history of cardiovascular disease, any of these risk factors, then yes, you could consider, but again, it's an informed decision that should be taken with discussion with the patient to initiate antiplatelet therapy.
Thank you, ma'am. It does make a little bit clearer. Rather than reading, it's always better when we learn from a experienced person. Thank you, Nandita ma'am. Sudha ma'am, we'll wait for a few questions if we are getting in the chat box. And if you don't mind, we'll move on to Sarita ma'am's talk. Sarita ma'am, can I introduce you? And can I request the RX team to please put up her introduction slide? Actually, Sarita ma'am does not require much of a introduction. She's been the president of RxEvents.co.in and she's been leading the whole battle from the forefront. She's been the founder president for the South Asian Federation of Endocrine Societies called the SAFEs, and president of the Endocrine Society of India from 2010 to 2011. She's been the editor-in-chief and also for the ESI Manual of Endocrinology, both the first and the second edition. Again, she's got such a vast CV. She's got the Lifetime Achievement Award for outstanding services in the field of diabetes and metabolic disorders, and also for her contribution to the UP Diabetes Association. She's delivered various prestigious orations and is now leading all of us when we talk about taking care of women with diabetes. And her areas of interest include diabetes education, thyroidology, growth disorders, and has more than 200 publications in international and national journals. She's editor-in-chief and editor for several monographs and books. So with that, I'm going to request Dr. Sarita Bajaj ma'am to deliver her talk, please. Thank you.
Thank you, Dhruvi. Thank you for those very, very kind words, and to RSSDI team for the invitation. I'll just share my screen. So we've had all the speakers talking about different aspects of diabetes in women. All I'm set, visible, audible?
Yes, ma'am.
Perfect. Thank you. So the most important part of how not to get into trouble, stated very simply, is to establish this non-communicable disease link of hyperglycemia and pregnancy. And that is what I will be addressing in the next couple of minutes. So I will be talking, this is the roadmap that I will be taking. I'm sure this has already been discussed, hyperglycemia and pregnancy, pre-existing diabetes and gestational diabetes, whether it's type 1 or type 2. The numbers, yes, they are really going up, and the numbers are becoming more and more scary. The implications of gestational diabetes as far as neonatal and maternal outcomes are quite significant. The most important aspect of this is not just what happens during the pregnancy, but subsequently. In other words, it has been linked to offsprings who develop obesity, diabetes, neurodegenerative, psychiatric disorders, low intellectual and verbal coefficient, language, motor impairment, attention deficit with hyperactivity disorders, and problems in psychosocial development. So the story does not end after birth. So this is what I will be focusing on. So I'm not addressing what happens during the hyperglycemic environment to the fetus, but what is this fetal programming that results in a host of subsequent disorders. The hypothesis was first proposed by David Barker in 1990 that the intrauterine environment influences the risk of non-communicable diseases. So what is the importance of this intrauterine environment? So we are having the conceptor starting off as a bag of genes, and the intrauterine environment is now going to dictate how these genes function. Even a small change in this environment has the potential to permanently alter the working of the genes and therefore the structure and function of the developing system. The genome transfers the information to the RNA. The factors governing this flow contribute to the development of the differentiation of cells, tissues, organs, and systems, which contribute to the phenotype of the individual. And it was Waddington who described all these processes which link the genotype to the phenotype at birth, and this was called epigenetic. So there is a permanent change in the structure and function of the organism occurring during crucial periods of development, which I am going to call programming. So I think this illustrates it quite nicely. So there are a lot of factors like maternal age has to be taken into consideration, what is the weight of the mother, and what has been her lifestyle. So during the exposure we have this intrauterine programming, which I was addressing. So disturbance of the hormone synthesis, placental development and function. Then early life programming, reprogramming. So you will have a large for gestational age baby, and there'll be more of fat. What happens in adolescence? These are the problems, metabolic problems. So I was just talking about cardiovascular disease as well. And then this is the transgenerational programming. Again, diabetes, cardiovascular disease, and obesity. And throughout, we have DNA methylation, histone modifications, which are continuously happening. This is another theory, that is the DOHAD theory, the developmental origins of health and disease, which says that the altered environmental influences, nutrition, metabolism, pollutants, stress during the critical stages of fetal growth predispose individuals to the NCDs in later life. So from the maternal size to the genome to fetal growth development, differentiation, birth phenotype, postnatal growth, environmental exposure, risk factors, morbidity, and then the associated mortality. Periconceptional, intrauterine, and postnatal periods are the most influential in this programming. When we say periconceptional period, that is 12 weeks before and after conception, it encompasses the natural wiping out of the inherited epigenome and the re-establishment of a new one. And this entire process is very vital, and it covers the whole stage till the formation of the whole individual. Interestingly enough, do paternal factors matter? Yes, even there is association with paternal obesity and diabetes, which support a stronger role for the intrauterine diabetic environment compared to genetic predisposition in the etiology of obesity and diabetes in children of diabetic mothers. So what are the factors which are responsible for this undesirable programming and responsible for the risk of later disease? So number one is the maternal nutrition, altered metabolism, infection, then there is exposure to environmental pollutants and toxins, extreme high atmospheric temperature, maternal smoking, as well as maternal stress. So I'll take these problems which arise one by one. Obesity and type 2 diabetes are very, very closely linked to hyperglycemia in pregnancy. So this is a large data, almost 30,000 children, 20 observational studies, a systematic review showed that maternal hyperglycemia was associated with obesity and abnormal glucose tolerance in the offspring. So in gestational diabetes, a higher body mass index was reported for the children of GDM, as well as high 2R plasma glucose from pre-puberty to early childhood. Type 1 diabetes, again, higher body mass index was reported in pre-puberty to adolescence in children with mothers of type 1 diabetes. And there's a high rate of type 2 diabetes from years 2 to 5, as well as early childhood. And the effects of diabetes during gestation in the offspring can be generationally transmissive throughout the maternal line. See, if you look at a white Caucasian baby, this is the body weight, the average body weight at birth. An Indian baby is much less. But look at the overall fat. The fat is much less despite the increase in body weight. The Indian baby has a much more fat mass as compared to the Caucasian. And this is wherein the concept of the thin fat Indian baby has been derived. So the developmental pathways I've tried to highlight. Suboptimal maternal nutrition also has a role to play, which will result in placental abnormalities, developmental adaptations, and alteration at the level of the liver, adipose tissue, pancreas, muscle, as well as the brain. So this is the vicious cycle. So you have a woman with gestational diabetes. We would like to control the hyperglycemia. This is the infant of a mother with gestational diabetes with epigenetic and genetic predisposition. And subsequently, we can prevent obesity and diabetes in the youth if we control it well. These women are at much higher risk. And this is the whole concept of trying to prevent obesity, PCOS, and preeclampsia in pregnancy. Okay, so all these have been highlighted. And the bottom line here is the insulin resistance leading to these problems. So what are the early life stressors which affect the developing beta cell mass apart from maternal hyperglycemia? Yes, undernutrition and overnutrition are both important. Uteroplacental insufficiency, corticosteroid therapy may be indicated in some patients, dyslipidemia, and hypoxemia. So all this results in a beta cell mass with an adaptive response in the fetus. So the critical window for these adaptive response to early life stressors, that is right from pre-implantation, post-implantation, and if we consider postnatal versus prenatal, then the prenatal environment exerts a greater effect on the beta cell mass as compared to the postnatal environment. And we have more of animal data which proves that. What about the maternal metabolism and fetal programming? We have substantial evidence which has now shown that maternal diabetes and obesity causing fetal overnutrition influence future obesity and diabetes in the child. Both genetic and non-genetic mechanisms are responsible. So this is the Peterson hypothesis, which suggests that an excessive transfer of glucose and other fuels to the baby in a diabetic pregnancy stimulates fetal islets, causing hyperinsulinemia. And the major hormone which does it is insulin. What Frankel expanded this idea to suggest that there is an increased risk of postnatal obesity, and diabetes was a fuel-mediated teratogenesis. So this was mediated by a stable change in gene expression, which we are now calling epigenetic program, and not on the inherited genetic trait. So this is what I was referring to earlier, the so-called fuel-mediated teratogenesis, which refers to an excess transfer of these fuels, that is glucose, amino acids, fatty acids across the placenta to the developing fetus, which causes a stable change in gene expression affecting not only perinatal, but also long-term outcomes in the offspring. So both in India, both undernutrition and overnutrition have an important role to play. And they are both operating side by side. Now, what we are talking about, focusing on the first 1,000 days of life as the most important window in the programming of health and disease. So the PIMA Indian study, this has been very important in helping us understand what is the importance of pregnancy weight gain. So this was an unparalleled design where every member of the community more than 5 years of age, including all pregnant women, if not already diabetic, was serially investigating with an oral glucose tolerance test every 2 years. So if we look at the data, non-diabetics, pre-diabetics, and diabetics, the intrauterine programming of obesity by maternal hyperglycemia was very well shown in this PIMA Indian data. The children born to diabetic mothers had a much higher prevalence of obesity compared to children born in pre-diabetic and non-diabetic mothers. So there are other studies which have confirmed this by Dabilia et al. This was a subsequent discordant sibling study who looked at the risk of obesity and diabetes in siblings expected to inherit similar amounts of diabetes and obesity genes who were born before or after the development of maternal diabetes. The outcome was obese or non-obese, non-glucose tolerant or hyperglycemic. The study showed that the risk of obesity and diabetes was higher in the siblings who were born after the diagnosis of maternal diabetes. So we have similar studies from Krishna Veni et al. In Mysore, a Danish study by Clausen TD et al. And then we have the Chicago Diabetes Pregnancy Studies by Silverman et al. As well. What about the HARPO study? This is in the Belfast Center of the HARPO study. Maternal hyperglycemia had only a weak effect on overweight and obesity in the offspring at 2 years of age. In the Scotland Center, type 1 diabetes, there was a significant effect on overweight and obesity at 7 years of age. These results could be viewed in relation to a previous observation that the macrosomic infants of diabetic mothers catch down during infancy, however, only to catch up at the time of obesity rebound and become obese later. This is the Australian carbohydrate intolerance study in pregnant women, where gestational diabetes was diagnosed in the 3rd trimester. There were 2 arms, one with intensive treatment and conventional treatment. The intensive treatment significantly reduced the macrosomia and related problems at the time of delivery, but had no effect on overweight and obesity at 5 years. Both groups were more obese than the background population. So these observations highlight a crucial role for the periconceptual environment and fetal programming of obesity, and they indirectly raise the possibility that non-glucose metabolic abnormalities may also be important. So this is Dr. Yagnik's data. This is Dr. Yagnik's publication rather. And we know that in India, he is the father of the Baker's hypothesis, which he is continually talking about. Again, Dr. Yagnik's data about poor in utero growth and reduced beta cell compensation, high fasting glucose from childhood, which are the harbingers of glucose intolerance in young individuals. Inadequate compensatory insulin secretory response to increasing insulin sensitivity from early life is the major pathophysiological underlying glucose intolerance in thin rural Indians. Smaller birth size, maternal pregnancy hyperglycemia, higher glycemia in childhood herald future glucose intolerance. So this mandates a strategy for diabetes prevention from early life, preferably intergenerationally. So much for obesity and diabetes. What about CVD? Again, prenatal exposure to maternal diabetes has also been shown to be associated with congenital heart disease. A later increased risk of CVD in later life has also been seen. It is unclear whether to what extent this prenatal exposure increases the risk over a lifetime. In this study, it has been highlighted that the exposed offsprings had a higher rate of overall CVD as compared to unexposed offsprings with a hazard ratio of 1.29. A greater rate of early onset CVD was seen in offspring exposed to pre-gestational diabetes, even frank diabetes. So this was early onset in offsprings. It was of similar magnitude, whether it was type 1 or type 2 diabetes. So heart failure, hypertensive disease, deep vein thrombosis, and pulmonary embolism were also significant. There was a higher hazard ratio for offspring exposed to maternal diabetes in each age group in childhood, before 20 years of age, early adulthood, from 20 to 40 years of age, regardless of the type of maternal diabetes. Motor impairment has been seen from early school age in children born from mothers with gestational diabetes. There's been some data on a reduction in cerebellum size. This correlates with decreased number of Purkinje and granular cells. What about cognition? That is involved in the regulation of emotional and social cues. Some studies have shown that maternal diabetes contributed to cognitive dysfunction in school age children as well. Hyperglycemia during the hippocampal development decreases the synaptic plasticity, reduces memory durability, presumably due to a delay in the normal hippocampal development, which is regulated by insulin and IGF-1 receptors that lead to structural, behavioral, and cognitive abnormalities. Psychiatric disorders like autism has been associated. There's, in some studies, have reported a significantly increased increment in ASD in infants from mothers of gestational diabetes. Yamano and Razi et al., they showed that in utero hyperglycemia reduces the size of the cerebellum. Whether this is physiologically relevant has not been completely resolved. Psychosocial disorders have also been associated. For example, schizophrenia has also been associated in mothers with gestational diabetes. In a Swedish case control cohort study, there was a greater susceptibility of developing schizophrenia in women with gestational diabetes. So therein lies the importance of early diagnosis. So the current practice must be very strictly adhered to. Pregnant women with no risk factors can develop diabetes as early as the first trimester, making it evident that early testing is required. So in our attempts to improve the perinatal outcomes, we should not ignore the long-term outcomes that we know have a very, very strong bearing on this diabetes pandemic. Pre-pregnancy planning is the crux of prevention of fetal programming of these non-communicable diseases. So I have told you about that window, the critical period of fetal programming, which is the window of opportunity we should not miss. So it should be pre-conceptional, throughout periconceptional period, gestational, and even during lactation. So this is the life circle approach to prevention and treatment of subsequent diabetes. Improvement in the health and nutrition of women in their reproductive age might provide an intergenerational solution to this rapidly escalating epidemic of obesity and diabetes. So this is what is meant by implementation of the reproductive life plan, which CDC has defined as a set of personal goals related to childbearing intentions. So this is used to assess a woman's pregnancy goals and guide the assessment of risk to provide appropriate interventions. So the aim of reproductive life planning is to maximize health before conception to improve pregnancy outcomes. So this is for women of reproductive age, whether it's type 1 or type 2, counseling, risk assessment before pregnancy occurs, the medical decision-making, setting targets, optimal diabetes control, changing medications when required, and this has to be a team or collaborative approach. So we've already discussed the ADA recommendations, which are, I think I will not go into the details. What are the ICMR guidelines for screening of gestational diabetes? Again, I think these have already been discussed. I will not go into details here. The high rates of diabetes and pre-diabetes in postpartum period has also been highlighted by Dr. Yagnik, which showed that one of the highest rates of postpartum hyperglycemia within a short time is seen after delivery in young urban gestational diabetes women. Majority of the risk factors were present before pregnancy, and they proposed that metabolic disturbances were also present. So this has implications for this periconceptional epigenetic program. So maternal dysglycemia, changes in the infant's epigenome, which have been modified by diet and physical activity intervention in pregnancy. This was a secondary analysis of a randomized controlled trial. So I've already spoken about the why. How it can be done is by diet and exercise, and what is behind it, that maternal gestational diabetes status were associated with modest changes in the DNA methylation and the impact of high maternal circulating glucose levels on DNA methylation can be reduced by lifestyle intervention in pregnancy. I would like to summarize and give the way forward as well. Maternal hyperglycemia increases the probability of several disorders, which I've tried to highlight. A lot of our women with gestational diabetes would have associated risk factors. Long-term benefits to the offspring are seen if maternal diabetes is well managed. Morphological and functional alteration in the CNS and its relationship with change in gene expression and maternal diabetes, that is quite complex. Children of mothers with diabetes, especially those with a history of CVD or with diabetes complications, have greater rates of early onset CVD throughout early decades of life. And these findings highlight the importance of effective strategies for screening and prevention of diabetes in women of childbearing age. I would like to end by saying that sometimes we forget that an individual is born at conception and not at delivery. Thank you. Thank you very much.
Thank you, Sarita ma'am. And it is really very intriguing to understand when we say that something is necessary to be done right at the time at conception and maybe even before that. My question is to both yourself and Sudha ma'am also, if she's listening to me, and I think Chitra ma'am is also present. Can I ask, there is another school of thought which says that sometimes hyperglycemia in pregnancy, if it is a physiological thing, it could be a protective thing as well. It is a hypothesis. But what is your take on this hypothesis?
I think whatever data we have, whether it's animal data or whether it's human data, it has been shown to be deleterious.
Okay, ma'am.
I agree.
Yes.
I agree with that.
All right.
Can I just come in, Dhruvi, for that?
Yes, ma'am. Yes, ma'am.
I think when the
Yes,
HAPO study came, we were still wondering if the guidelines are very stringent. We reduced it from 2 abnormal values to 1 abnormal value, but now we've accumulated follow-up data for the HAPO study for almost a decade now. The children are now 10 to 12 years of age, and now all the groups who were involved in the HAPO study do have follow-up data with metabolic parameters of the children, right? And there is definite evidence to suggest that the incidence of impaired glucose tolerance is higher, the obesity rates are higher in children who were born to mothers whose sugars were in the current GDM range. So I don't think we should again go back and forth and question this at all.
Thank you, Chitra. See, like if we go again back to the PIMA Indian data, then we come to our home ground and we talk of Dr. Yagnik's data. See, he's been following that those women for almost 4 decades now. And he has shown he has excellent data. Insulin resistance, insulin studies, HOMA, everything is being doing. And he's shown absolutely yes. Thank you, Chitra.
So thank you. So it does make it clear for anybody who's coming and debating with us that you should not be talking and emphasizing more on control of hyperglycemia during pregnancy. We should be doing that. So it's not debatable then. And ma'am has established about the link with other non-communicable diseases also, and not just diabetes. Should we make some guidelines also as to what all screening and diagnosis should be done postpartum also? Because after the delivery, all the focus goes from the mother to the child. And even the family members, they are more focused कि बच्चे को क्या हुआ, उसको क्यों, कैसे कर रहे हैं, and nobody focuses on the woman again.
No, I think those guidelines, guidelines are absolutely clear. that GD, of course, you cannot say that 100% it's going to recur. It's about 60% at the end of 15 to 16 years. They become frank type 2 diabetes. But then that will depend on what was the initial fasting levels. If the initial fasting levels are high, then that happens. If they do not lose weight, again, the tendency persists. So there are some individual factors which are important. And then if there's a very strong family history, that is also extremely important. So the education has to start from day one.
Yes,
not even day one. I said even pre-conception.
Before, yeah.
Exactly.
All right.
Exactly. See, women are marrying late. They are having children later. So that itself is one of the very important reasons for why maybe gestational diabetes is there in a big way. Okay, so we start pre-conceptional, we continue throughout conception, and we do not forget it after delivery. They must be told. So we will repeat the blood glucose values after 6 weeks, then 6 months, then annually thereafter. This is lifelong. This has to continue. And we have where we talk of trying to link it, because the woman, like you said, the focus is on the child now.
Yeah.
The baby will be taken to the vaccination center.
Yeah.
So we talk a lot, but I don't think we've been able to hook up the vaccination center where the mother will go with the baby, where she can, that is the time to be able to catch hold of her and get the tests we want to do for her and counsel her there. I think that link we are missing.
Yeah.
So I think that is,
we could do
that
something
should be
for
actually the way forward.
Can I add something?
Yes, please.
Yes, ma'am.
Yeah. See, I live in a rural area. I live in Manipal. And what happens is we have a lot of rural women who think that it's very important to eat after they deliver because they have to feed the baby. So I have seen people with diabetes and without diabetes, two different scenarios. Those who have GDM and come out of it and then they see the normal sugar, it's like freedom, escape from jail. So they start eating all kinds of things and binge on sweets and whatever. And even the non-diabetic females, they are made to feel that unless they put on weight, they cannot feed the baby. So there is some amount of overnutrition. I've seen women gaining a lot of weight postpartum. So I think like what Sarita ma'am said, the education has to be there even during pregnancy. That is not good to binge eat once you finish a GDM and somebody shows you a normal sugar value. And even for the others, that is not good to eat so much and become very obese and they never lose that weight. And this is not about GDM, but even normally people who become pregnant, deliver, they gain a lot of weight and they find those 10 kgs impossible to lose for the next 2 decades.
I think it's not just the mothers, the grandmothers as well.
The grandmothers.
And I'm also at fault. I'm no better, but I'm just telling you, these myths, at least in our country, are going to be impossible to take away.
Yeah,
it just doesn't work. I always tell this jokingly that one of my relatives always tells me that she was told to take a lot of ghee during pregnancy because that ghee lines the vaginal passages and the baby slips out easily. I mean, like I said, good God, it is that bad a myth.
They could have come up with a better one, madam.
I don't know. Yeah.
Thank you, ma'am. Thank you. I do understand we live in such a paradoxical country and there is existence of almost everything.
Yeah.
Yes, ma'am.
So childhood obesity, we haven't even just mentioned that. It's so important. All mothers complaining that the child does not eat, even if everything is normal. So we shouldn't worry about that. That a fat baby is a fat adult, etc., etc. A thin baby is normal. Even if the child is thin, they shouldn't worry about it. So we have to, that's how do we convey that message? That has to be conveyed right from the beginning.
True, ma'am, very true. Can I request the RX team if we have any questions in the chat box or anywhere else for any of our speakers? We have Chitra ma'am, Sarita ma'am, and Sudha ma'am here as our panelists still present. I don't see any more questions, ma'am. With your permission, could we close the session?
Hello, ma'am.
Thank you.
हाँ, ma'am.
हाँ, Abhijit. हाँ,
Thank
Abhijit,
you.
कोई questions है?
No, ma'am.
Thank
Okay,
you.
thank you.
Thank
you,
you.
Abhijit.
Thank you, Dhruvi. Very
Thank you.
kind of you. Again, thank you to
all.
the
Thank you, Sarita.
organizers. Lovely seeing you, Chitra, Sudha. I think Divya has also joined us.
Yes.
Thank you,
Not
madam.
sure
Nice seeing
if,
you too.
yeah,
I'm seeing you after a long time. Nice
oh,
to see you,
lovely.
madam.
Always, always.
Okay.
Benny,
Yeah.
Usha must have been there. Yes, lovely.
Yeah.
I think there.
Yeah.
Thank you. Thank you to.
Thank you all,
Wow,
ma'am.
there you
Thank
are.
you, Sarita
Thank you
Bye-bye.
ma'am.
so
Thank
Bye.
you.
Bye.
Thank
Bye-bye.
you. Bye-bye.
Thank you, ma'am. Bye-bye.
Bye-bye.
Abhijit, should we move on to the next session?
Yes, ma'am.
So the
Ma'am,
chairpersons are
session.
present.
No, ma'am.
Please
chair.
call them up.
Yes, ma'am. I'm contacting.
All right. In the meantime, let's not waste time. We have Divya ma'am already present in the panel. If you could put up her introduction slide, Abhijit, I'll introduce her.
Okay, ma'am.
Divya ma'am.
Hello.
Hi, ma'am. Should
Yeah,
I
hi.
introduce you and should we move ahead with the...
Yeah, no issues. I'm ready.
Thank you so much, ma'am. It always happens that, accidentally we are together somewhere. We should plan and get together then.
Yeah.
All right. The pleasure is mine to introduce you today again. And the legal chairpersons of today's session were supposed to be Dr. Asha and Shah, ma'am, and Dr. Dharmendra Panchal. Abhijit, can I have Divya ma'am's slide? Abhijit?
मीटिंग स्टार्ट करवाना हेलो
Abhijit, you are unmute, first of all. And secondly, I would request you to put up her introduction slide. Sorry, Divya ma'am.
Issues. It's okay. It's fine with me.
How are you doing, ma'am, otherwise?
Yeah, I'm perfectly fine. Dengue is on peak here. So I was quite busy these days. But hopefully the situation will improve.
I look forward to meeting you in Goa for the first time. We've never been introduced.
Definitely, we are meeting in Goa.
All right. So we have your introduction slide now, ma'am. Dr. Divya Saxena, ma'am, is an MD and she has a lot of fellowships, all from American College to nutrition to, I don't know, some of the, full forms as well. She's done so many fellowships. She's a tutor for MSc Diploma in Diabetes for the University of South Wales. She's also done her PG Diploma in Diabetes from the Boston University and also from the Middlesex University. She's the director for Orange Clinic, a hospital, New Delhi, and she's the director for Saxena Multi-Speciality Hospital in Sonepat. So with that, I am aware that she's doing a lot of work for in-hospital hyperglycemia management as well, and she's an active member of the American College of Physicians, and she's conducting a huge program next month. With that, I think I should give off the stage to Divya ma'am.
Thank you. Thank you so much for the kind introduction. And first of all, a very good evening to all of you. And at the outset, I must thank Dr. Banshi Sabu and Dr. Vasanta Kumara sir and the whole scientific committee for giving me this opportunity to share my views on this prestigious platform. And I must congratulate the whole scientific committee and organizing committee for wonderfully organizing this conference. The topic which has been assigned to me is really of great clinical importance, and I hope I can do justice with the topic. And the topic is hyperglycemia management in transplant patients and patients on steroid. Just hold on, please. The slides are not moving. Just give me a minute. Yeah.
We all know that solid organ transplant is the best option which available as of now for organ failure, including all kind of organs like heart, kidney, pancreas, lungs, and even in some cases the small bowel transplant also. But there are really issues of post-transplant diabetes mellitus, which is a frequent consequence of all solid organ transplantation. And it is really associated with greater mortality and increased chances of infection in these kind of subgroups of patients. We know that with the newer emerging free immunosuppression regimes, it was expected that probably they can reduce the risk of developing diabetes significantly. But unfortunately, the fact is that even without a steroid, risk of diabetes remains a major concern. And the data till date available, although is mainly from kidney transplant patients, and the incidence is really high in these kind of patients, but we have seen that PTDM is more common among liver transplant rather than kidney transplant patients. So now coming to whether the PTDM is another form of type 2 diabetes mellitus or it is a separate pathophysiological entity. In 2003 consensus, it was named as NODAT, that is new onset diabetes mellitus in transplant patient. But after 2013 consensus, the first recommendation was to change the term from NODAT to PTDM because many of the patients might be having diabetes in the pre-transplant period also, which gone undetected, or they may be destined to develop diabetes irrespective of transplantation. And it is also really unclear whether the thresholds we are using for general population can be used to diagnose PTDM in post-transplant patients also. The data till date available with the available evidences says that the major concern is not of microvascular diseases associated with these patients, but rather the increased risk of cardiovascular disease and death also. There is a study showing from Oslo Transplant Center that the persistently high fasting plasma glucose of more than or equal to 126 milligram per deciliter and OGT-derived hyperglycemia of more than 200 milligram per deciliter as well as more than 140 milligram per deciliter were all associated with mortality in kidney transplant patients, while HbA1c levels of more than 6.5% were not associated with mortality. This cartoon is showing the evolution, how the post-transplant diabetes evolved in these post-transplant patients because of the moderate to severe damage to beta cells or pancreatic beta cells. It may be pre-diabetes or it may be present as frank diabetes also. The incidence, according to the data available till date, is of 10 to 74% in kidney transplant patients, 11 to 38% in heart transplant patient, and in liver transplant patient, the data ranges, the incidence ranges from 7 to 30%, while 32% in lung transplant patient. Now, coming to what are the key risk factors which are responsible or which may be responsible for post-transplant diabetes mellitus. There may be some pre-existing diabetes risk factor in the patients who are awaiting for transplant, like age more than 40 years or BMI more than 25 kg per meter squares, or increased waist circumference is also an independent risk factor which can lead to post-transplant diabetes mellitus. Race and ethnicity is also responsible, may also be responsible for the same, where diabetes mellitus candidate gene may also be associated, certain conditions, metabolic syndromes, pre-diabetes, particularly low level of HDL may be associated with post-transplant diabetes mellitus. We know that post-transplant conditions are the inflammatory conditions, and there may be some acute or chronic inflammation existing in these patients, which can lead to PTDM, and certain inflammations like hepatitis C, cytomegalovirus, or HLA mismatch can also lead to post-transplant diabetes mellitus. Like some other factors like PCKD in kidney, CF in lung treatment, even statins are also suspected to low vitamin D levels, low magnesium levels are also suspected to be a cause of post-transplant diabetes mellitus. For immunosuppressants, we definitely know they can lead to hyperglycemic conditions in these patients, and corticosteroids, they are well established to cause hyperglycemia through a number of mechanisms, maybe either by worsening pre-existing insulin resistance or by increasing hepatic gluconeogenesis, and in long term by stimulating appetite and weight gain also. Where high dose corticosteroids, which are oftenly used in the initial post-transplant period, have a greater impact than the chronic low dose corticosteroids, which are being used as a maintenance therapy and immunosuppression protocols in these patients. There are increasing evidence which says that the use of immunosuppressants, particularly CNIs, tacrolimus, and cyclosporins, and inhibitors of mammalian target of rapamycin, sirolimus, rapamycin, and everolimus, they also may contribute to PTDM. While the animal studies suggest that these effects of tacrolimus and sirolimus on glucose metabolism are mainly dose dependent. Now, coming to the timeline, when can we detect, or when we should detect or term the patient as post-transplant diabetes mellitus? In the pre-transplant phase also, certain patients, few group of patients might be having risk factors like age, race, ethnicity, or maybe having metabolic syndrome, whether it is obesity, pre-diabetes, hyperlipidemia, insulin resistance, or with the family history of diabetes mellitus or genetics. They might play a role in the precipitation of post-transplant diabetes mellitus in the later phase, that is after 12 to 24 months. And the initial 3 to 12 weeks, tacrolimus, steroid use, cyclosporin, rapamycin, everolimus, they may cause, in most of the cases, hyperglycemia in the initial post-transplant phase. Now, according to 2021 guidelines from the Association of British Clinical Diabetologists and Renal Association, every patient who is going to transplant should be assessed for the risk of development of diabetes according to 1B evidence, and all people who are awaiting for transplantation, they should be educated for the risk of developing diabetes mellitus, as well as they should be encouraged to minimize the weight gain also. And if the patient is having any risk factor like hepatitis C or any other risk factor, they should be treated while they are waiting for the transplantation. We know that immunosuppression drugs, they can impact insulin signaling and they can cause post-transplant diabetes mellitus. Where corticosteroids, tacrolimus, they have increased risk of diabetes mellitus in these patients, while cyclosporin, M2RI, basiliximab, they have increased risk, but in comparison to corticosteroid and tacrolimus, they have lower risk. Where belastacet is, as per the evidence is available, they have slightly decreased risk of developing post-transplant diabetes mellitus, while mycophenolate and azathioprine, they have no effect on such development of diabetes mellitus. Now, the recommendations also says that if anyone is going to modify the immunosuppression regime to attenuate PTDM risk, it should always be balanced against risk for allograft rejection, and individualization of immunosuppression should be done on the recipient's immunologic and glycemic risk, which should be taken as a part of an overall strategy. The drug should be chosen primarily to prevent rejection rather than PTDM. And there are as such no evidences which suggest that there is a role of changing immunosuppressive therapy in the management of PTDM. And there are no such evidences that newer agents such as belatacept are beneficial in controlling PTDM in these patients with class 1C recommendation. So coming to how to diagnose these patients, or when can we say that these patients are having post-transplant diabetes mellitus. For every pre-transplant patient should be screened for diabetes by doing FPG and A1C, and other cardiovascular risk factors like lipid profile and blood pressure should also be assessed. And if there are any risk factors for type 2 diabetes, they should be managed appropriately in this period of time. In post-op patients, post-lung CBG monitoring are advisable, and to confirm the diagnosis, OGTT is the gold standard test where A1C is not reliable in the immediate post-op patients. After 3 months, A1C can be done, and OGTT is a better treatment, better diagnostic modality in these patients. After 12 months, then annually the patient should be assessed for A1C, and OGTT may also be done in these patients. The recommendation says that in immediate first 6 weeks post-operative period, we should avoid to diagnose PTDM because transient hyperglycemia is almost always associated in this period of time with class 1B recommendation. And to detect post-operative hyperglycemia, afternoon capillary blood glucose monitoring should be done, and formal testing of these patients can be done once the patient is clinically stable, and it can be made after 6 weeks of post-transplantation by using OGTT test. OGTT is definitely a current gold standard for diagnosis of PTDM. It may not be practical in some use, but it can be utilized whenever and wherever it is possible for additional risk stratification and for diagnostic confirmation. Where HbA1c of equal to or more than 6.5% is not a very reliable test, and it can only be done in clinically stable recipients after first 3 months of post-transplantation. And in asymptomatic patient, the test should be repeated after 2 weeks to confirm the diagnosis. The caution should always be taken while using HbA1c if there is a presence of factors that may impair accurate interpretation that by class 1A recommendation. In stable patient, always FPG and HbA1c both should be combined to detect the majority of PTDM patient, and the patients who are awaiting for transplant should be screened annually by testing FPG and HbA1c, where high-risk patients should then go for OGTT testing. The use of novel diagnostic tests such as fructosamine and glycated albumin are undetermined, and they are not recommended as clinical tools for diagnosing these patients. Now, coming to the most important part, that is the management part of the post-transplant diabetes mellitus. And we know that healthy behavior interventions, lifestyle modification always play a role in managing hyperglycemia in any kind of patient. We should always individualize glycemic targets in these patients, and if in any case pharmacotherapy is required, the drugs which should be preferred which do not cause any kind of weight gain. Sulfonylureas are especially avoided in transplant patient, in pancreas transplant and renal transplant patient, and insulin is recommended if there are osmotic symptoms or there is severe hyperglycemia. This is the treatment or management algorithm which is given as 2021 guidelines from Association of British Clinical Diabetologists and Renal Association. these patients, if in the immediate post-transplant period, if they have glucose level of 14 millimole, less than 14 millimole per liter, the oral hypoglycemic therapy or agents can be chosen for the treatment. And if the glucose level is more than 14 millimole per liter, insulin is the drug of choice for these patients. And in the clinically stable period, that is after 6 weeks, non-insulin therapy can be chosen as a first line of treatment. And even if this patient is above the glycemic target, we can add any other non-insulin therapy. And if still the glycemic targets are not achieved, insulin is the indicated in these kind of patients. And among oral hypoglycemic agents, metformin can be used if the BMI is more than or equal to 25 and EGFR is more than 30. And for the patients of BMI more than 25 and EGFR is more than 15, GLP-1 receptor agonist can be chosen. And if we want to give or prescribe SGLT2 inhibitors, the expert advice should be there for these kind of patients, where pioglitazone should be used with little caution. DPP4 inhibitors don't have any safety concerns in these kind of patients. Sulfonylureas and meglitidenide, they should be used with caution in these patients. Now, coming to the in-hospital management of these patients, there are so many things which can, with those so many factors which can impact glycemic control and influence the risk for adverse effect. So these should be considered while treating these patients. And there are no specific glycemic targets which are being established for immediate post-transplant patients, while there are studies showing that in kidney transplant patient, tight glycemic control between 70 to 110 milligram per deciliter is associated with increased hypoglycemia and may increase the risk for future rejection. And we should follow the standard blood glucose control protocol, that is maintaining blood glucose between 70 to 180 milligram per deciliter. Or we can follow the current general practice guidelines for inpatient blood glucose goals, that is 140 to 180 milligram per deciliter. In non-intensive care unit, pre-meal blood glucose goal should be targeted below 140 and random blood glucose goal should be below 180 milligram per deciliter. In immediate post-transplant patient, there are concerns of high dose immunosuppression. There may be pain associated and stress is very high in this period. And the patient is usually kept under observation in intensive care unit, where these patients require IV insulin infusion protocol. And these patients should be monitored very diligently. Early blood glucose monitoring should be done, and they may require frequent dose adjustment of insulin infusions in the immediate post-op period because of anticipated dose changes to cover because of corticosteroid high doses in this period. In the first week post-transplant patients, nutritional intake increases, steroid dose is to be weaned off, and there is rapid improvement in renal function. So high dose immunosuppression is really common in this period. So the patient should be switched to, should be switched to subcutaneous insulin. And once the patient is stable and starting oral intake, the total dose should be calculated from last 8 to 24 hours IV insulin requirement, and patient should be monitored at least 4 times daily in first post-op period of transplantation. And insulin requirement, we should take into consideration that insulin requirement may change daily due to improving renal function and increased nutritional intake also by day-to-day basis. In acute steroid boluses, when we have to give, there may be increased requirement of insulin, and at this time we can consider long-acting insulins in NPH, glargine, or detamir for steroid boluses, or if very high dose steroids are being given in these patients, temporary IV insulin infusion can be started. There may be some fluctuations in renal functions, particularly after kidney transplant. So this should be considered, and we can transition back to the previous insulin regime once the steroids are tapered off, or in high dose steroid boluses regime is complete. If the blood glucose is still rising significantly, IV insulin infusion can be considered as a temporary therapy in these patients. And once the patient is requiring TPN or enteral feeding, the insulin requirements can be increased. So at this period of time, IV insulin infusion should be considered, or we can divide some insulin requirement for TPN bag also. And once the IV requirement are established and the patient is stable, we can switch over to NPH long-acting insulin every 8 hours, plus boluses for correction every 4 to 6 hours. We should consider that insulin dose adjustment can be required in this period if the patient is off TPN or not taking meals or not accepting meals properly. And long-acting insulin should be decreased if the TPN or tube feeds are stopped in these patients. Once the patient are stable, IV insulin can be transitioned, that we know, to long-acting insulin with the correction boluses every 4 to 6 hours. And it is really essential to anticipate the change the insulin therapy, whether it is IV insulin or subcutaneous insulin, with noted interval improvement in insulin resistance, planned transition of TPN, or planned taper off of immunosuppression regime. To summarize the treatment in hospital patients, insulin requirements for hospitalized transplant recipients can vary considerably depending upon the clinical scenario, and it really requires diligent blood glucose monitoring and frequent insulin dose adjustment or titration can really be required in these patients. In general, as an inpatient management of diabetes in non-transplant patient, oral hypoglycemic medications should be avoided because of risk of side effects and because of some concerns over a lack of efficacy in this kind of setting. Even in the event that a transplant patient require very low dose insulin therapy, there are considerations which should be made to initiate oral hypoglycemic therapy at the time of discharge or at the follow-up clinic visit. This is the table summarizing the use of all oral hypoglycemic, how can we use, and which oral hypoglycemic can be used in such kind of scenario. There are evidences from 2 studies available with SGLT2 inhibitors in this kind of setting in PTDM patients. And this is the table which shows that there are some direct and indirect effect on the organs of both the drugs, that are SGLT2 inhibitors and GLP-1 receptor agonist. I will not go into detail, but both of these agents can be used with little expertise in these kind of patients. According to British Clinical Diabetologist and Renal Association guidelines, in immediately post-transplant patient, an early postoperative hyperglycemia should be actively monitored and treated. And if it is mild, then oral hypoglycemic agents can be considered. Otherwise, early insulin therapy always be instituted, either IV or subcutaneous, where glycemic target should be around 7%, but it can be adjusted according to degree of CKD, age, comorbidity, or ability to self-manage and patient preference also. All the patients who are having confirmed diagnosis of patient PTDM, they should be offered structured diabetes education, which is really, really very necessary in this patient. And these patients should be, and this diagnosis, this education should be conveyed to primary care practitioners also, and they should also be offered for structured care and regular screening for any kind of complication. This is also been suggested that patients with stable EGFR of more than 30 ml per minute and a BMI of more than 25 kg per meter square, metformin can be considered as a first-line oral therapy, while other therapies like sulfonylureas, meglitinide, DPP-4 inhibitors, triaglitazones, GLP-1 analogs, sulfonylureas should be used with care, and doses should be adjusted according to EGFR. SGLT2 definitely should be used with caution in patients with a stable EGFR of more than 30 ml and in patients where there are lower risk of UTI with the expertise, it should be used. And insulin therapy should be considered in every patient who have inadequate glucose control or who have symptomatic hypoglycemia also. Blood pressure should be monitored or should be maintained below 130 by 80 millimeter of mercury, and all patients should be offered statin therapy irrespective of cholesterol levels in those patients. And all the patients should have an access to a specialist diabetes expertise within a multidisciplinary team setting with a class 1C recommendation. For non-renal transplant setting, organ-specific factors should be considered while counseling patients for their risk of PTDM before going for solid organ transplantation, and diagnosis of PTDM should be consistent across different solid organ transplant setting with organ-specific caveats in mind. The management should be consistent across different solid organ transplant setting and organ-specific caveats in mind with class 1B recommendation. Now, here are few studies done with these kind of patients, and this is a study done, a Spanish multi-center cross-sectional study. The objective of this study was to estimate the prevalence of and access the risk factor for PTDM, where 2,178 patients were included. And it was found that 17 and 4/10% of the patients who did not have diabetes mellitus prior to transplantation, they developed PTDM. And the greater prevalence was observed among patients with a family history, HCV, and tacrolimus patients. So the learnings are there that the prevalence of PTDM among kidney recipients was higher than that in general population, and especially in those patients with a family history and HCV positive, and tacrolimus is an associated risk factor in this patient. There was another study which was conducted with an objective to evaluate the association between admission, blood glucose, and mortality following hospitalization of organ transplant. And this study included 832 patients with the conclusion that in organ transplant recipient who are admitted for any cause to a general ward, markedly elevated ABG in these patients without diabetes was found to be independently associated with higher mortality risk in comparison with abnormal ABG levels. And in patients who were having diabetes, there was no such association between ABG level and mortality, while there is increased mortality risk was independent of age, gender, smoking, alcohol, or any other comorbidity. This is the Kaplan-Meier curve, which is depicting better survival in patients without diabetes with normal ABG levels in comparison to those with markedly elevated ABG. And the patients in diabetes, there was no significant difference in survival across the various ABG categories. There was another study done for evaluating the recurrent incidence of hyperglycemia which are going to affect differently by immunosuppressive regimes, demographic and medical related risk factors, and inpatient hyperglycemic conditions. So this was a retrospective analysis and conducted in 407 patients undergoing transplant. So the conclusion of this study draws attention to the importance of analyzing the risk factors associated with the disease with respect to both its first and recurrent incidence, as well as carefully differentiating these two perspectives. And this is a fact that is currently overlooked in the literature available. So conclusions are there that diabetogenic effect of tacrolimus can be established when hyperglycemia is experienced for the first time. However, contrary to this effect cannot be established for the recurrent incidence of hyperglycemia. As the diabetogenic effect is ruled out, the results show that age, race, BMI, HDL, steroid use, and uric acid are the only significant risk factor for the recurrent incidence. So this was the study done to show the influence of lifestyle modification in renal transplant recipients with postprandial hyperglycemia. And it concluded that glucose metabolism can deteriorate in transplant recipient despite passive lifestyle modification advice. And this is also showing that active lifestyle modification benefits high-risk transplant recipient with glucose intolerance and should be aggressively pursued in these patients. Another study was done. It was a national survey from China Liver Transplant Registry. It was aimed to evaluate the etiology and prognosis of NOH within 1 month after liver transplant, and it included 3,339 adult patients, showing that NOH lead to increased morbidity and mortality in liver recipients. There was a close surveillance and tight control of blood glucose, which is desired in immediate post-op period following liver transplant, particularly in those patients with delayed graft function and receiving corticosteroid. So strategic targeting graft ischemic injury may help maintain glucose homeostasis in these patients. So as a take-home message, we are witnessing that efforts are being made to prevent diabetes and to improve immunosuppressive regimes which can contribute to PTDM. But it's really important that the immunosuppression regime should be chosen which is most likely to be effective for successful solid organ transplant and not to minimize the risk of PTDM. Long-term outcomes for the patients are linked first and foremost to the graft survival, and the management in these type of patient is more challenging in comparison to non-transplant setting, because they have a higher risk of fluctuating kidney function. There are varying type of nutritional supplementation that impact diabetes treatment regimes also, and there are large variations in insulin resistance due to changes in immunosuppression, intermittent episodes of rejection, infection, or the need for interval procedure for surgery. And until PTDM, it can be reliably prevented. It will require management much like those with pre-transplant diabetes, and management is further complicated by the greater risk for drug-drug interaction between the immunosuppression agents and the drugs needed to manage other comorbidities like hypertension and hyperlipidemia. But it is really a good news that despite these challenges, the management of the patients with PTDM has greatly improved over the period, and there is also hope for further improvement as more groups are working on better strategies to prevent as well as to treat PTDM for the benefit of all future transplant recipients. These are the differences. With this, I end my talk, and thank you so much for patient listening and for being there and for sparing your valuable time. Thank you so much.
Thank you, Dr. Divya, for an excellent presentation. The questions will be dealt with at the end of the session. We have a time for discussion. Thank you very much. Next speaker is Dr. Navneet Agrawal. His topic is hyperglycemia management in patients on parenteral and formula or enteral feeds. Dr. Agrawal is a chief diabetologist and director in Gwalior Thyroid Center and Obesity Center. He is the CEO and founder of DNA Sugar Clinic and medical director for Novik Healthcare. He is a regional faculty of Public Health Foundation of India and also IDF National Diabetes Educator Program. He is editor in many journals and published many papers in international and national journals. And also he is a reviewer. He's got a Times of India Health Award and many other awards. The list is quite long. So I would invite Dr. Agrawal to start his topic.
Thank you, Chairpersons. Am I audible?
Yes.
Technology team, please allow me to share my screen.
Yes, sir, you can share.
Is it visible?
No. Yes. No. It's
Yes.
fine.
Yeah.
Is it visible?
Yes. Yeah.
Yes.
And I hope I am audible clearly.
Yes.
Okay. So at the outset, I first wish to thank my sincere thanks to the organizing team of RSDI 2021 for inviting me and allowing me to discuss the management of hyperglycemia in patients on parenteral and the enteral feeds. So when we all know that when patient is being hospitalized and patient is either not allowed to take orally or cannot take orally, has to be switched over to the parenteral or the enteral feeds due to one or the other reason. And hyperglycemia is a major challenge in these type of patients when they are being hospitalized to control or to achieve the targets. And so it is a frequent complication of enteral and parenteral nutrition in the hospitalized patients. It has been reported, the hyperglycemia has been reported up to 30% in patients on enteral feeds and almost more than 50% patients on the parenteral feeds. So this is a very huge prevalence. And this is a concern because hyperglycemia in hospitalized patients, as Madam Divya has already told us, that the hyperglycemia has to be taken care of in the post-transplant patients. So the patient, it can affect the patient outcomes. It can affect the mortality or increase the mortality. It can increase the complications in the patient. It can increase the length of stay and overall hospital cost. And it is important that this hyperglycemia not only occurs in patients who are already known diabetic, but it can also be seen in patients who are previously undiagnosed diabetic or didn't have diabetes or were not detected diabetes. And the major challenge is that in patients who are not diabetic or not known diabetic have the higher mortality. So this is the data which shows that the new onset hyperglycemia has higher mortality rates as compared to the patient who are normoglycemic or as compared to the patient who are already known diabetic. There is a number of literature, n number of publications available which shows that the hyperglycemia is associated with the worst clinical outcomes in different numerous settings, being the patient on the total TPN, and the patient on non-cardiac surgery, on the patients of the neurosurgery, patient who were admitted for any critical injury, COPD, or the community acquired pneumonia, and there is an increased risk of mortality risk, pneumonia, or other ICU-associated complications in the patients who were having hyperglycemia during their hospital stay. And the pathogenesis of this hyperglycemia during this nutritional support, whether the patient is on enteral or the parenteral nutrition, is very complex. There is increased hepatic glucose production, reduced glucose utilization, and there is, because of this acute illness, surgery, and trauma, and because there is an increased risk of stress mediators that interferes with carb metabolism and leads to the hyperglycemia. There is increase in the peripheral insulin resistance during stress and illness. And bed rest, when the patient is being confined to the bed, it itself decreases the glucose utilization and leads to the hyperglycemia. And it has been seen that the insulin resistance increases by 7 to 8-fold in patients undergoing any surgical procedure, largely explained by increase in glucagon, cortisol, or the counter-regulatory hormones. And finally, the excessive delivery of glucose or the gluconeogenic substrates by enteral or the parenteral routes in hospital patients can lead to the hyperglycemia. So what are the recommendations for these hospitalized patients? All critically ill patients in intensive care unit settings, we should have a target plasma glucose of 140 to 180, and intravenous insulin is preferred. I'm sure my next speaker, Dr. Suri, will take us through this management of the hyperglycemia in the ICU settings in the critical ill patients. And in non-critical ill patients, Dr. Shah will tell us and will be taking us through the management of non-critical but yet critical patients. So like the targets in these patients, the pre-meal less than 140, random less than 180, and sliding scale insulin should be discouraged. But whenever we are targeting this glycemic window, we should be very cautious about reducing the risk of hypoglycemia. So coming on to the enteral and parental nutrition, we know that these are provided to any patient who's malnourished or at risk of general malnutrition because of the compromised nutritional intake in the context of the duration or the severity of the disease. So enteral nutrition is preferred when the patient has an intact GI absorption. It can be short-term or a long-term. The short-term can be done by the nasogastric tube, nasoduodenal or nasojejunal tubes. Long-term can be done through the gastrostomy or jejunostomy. Whereas the parental nutrition for patients who are at risk of a deranged GI absorption, like the patients who are having intestinal obstruction, ileus, peritonitis, bowel ischemia, or the intestinal vomiting, diarrhea, where we can have a short-term with the peripheral access and we can have the long-term TPN by the stencil access. So there is, in the patients who are in enteral nutrition, the risk of hyperglycemia is there. So continuous or intermittent delivery of calorie-dense nutrients might lead to the hyperglycemia. There is a wide variety of schedules like the elemental, semi-elemental, or the disease-specific enteral formulas are available. And there is increased risk of hyperglycemia because of the use of these formulas if we are not very cautious. So the recommendation that basal insulin should be ideal treatment strategy, or combined basal regular strategies can be optimal. And there is a study which has shown this. This is the data from a patients who were admitted to the acute care hospital. They were on the enteral nutrition for 15 days and they were non-diabetic. 27% patient reported 1 to 3 events of the hyperglycemia, that is blood glucose of more than 200. 6% patient reported 4 to 6 events of the hyperglycemia, and 2% patient reported hyperglycemia 7 or more events. So in patients who are on the enteral formula are admitted in the hospital can have hyperglycemia irrespective of whether they were diabetic or non-diabetic before the admission. So what should be the option of the therapy? Basal plus correction insulin. Basal can be used as a determer or glargine once a day, or the rapid acting insulin with the supplemental basal insulin if needed. Basal plus fixed dose nutrition plus correction insulin. So like if the patients, there we have to keep in mind that the basal is required, nutritional is required, and the correction insulin is required as per the blood glucose monitoring. So insulin and we should take care of the insulin therapy for the coverage, particularly when the tube feeds abrupt slowly, suddenly stop. So we should calculate the total carb calorie which were given in the tube feed, assess blood glucose every 1 hour, and if it is going less than 100, we should supplement it with the dextrose containing fluids, be it D5 or D10. When coming into the parental nutrition, there is a continuous IV delivery of the high concentration of maybe dextrose, the carbs, the calories, the protein, the fats, the amino acids, and there is no incretin stimulation of the insulin secretion. So hyperglycemia is common. Here also the basal insulin should be the ideal treatment along with the nutritional as well as the correction. And this is the data which shows that the glycemia in patients receiving TPN, as we see that the hyperglycemia or the risk of hyperglycemia increases with the duration of the therapy, and this hyperglycemia is directly correlating with the increased mortality in the patients who are on TPN for some or the other reason. And if you see the patient outcomes in different clinical settings or in different publications, it is associated with the glucose levels, the risk of the mortality, any infection, cardiac risk, acute renal failure, septicemia, or any complication, or even the duration of the hospital stay has shown a relatively increased risk in the patients who develop hyperglycemia on the TPN. So in patients who are without diabetes, patient can develop hyperglycemia from the TPN, and it is based on the variety of factors like age, severity of illness, and the rate of the dextrose and the concentration of dextrose in that particular TPN. In individuals with pre-existing type 2 diabetes, not previously receiving insulin therapy, 77% of the patients required insulin to control glycemia during TPN. And insulin doses are required in the higher doses in the patients who are diabetic and are on TPN. So like adding incremental doses of insulin to the TPN is one option, but this may require days to determine the correct insulin dose. So the best advices or the best recommendation that we should use a separate IV infusion, and that brings many of the or majority of the patient under the target. And 2/3 to 100% of TPN, this total number of units, can be added to the TPN bag on the subsequent days if we can calculate the total daily requirement. This is the Society of Hospital Medicine Glycemic Control Task Force recommendations for the patients, the preferred insulin regimes for the different nutrition situations. So patients who are nil orally or patients are on clear liquids, we can use the basal insulin, that's the 50% of the total daily dose. plus the nutritional insulin if required, if the patient, but the patient is on NPO, so there is no need of nutritional insulin. Again, we can use the basal insulin, either glargine or the detamil. If the patient on bolus tube feeds, so like patient is on tube feeding and that is to be in the bolus like 4 hourly or 6 hourly, then we can use a 40% of the total daily dose of insulin as a basal, and rest 60% to be divided in the equal doses as along with the bolus feeds. If the patient is on continuous tube feed, the basal insulin again 40% and the rest of the insulin to be in the divided doses, 4 to 6 hourly depending on the monitoring. And if the patient is on parenteral nutrition, insulin is given preferably parenterally or in the IV infusion. So like there should be a separate insulin drip which allows for the accurate dose finding, and then 80% of the amount determined as a total daily dose using drip is added to the subsequent TPN bags. So the approach to the insulin therapy during parenteral and the insulin feeds, if the patient is non-diabetic, we should monitor, and if the patient is not diabetic or not previously or not detected diabetic, we should be monitoring the blood glucose 4 to 6 hourly, and if after 24 to 48 hours patient has the normoglycemia or patient is not having hyperglycemia, we can reduce the frequency of monitoring. But if the patient is non-diabetic, we should continue the monitoring 4 to 6 hourly, and depending on the patient's plasma glucose, if it is more than 180 or it is between 140 to 180, then we should define what to be the insulin therapy or the insulin dose in that particular patient. If the patient is on enteral nutrition, we should use the diabetes specific formula. As I told, there are elemental formulas, there are semi-elemental formulas, and the disease specific enteral formulas. And we should start the insulin therapy basal as per the weight we can use, or if we know the total daily dose requirement, then we can calculate on the basis of that. And the patients on parenteral nutrition therapy, we should reduce the dose of the dextrose containing fluids, or we should reduce the concentration of the dextrose in those TPN fluids. And then we should mix the regular insulin, either it is 7 to 10 units per 100 gram of dextrose if patient is non-diabetic, or 5 to 7, but it all depends on the blood glucose monitoring. Particularly the patient on TPN patient is critically ill, we should do it every hour. So we know that the insulin is the standard of care and it has a rapid onset of action, it is adaptable and the easy to titrate. So like ideally the insulin has to be chosen, and the basal bolus therapy in the critically ill patients who are on the insul or the parenteral formulas is the therapy of choice. And as far as the targets in the ICU settings, I'm sure Dr. Suri and Dr. Saha will tell us the targets in the critical settings, in the ICU settings, in the non-critical patient. But if this data shows that if we are going very aggressive, we are increasing the mortality. So ideally, we should keep the plasma glucose between 140 to 180, and we are not that will not cause the hypoglycemia in our patients in the critical settings. And what should be done for the transition from IV to the subcutaneous insulin therapy? So we know that if you are stopping the insulin infusion, to maintain the effective blood levels of insulin, it is necessary to administer short or rapid acting insulin 1 to 2 hours subcutaneously before the discontinuation of IV infusion. And intermittent or long acting insulin must be injected at least 2 to 3 hours before discontinuing the insulin infusion. Otherwise, patient will develop hyperglycemia later on. So there should be a stepwise approach to the physiological insulin dosing. Decide if patient is appropriate for that particular protocol and discontinue the oral antidiabetics once the patient is being admitted. If the patient is non-diabetic, we should calculate the total daily dose of insulin, determine the distribution of total daily dose calculated based on the nutrition regime, and reevaluate and adjust the total daily dose based on the glycemic control of previous 24 hours. So how to calculate the total daily dose? There are 3 ways to calculate the total daily dose. Add up the total insulin dose as outpatient if the patient is already non-diabetic, adjusting for the quality outpatient control, current degree of hyperglycemia, current patient status, and various other factors. If we can calculate also the total daily dose on the basis of the weight. If the patient the patient's weight multiplied by N, whereas N stands for if the patient is malnourished, elderly, CKD, on dialysis, or severe liver disease, it is 0.3. If the patient is normal weight, including type 1, it is 0.4. If a patient is overweight, it is 0.5. And the patients who are obese, on the high dose steroids, or other markers of significant insulin resistance, it is 0.6. And otherwise, we can also calculate the total daily dose from the recent insulin infusion requirements, which were the patient was already on. These in the last 24 hours, patient is on the insulin infusion in the ICU settings. So we can calculate the total daily dose on the basis of our patient's profile, on the patient's status, non-diabetic, unknown diabetic, patients on OADs, or patients on insulin. And out of this total daily dose, we can divide the 50%. The 50-50 rule is simple and generally works well. and it should be promoted. So basically 50% of the total daily dose to be given as a basal, with the rest of the 50% administered as on the to cover the glycemic excursion as a nutritional intake. But here we should also keep in mind that other than this, like the basal plus the nutritional insulin, we should have an option of the correctional insulin. If the patient has severe hyperglycemia or patient has hyperglycemia, in spite of this insulin doses, we should be providing or we should be injecting a patient with the correctional insulin dose. So for the prandial insulins, we can choose the rest of the 50% depending on the bolus or depending on the nutritional intake, depending on the amount of nutrition, depending on the calorie or the carb content of that particular nutrition. If the patient is on enteral nutrition, we should divide the dose of the prandial insulin in 3 or 4 meals if the patient is on the, like say, 4 hourly or 6 hourly tube feeds. So the types of insulin which we are using the basal insulin and the rapid acting or the insulin locks in the hospital setting for this. And we should have this the correction insulin in mind, but particularly when the patient is not controlled with the nutritional as well as the basal insulin. The dictum is that, as Madam Deve has already said, that we should be proactive and anticipatory of the insulin or the anticipatory insulin needs we should know, and we should give insulin in anticipation and rather than be reactive to the hyperglycemia. Otherwise, we can increase the risk of complications in our patient. So the unexpected hyperglycemic excursions are common, and the use of correction remains a pervasive and the arguably logical practice. If correction insulin is used, it should be ordered as a separate step, and the dose of scheduled insulin should be adjusted regularly if correction insulin is consistently being required. So we should be increasing on the prandial insulin, we should be increasing on the basal insulins. This is just an example of the basal bolus insulin regime. If the patient is already diabetic, stop all oral antidiabetics, start with the, say, like calculating the total daily dose on the basis of the patient's age, patient's other comorbidities, and the 50% of this dose can be given as a basal and then 50% as a nutritional insulin. Give basal insulin once like the glargine or detamir, or twice, we can, depending on the patient profile and depending on the patient's hyperglycemic status, and then adjust the insulin doses as per the blood glucose monitorings. This is like on the basis of that, what is the level of the plasma glucose? If we are doing every hourly, we can increase or decrease the dose. So to conclude, when the patient is being admitted or in the hospitalized on the enteral or the parenteral formula, we should have a very regular capillary glucose monitoring for patients with diabetes, even for patients without diabetes, if the patient is receiving enteral or the parenteral nutrition, because many of the time the patients are undiagnosed, undetected, or even the patient might develop the diabetes or patient might develop the hyperglycemia due to the stress. And we have seen very commonly in patients during COVID times when patients are admitted with the COVID on the steroids or were given the IV fluids. So the glucose monitoring can be discontinued in patients without a prior history of diabetes if the plasma glucose is less than 140 without insulin therapy for 24 to 48 hours following achievement of desired caloric intake. In patients with a history of diabetes, insulin therapy should be initiated for the patient with the blood glucose more than 140. For those patients without a history of diabetes, insulin therapy is indicated if blood glucose is above 180 or in patients with persistent requirement for correction insulin. And we should know that the reduction in the carb content in order to lower blood glucose concentration, particularly in the patient of the TPM or even in the enteral formulas. Frequent reassessment of the patient's clinical status is critical, not only to allow maintaining adequate glycemic control, but also prevent the hypoglycemia. That is more important, that we should be correcting hyperglycemia, but we should be avoiding hypoglycemia because that can also be dangerous. And yes, the further studies are needed to determine the safe and beneficial glycemic targets or the formulas wherein we can prevent the hyperglycemia in critically ill patients who are admitted and are on the enteral or the parenteral formulas. Thank you very much for the patient's hearing. Thank you very much.
Thank you very much, Dr. Agrawal, for finishing your presentation well in time, and it was very informative. We will have the questions, if at all, any later. We will move on to the next speaker. Yes, the next speaker is Dr. Sandeep Suri. He is going to talk on topic is hyperglycemia management in ICU. He is a gold medalist from CMC Vellore and recipient of Diabetes Awareness Award from Diabetes India, President of Indian Podiatry Association, Haryana, and regional faculty of CCE, BDEM, and etc. He has published several articles in various journals, and he's also conducted many trials. So I hand over the mic to Dr. Suri. Please start your presentation.
Thanks, ma'am. Yeah. Good evening, friends. At the outset, I must thank from the core of my heart, and rather I must congratulate our Honorable RSSDI President, Dr. Bansi Sabu, sir. Can I share my screen? Can I share my screen now? Okay, fine.
Yes, sir, you can share.
Sure. So let me, my slides are visible?
Yes.
Okay, ma'am. Thank you. So I must congratulate our Honorable RSSDI President, Dr. Bansi Sabu, sir, and our Dr. Vasant Kumar, sir, and our Honorable Secretary, Dr. Sanjay Agarwal, sir, and for making me a part of this fantastic academic feast. And my sincere thanks to respected Chair, ma'am, for the kind words. Friends, in the next, say, 20 minutes or so, I will be talking about management of inpatient hyperglycemia and focusing on critical care aspect of management of hyperglycemia. And we have just enjoyed the listening of Dr. Divya and Dr. Navneet, and many things has been touched upon for critical care scenario. And my focus will be more on ICU management, and I will be going to put more focus on that aspect. Plus, I will be giving you some clues where the pitfalls occur, or you can say where inadvertent mistakes occur. We commit something wrong during our hospital hyperglycemia management in ICU scenario. So these are my disclosures. Nothing to disclose, only to say that presentation is based on scientific evidences from various guidelines, national and international, and there is no conflict of interest and some sort of, you can say, that experience we have added to it. Now, friends, if we look at the Indian scenario of diabetes and hospitalization, there are two retrospective studies. One is Kapoor et al. Study and another one is Vasant et al. Study. Kapoor et al. Study was published in the Indian Journal of Medical Research in 2017, and whereas Vasant et al. Study was there in Journal of Diabetes in 2012. These are two retrospective studies. As diabetes gets complicated and the severity of complication increase, the people with diabetes, they spend more and more time in hospital for one or other reason, and more time in hospital is spent and more time is spent with health related issues, and the cost of treatment simply escalates like many folds. Now, diabetes accounts not only to the number of admissions that increases to 9% per se due to diabetes. It is not only the number of admission that gets increased somewhere around 8.2 or 9%. There is a 2 times higher mortality rates in patients with diabetes at admission compared to those patients who are not having diabetes at the time of admission. And this mortality is, you can say, around 40%. It is caused by your vascular disease. That means it can be myocardial infarction or stroke. 35% it is due to infections, progression of infection to sepsis and multi-organ failure. Rest 9% can be due to renal acute kidney injury or renal failure, and then 9% due to malignancy. So we can infer one thing, that hyperglycemia in inpatient scenario is associated with adverse outcome and twice increased mortality. Now, if I must say that it is not tough to understand here, courtesy COVID first and second wave, we have definitely appreciated, we can all appreciate that at admission, hyperglycemia is associated with adverse outcome. So if it is less than 200 milligram per DL at the time of admission, mortality is 10% and complication rates are 20%. Whereas just over 200, if you add 10, 15 milligram more than 200, it will be 15% as a mortality, and the complications rate grow by 30%. So the risk in hospital complication and death are significantly higher in those patients who are admitted with blood glucose at the time of admission more than the 200 milligram per deciliter. But this is not a criteria to diagnose hyperglycemia. It is just a random blood sugar value of 200 milligram per DL. Now, to define hyperglycemia in hospitalized patient, a random blood glucose concentration of 7.8 millimoles per liter, or it can be 140 milligram per DL as per the ADA and American Association of Clinical Endocrinology guidelines. But these patients who are having hyperglycemia in hospital, they are a heterogeneous group of patients. They are having different glucophenotype. Previously diagnosed diabetic patient can be there, where diabetes is diagnosed prior to the admission. You can have previously undiagnosed diabetic patient. Just at the time of the admission in the hospital ICU, they were diagnosed as a diabetic patient. And at admission, fasting plasma glucose, RPG, and HbA1c, they are fitting into the criteria of diagnosis of diabetes. And there are good number of patients which are having stress hyperglycemia. That means their fasting plasma glucose is 126 milligram per dl. Random blood glucose is more than 200 milligram per dl, but HbA1c value is less than 5.7%. And post discharge, they go into normoglycemia. So that this message is that any patient having random blood sugar value of more than 140 in hospital, specifically in ICU, should undergo HbA1c testing, so that we can dichotomize, or you can say we can have them segregate between whether they are previously undiagnosed diabetic patient or they are having stress hyperglycemia, because that has got deep implications. Consequences are very, very different in between these two patients. All these three have different consequences and implications. For the prevalence of hyperglycemia in critical illness patients, we have Plummer et al. Study. It was published in Intensive Care Medicine 2014. And this shows that around 50% patients, they have got critical illness associated hyperglycemia. 22% patient, they are already recognized case of diabetes, whereas 5.5% patient are unrecognized patients, the unrecognized diabetes patient. So overall, if you sum up or total, it is around 75% patient who are having hyperglycemia related issue in a critical care illness patients. So only 22.7% patient, they have got normoglycemia. So hyperglycemia in ICU is a very frequent in our setting. And this hyperglycemia is associated with increased mortality in critical illness patients. And the tipping point, it starts just at 80 to 90 milligram per dl, where the mortality is just 9.6%. And if you go from 100 to 200 milligram per dl, it is 2 times higher. If you go from 200 to 300, it is 3 times higher. And above 300, it is 4 times higher, and it is around 45% mortality. You can just see from this cartoon. So that means 45% mortality, half of your patient, nearly half of your patient will die if you don't do appropriate management in hyperglycemia related to critical illness. Now, another important finding, very interesting finding by Umprez et al. It was published in Journal of Clinical Endocrinology and Metabolism in 2002. Mortality rate is highest among newly diagnosed hyperglycemic patients. Even it is 3 to 3.5 fold higher than those patients who are known case of diabetes. And this newly hyperglycemic patients can have hyperglycemia due to stress, or you can call stress hyperglycemia, or they are previously unknown case of diabetes, first time diagnosed as diabetic during ICU stay, during ICU admission. And we will look into this, why this is there, why the cause they are having higher mortality. Now, what about pathophysiology, or you can say pathogenesis of hyperglycemia in hospitalized patients? There are 2 key components to remember. Number 1, there is either absolute or relative insulin deficiency. Secondly, there is increased counter-regulatory hormones, glucagon, catecholamines, cortisol, growth hormone, all they are escalated. Plus, there is inflammatory cytokine storm. You are all aware of this during COVID. Interleukin 6, TNF alpha, 2 are to be remembered. They are very highly significant, important insulin resistant cytokines. They just block the efficiency of insulin everywhere. And then you can have exogenous factor, as Dr. Divya and Dr. Navneet has already told you, IV dextrose, glucocorticoid, parental nutrition, enteral nutrition, all they play with hyperglycemia, all lead to hyperglycemia, added to inflammatory cytokines. Then there can be endogenous factor, there is insulin resistance, and this insulin resistance leads to increased lipolysis. Fatty acids going into the circulation, glycerol going into the circulation, going to liver, there is increased glucose production, increased hepatic gluconeogenesis, there is decrease, also there is glycogenolysis, there is increased glucose output from the liver. Then there is another, you can say, raw material that is coming from the protein breakdown from the muscle due to catabolism. It is amino acids and lactate, which go to liver. Again, there is increased glucose output and production from the liver. Plus, there is decreased glucose utilization at the peripheral tissue, at the muscle specifically. All these lead to hyperglycemia. Hyperglycemia due to osmotic issues, it can lead to circulatory and electrolyte effect, again increasing your insulin resistance. Volume depletion, hypoperfusion, electrolyte loss, and acid-base disturbances. And there can be tissue-related effect. There can be cellular damage, reduced nitric oxide production. I nose goes up, E nose goes down. Then superoxide generation. Then there is endothelial dysfunction, platelet activation, immune dysregulation, mitochondrial distress, mitochondrial injury, endoplasmic reticulum stress. They are the two key factors that happen, ultimately leading to progression of sepsis, multi-organ failure, and death. So we can have a complex interplay of both exogenous and endogenous factor, leading to vicious cycle of hyperglycemia, culminating into sepsis, multi-organ failure, and death. Now, why this stress hyperglycemia? Should we treat or we should not treat? Yes, we should treat. Earlier, it was thought that it is an adaptive and protective response that to divert the fuel to the stress, hypoxic, inflamed tissues, especially immune tissues and your nervous system, but it backfires. Also, there is down regulation of glucose transporter in your routine diabetic, old known diabetic patient, and at cellular level, there is decreased glucose transportation due to chronic hyperglycemia. But this adaptation doesn't happen in your stress hyperglycemic patient, and there is increased unchecked glucose ingress, that is also glucotoxicity. There is excessive counter-regulatory hormone secretion more in stress hyperglycemia in comparison to known case of diabetes. Higher tissue and circulatory concentration of TNF-alpha and interleukin-6 has been reported in stress hyperglycemia in comparison to already known case of diabetes. So that's why we find 3 to 3.5-fold higher mortality in ICU patient with stress hyperglycemia versus known case of diabetes. So we should treat it appropriately. But there are certain issues, certain barriers to glycemic control in hospitalized patients, as has been already alluded to you. Diet can be one factor. There can be variable meals planning, variable meal timing. NPO orders can be there, use of enteral and parenteral nutrition, concomitant use of medication like glucocorticoid, certain antibiotics, and there is potential drug-to-drug interaction. There can be physiological factor per se. There is increased cytokine storm or cytokine inflammatory cytokines, acute illness-related issue. Then there can be physiological stress. There can be psychological stress. There can be impaired renal function. All these are the potent barriers to glycemic control in hospitalized patients. So to take care of these barriers and manage hyperglycemia in critical care illness patients appropriately, we have to have certain principles. Number one, once admitted to hospital, patient with hyperglycemia should be managed using either IV or subcutaneous insulin regimen. And IV insulin regimens are the best because of their rapidity of action, their predictable response, and their smoother control, and their safer control and easy titration. And these aspects are very important when you talk about critical illness. Most treatment algorithms, they recommend discontinuation of oral antidiabetic drugs and initiation of insulin analog or regular human insulin. Insulin is the preferred agent for glycemic control in hospitalized patients. And the goal of insulin therapy is to reach acceptable glucose target in the shorter duration of time with the minimal incidence of hypoglycemia. Now, two other important factors that are very important, inherently complex factor in inpatient scenario: blood glucose, insulin requirement fluctuate with acute stress illness and surgery. Even simple bandages of burns or debridement, or you can say removal of abscess, can clearly change your whole glycemic factor, and your insulin requirement can go up and down with simple procedures. Transitions across specialties and inpatient location, going for MRIs and requiring other specialties, then patient can have different requirements, or insulin infusion can be off due to these transitions. Now, very important to know what target we should achieve. These are earlier debatable. Now, most of us are settling down, starting threshold for no higher than 180 milligram, 114 diagnosed patient of diabetes, and 180 who are not diagnosed case of diabetes. Once IV insulin started, the glucose target should be maintained between 140 to 180. So we should not err. We should not sway between hypo and hyperglycemia. Lower glucose target of 110 and 140 may be appropriate in selected number of patients, selected group of patients. And what are these patients? These are cardiothoracic patients, cardiothoracic vascular surgery, bypass patients, neurosurgical ICU patient, IC bleed or intraspinal bleed. There can be stroke patient which require stronger, better control of glycemia from 110 to 140, burns patient, sepsis patient, surgical ICU patient, where there is a maximum documentation of strict control of targets of 110 to 140, even less than that. So the targets, usually acceptable targets, recommended targets by American College of ADA 2021 is 140 to 180. Acceptable 110 to 140, but don't go too low to avoid hypoglycemia at all costs. Now, importantly, there are selected, these are important landmark trials, but they randomized controlled trials, which has been done in intensive glucose management, showing no benefit with intensive glucose treatment. And these are heterogeneous populations studied here. Some are done in surgical ICU patients, some are done in medical ICU patients, some are done in operating room scenario. But you can see there are different criteria, blood glucose targets different, blood glucose achieved different. But most of these, they say that intensive glucose treatment or targets, they are rather more harmful, less benefit, rather they are more harmful. And last one is NICE sugar study, 2009, around 6,000 patients, 3,000 in each arm, done in ICU scenario patient. Two targets were given. One was intensive target, another was in conventional target. Intensive target was 81 to 108, whereas conventional should be less than 180. And the target achieved in intensive arm was 115, and whereas conventional arm was achieving around 115 milligram per DL. And we looked at 90-day mortality, and it was 10.6% relative risk reduction favoring conventional treatment in comparison to intensive treatment arm in NICE sugar study. And this is that study which I am showing you here. So all-cause mortality at 90 days was less in conventional group control, whereas in comparison to intensive control patients. And look at the severe hypoglycemia. It was, you can say it is the 6-fold higher in intensive glucose control arm, 6.8% in comparison to just 0.5% in conventional treatment arm. So clearly advocating that conventional targets of less than 140 to 180 are acceptable to us. So this was depicted from NICE sugar trial, and most of the standard guidelines, both national and this RSSD guideline, and also our other international guideline, ADA, CDA, and Society of Critical Care Medicine, they are clearly now settling to this target in ICU of glucose target of around 140 to 180 milligram per DL. We have many IV insulin protocols. How to achieve this? Go by the insulin infusion, and we have got many insulin infusion protocols. But the most important line is that the exact protocol is probably less important, whichever you are following. It is more important that it should be, its presence in an institution and adaptation to the individual hospital needs. What does this mean? This means that ideal insulin protocol should be easily ordered. It should be signatured only. It should not have any calculation, not much calculation. It should not be computer based. Effective gets to target as early as possible. It should maintain blood glucose within a defined target range over several hours. It includes an algorithm for making temporary corrective increments or decrements in infusion rates. It should be safe. That means it should lead to minimal risk of hypoglycemia. And directions for treatment of hypoglycemia should be included in this protocol. It should be easily implemented, can be executed by nursing staff at their own with response to a single physician order. So it should be very, very simple to be understood by all our hospital staff and ICU medical officers. So we can adopt any protocol, but most of us are what we follow in our hospital, and I'm sure that most of us are following this updated ELA insulin infusion protocol, and it has got 3, 4, 5 steps. Step 1 is we start with insulin infusion, and how we make insulin infusion: we mix 1 unit regular human insulin per 1 ml, 0.9% normal sodium chloride. So this we make a concentration of 1 unit is equal to 1 ml of the saline. We administer via infusion pump in increments of 0.5 unit per hour. Now, how much should be the infusion rate and how much we should start? It is the rule of thumb which can be used. Divide initial blood glucose by 100 and round to the nearest 0.5 unit for the bolus and the initial infusion rate. So that means if you have got 325 as the initial presenting blood sugars, you divide by 100, it is 3.25, round up to 3.5. That means IV bolus 3.5 unit plus you start an infusion of 3.5 unit per hour. So it's very easy to understand. But importantly, priming of this tubing, priming of with this most of time this is forgotten. Priming with 20 to 30 ml insulin solution has to be done because the polyvinyl chloride or ethyl vinyl acetate or polyethylene plastic tubing, they have got absorption for insulin. So to saturate these insulin absorption sites for two plastic tubing walls, 20 to 30 ml insulin solution has to run down, and then you can start the fresh infusion. You can start the proper rate. So before that, you have to prime the whole of your tubing. And every time you change the tubing, you have to re-prime it again and again. And the subsequent rate adjustment has to change in infusion rate are determined by the current infusion rate and the hourly rate of change from the prior blood glucose level. So how to do it? This is the step 2. So we started with insulin infusion, we primed it, and we know the how to start, and we gave the bolus also. Now how to look at the how to do for the changing increment or decrease the dose. So whether the blood sugar is worsening or it is static or it is decreasing or improving appropriately. Now what is the appropriate improvement? It is 40 to 75 milligram per deciliter fall every hour. If you are sustaining this, then you are doing okay. You are on the right track. You can continue with the same dose. No drip change is required. But if there is an increment, suppose you are not able to achieve this, you are having worsening. That means you have increased the blood sugar by 50 to 75 milligram. Then you can have delta 1 delta increase. That means 1 or 2 unit increase in the basal rate that you can start. If you have got more than 100 increment, suppose you started with 300, now it is 500. That means you have to double the dose which you are using. You are using 3 units per hour. Now you have to go to 6 units per hour. So 2 delta change has to be given. Plus there is a trial which shows that you can even give another bolus also. You can repeat the bolus depending upon that blood sugar value. So this can be also given. So this is how. And suppose if you are decreasing too rapidly, it is 100 milligram per dl decrease per hour. So then you can decrease the dose, and make it 75%, make it 50% decrease. So this is very easy to do. And it is, once it is taught to your staff, or you can educate your medical officer, then it is very easy to do. But this is how the delta rate that can be changed depending upon the baseline infusion rate that can be changed, and also the how much increment is there, whether it is static or whether it is decreasing or decreasing in an appropriate way. But also look at the signs of ketosis in your patient. Never miss these signs of ketosis in your patient, because there can be worsening of saturation, there can be worsening of acid-base plan, and there can be electrolyte changes, and anion gap can also be looked at. So these are the issues we can plan for looking for the ketosis. And then if that is there, then you can go for the ketosis protocol also. Now, watch very diligently. Watch very diligently for hypoglycemia, because not only you should treat hyperglycemia, you have to avoid hypoglycemia, because hypoglycemia per se is detrimental to already stressed and under protected tissues and organs. So what you do, you give 25% dextrose, and this is the most common mistake. Most common mistake, inadvertently done. You run down the whole bottle of 25% dextrose, and that is 100 ml of 25% dextrose. That basically it is 250 milligram per ml. And if you run down 100 milligram of dextrose, and it is most commonly done by your staff, inadvertently done, and there can be rebound hyperglycemia. So the safe zone is between 100 to 150 if you're treating for hypoglycemia. Don't go away above 150 at all costs. Try to do it. And most of the time, in my scenario, and I always advise my staff or senior person should stand at the side of the patient on the bedside, as you do for the thrombolysis in your myocardial infarction patient, acute MI patient. Stand there, give appropriate amount of 25% dextran. And what is this appropriate amount? You require only 15 to 20 gram of glucose to increase by 30 or 40 milligram of blood sugar. So if you started at 60 or 70, in hospital scenario, it is rarely go below 60 because you are checking it regularly. So you require around 20 to 25 gram of glucose, and that is by 50 to 60 ml sufficient to put patient into the safe zone of more than 100 milligram. So if there is a recurrence of hypoglycemia, even by altering the insulin infusion dose, then you can repeat it, but you have to recheck the blood sugars after 15 minutes if your patient is having symptoms of hypoglycemia. And what are the symptoms of hypoglycemia that you should look? And because your patient may be on beta blockers here, patient may be unconscious, diaphoresis, sweating is the most important, and irritability. These are the two most important factors, symptoms you should look in your patients who are even comatose. They can have diaphoresis. Even patient on beta blockers can have diaphoresis. You may not have your heart rate going up and your swings in hemodynamic, but diaphoresis will be there even those patients who are on beta blockers. So sweating, profuse sweating, specifically on forehead and on the back, they are the most important thing that you can say that your patient is symptomatic for hypoglycemia. For symptomatic patient, 15 minutes checking, and for asymptomatic patient, 30 minutes repeat testing. And if you require the dose still, then you can increase, again, give that bolus of 25% dextrose. Now, how to monitor? Point of care blood glucose monitor should be used in that is being used in most of our ICU setting. But the suggested protocol is 1 hourly interval initially, then 2 hourly if you have got 3 consecutive readings falling within the desired target range, and 4 hourly if your target range is maintained for consecutive 24 hours, and then you keep on increasing the gap. But you have to revert back if you have got hyperglycemia. Now, monitoring, as again, now it has been technology entering in our ICU like CGMS and also flash glucose monitoring can be used. There are more preferences building for these type of modalities which can be used. But importantly, doubtful accuracy, there is a lag period. Interstitial fluid and blood sugars, they have got lag period. Rapid hemodynamic swings can be in doubtful accuracy for these. Interference with paracetamol, specifically in COVID, more than 4 gram per day, then vasoconstriction. Also, point of care devices like glucometer can have doubtful accuracy in vasoconstriction, in digital oligemia, temperature changing in ICU, PCM, aspirin, vitamin C infusion, specifically in COVID patient. Then there can be doubtful accuracy even in your glucometers also. But the best way is dedicated arterial or venous port for acid blood gas analysis and electrolytes that can be used for blood sugar analysis, or subcutaneous or continuous subcutaneous sensor placed like your CGMS. Now, whether we should use other type of analogs that can be used in infusion, yes, you can use regular human insulin most commonly, but aspart, fiasp, and lispro, they can also be used as an infusion. And there is a study from Udvardia et al. They showed that if you use fiasp, aspart insulin, there is better and rapid achievement of blood sugar target with least amount of hypoglycemia. And they are all recommended. And now, transition from IV insulin to subcutaneous insulin, this is again sometimes sometimes it is a faulty approach that leads to rebound hyperglycemia in our patients. So you have to calculate total daily dose, and for total daily dose, either you take 24 hours or you take 6 to 8 hours of stable dose, then you multiply by 4. This will give you total daily dose, and for this you can shift your patient to subcutaneous insulin. But before stopping your insulin infusion, give a 2 to 3 hours of overlap. Give NPH or basal insulin analog, preferably preferable to regular human insulin and preferable to your rapid acting insulin analog. NPH and basal insulin analog are preferable overlapping insulin dose to be given 2 to 3 hours before stopping the IV insulin, and the dose to be for use for subcutaneous injection. Further, total dose should be taken 60 to 80% of total daily dose that should be used for further use, and 50% should be taken as basal and 50% should be taken as boluses. So this is how you shift your patient from IV insulin to subcutaneous insulin. So the key take-home messages for my talk: hyperglycemia in ICU is very frequent. Around 50% of your patient will be admitted with hyperglycemia in your ICU. Hyperglycemia is a potent prognostic marker, rather it is a driver for adverse outcome with 2 to 3-fold increase increase in morbidity and mortality. IV insulin infusion is the mainstay of treatment of hyperglycemia in ICU. General targets to be maintained between 140 to 180. Selected patients, I alluded to you, 110 to 140, especially in CTVS, sepsis, and burns patient. Frequent monitoring is the key, and avoidance of hypoglycemia is the most important thing that has to be done. So I will stop here, and I will thank you all for the patience here. Hello, Abhijit, I have done with my presentation. Hello.
Yes, sir.
Yeah.
Yes, sir. Hello, Asha ma'am.
Yes, yes. I am here. 1 second. I was logged out for a moment. Yeah. Hello. Hello. Can you hear me?
Yes, ma'am.
Yes, yes. I am sorry, there was some technical hitch. Now, thank you, Dr. Suri, for a very nice presentation. Now, the next speaker is Dr. Navneet Shah. He is going to talk on management of patients' hyperglycemia management in non-critical care setting, not critical yet critical. So that I was also a little confused about the topic, but since the step down management in the step down care, he is a MD from Gujarat University and ex-professor and head of the department in NHL Medical College. He is a director of Department of Diabetes and Endocrinology in Sterling Hospital, and he's also honorary diabetologist to Her Excellency Shri Governor of Gujarat. Contributed chapters and papers in many books. Ex-president of Ahmedabad Physician Association. Also ex-member of Gujarat Medical Council and Dental Councils, and he is received Vishwanath Oration and Jimakon Oration at Himatnagar. Also Jason Bapa Oration, awarded DN Mehta Oration, so multiple oration and multiple councils. So I would invite Dr. Navneet Shah to start on his talk.
Thank you, Chairperson, for very kind words. And at the beginning, I would thank the organizing committee of RSS, Dr. Bansi Sabu, Dr. Vasant Kumar, and Dr. Sanjay Agrawal, and all other members. So thank you very much for this. And it is such an odd time here that I'm in USA, and right now it is morning 6 o'clock. So you can understand. And after listening to the three stalwarts in the field of diabetes management in ICU and other things, I'm going to speak about some odd topic, that non-critical care setting, which is also critical. Hope I'm audible, correct?
Yes, yes.
Right? Can I share my slides, please? My slides are visible now.
Yes.
Okay. So it is the hypoglycemia management in not critical care setting, not critical but critical. So there are various agenda here, and because many of the things have been talked by Dr. Divya, Dr. Navneet, and Dr. Suri, I think my task will be less, and I also would be able to spare some time for question answer session. So these are the outline. Now all of you know that diabetes and stress hyperglycemia are common in hospital settings. It is generally accepted that hyperglycemia and hypoglycemia should be avoided in hospitalized patients. And for the past 15 years, insulin therapy has been considered the cornerstone of the management of patients with hyperglycemia in the hospital. However, the practice varies widely internationally and locally, and the findings from several randomized controlled trials have shown that non-insulin drugs can have a role in the management of patients with type 2 diabetes. So if we really summarize the previous three talks, then what is important is that I think the patients, when they are admitted, whether they are diabetic or non-diabetic, we should do a blood sugar at the time of admission along with HbA1c. Likewise, now we are also recommending all patients who are undergoing solid organ transplants, and whether they have no history of diabetes, but they should have baseline, even baseline C-peptide, HbA1c, and sugars are very important. And Dr. Sandeep and Dr. Navneet, they both have shown that the newly discovered hyperglycemia patients are having highest mortality in comparison to patients without diabetes and patients with non-diabetes. So that is a very important point which we must keep it in mind. The growing prevalence of diabetes and increased longevity escalate the burden of inpatient dysglycemia, affecting nearly all areas of hospital care. Suboptimal glycemic control in hospital is associated with adverse clinical outcomes and prolonged length of stay, delayed wound healing, and all other things are known. Inpatient hyperglycemia represents a considerable portion of national and international healthcare expenditure related to diabetes, and there are growing concerns about the safety and quality of inpatient hyperglycemia management as staffing levels are being stretched while the prevalence and complexity of the cases increase. So numerous observational studies have shown that hyperglycemia increases poor clinical outcomes. Treatment of hyperglycemia is associated with decreased mortality and morbidity among the hospitalized patient. However, hypoglycemia is also equally important, and which has been stressed and focused often in this symposium. Therefore, guidelines recommend avoiding iatrogenic hypoglycemia, and thus hospitalized patients with diabetes require glycemic control with low glycemic variability to prevent both hyperglycemia and hypoglycemia. All of us heard that the major guidelines, including the NICE guidelines, now recommend the safe glucose level between 140 milligram to 180 milligram per deciliter without hypoglycemia in non-critical hospitalized patients. Glycemic variability is also very important. We should keep it in mind. Most instances, hospital setting, insulin is the preferred treatment of glycemic control that is recommended that most critically ill patients receive insulin infusion therapy. That is what Sandeep has said. And in non-critically ill patients receive basal bolus therapy. However, the basal bolus regimen is also associated with good control, but there is an increased high risk of hypoglycemia. And I'll just show you some of the studies where it has been mentioned. Hypoglycemia has been reported in 12 to 32% of the patients with type 2 diabetes in general medicine and surgery who were treated with basal bolus insulin regime. The use of oral anti-diabetic drugs is generally not recommended for patients admitted in hospital because of paucity of data on their safety and efficacy. As such, the safety and efficacy of non-insulin anti-hyperglycemic therapies in hospital settings are areas of active research. Current scenario, diabetes technology is rapidly evolving. The preliminary data have shown that feasibility for inpatient use of continuous glucose monitoring devices and automated insulin delivery system has been taking place very rapidly. Of course, not in our setup, but in Western setup. And the COVID-19 pandemic has shown us that use of technology in the hospital setting is very important, because many a times in this situation, patients have to be treated remotely from the station without touching them, or doing the frequent blood glucose pricking and other things are not possible. So the recommendations are, despite paucity of good quality evidence in inpatient management of diabetes, several international guidelines were developed to guide practice. Because of the evidence has often been inadequate to determine how best manage different aspects of inpatient care, these guidelines often have a large element of consensus-based medicine, and with recommendation from the medical societies that often reach different conclusions, with the most notable differences related to glucose targets and use of non-insulin glucose lowering drugs. International variations practice differ. Although the use of insulin therapy in hospital is common in US and Canada, the use of non-insulin agents such as metformin and sulfonylureas are relatively common in other countries like UK, India, and Israel. So what are the pharmacological management of hyperglycemia? So as mentioned earlier, the continuous insulin infusion therapy is the preferred regime for ICU patients with hyperglycemia, including those without a diagnosis of diabetes, and for most patients with hyperglycemic crisis. But one point is that frequent monitoring of blood sugar, which has been mentioned here, that if patient is conscious and if you are going to do 1 hourly blood sugar monitoring with the glucometers, the pricking of fingers are very difficult on long run, and this may not be a question of a day or two, but couple of days, then that makes a little inhuman in doing this frequent monitoring. US and UK professional societies have produced algorithm for intravenous insulin management, which has been mentioned earlier, and generally patients with moderate to severe diabetic ketoacidosis should be treated with continuous IV insulin infusion. So one point where I would like to say that all algorithm should be according to your infrastructure, your facility, your staff, and your doctors on duty. Then and then you can do a better algorithms and better management of these things. Another important thing which we usually should keep it in mind, that hypokalemia is common about 50% during treatment, and therefore careful monitoring of potassium concentration is recommended, and a systemic assessment of modification practice is warranted. The ischemic event patients, rapid control of glucose values might be warranted in view of known potential harm associated with hyperglycemia. However, attempts to lower glucose concentration intensively have not shown additional benefit and might increase the risk of hypoglycemia. And so, as mentioned earlier, targeting a lower glucose range is opposed to a conventional range of 140 to 180 milligram may improve the clinical outcomes in the cardiac settings, except in certain CABG patients, you may have a little tighter control. You can still use a computerized algorithm that minimize the risk of iatrogenic hypoglycemia, because many factors are taken into consideration for a computerized algorithms. as earlier mentioned, the transitions from the patients who are close to discharge, we must remember that those patients who were on basal bolus therapy, whether you should continue the same treatment or whether you should switch over to the oral drugs which patients were before admission. All these things will depend upon the type of the patient you are treating. And most of the times, those patients who have undergone surgery or those who have recovered from COVID or those who have a wound healing pending and all this, I think it is always better to continue insulin, because this insulin is an anabolic hormone, not only controlling the diabetes, but it also improves the patient's health. So once patients are off the hook from the doctors, like they have no dressing required, no other things are required, patient's diet is full, activity is full, then you can change over to the other previous regimes which patients are taking. So this is an algorithm which is self-deprecatory. You can see here that mild, moderate, and severe hypoglycemia, how will you deal with which whether it is mild hyperglycemia, you can consider low dose basal insulin with OAD or OAD. If it is a moderate hypoglycemia, basal insulin with or without correction, nutritional insulin. And you can start with low dose to depending upon the patient's obesity, insulin resistance, and kind of illness. And especially remember one thing, when patients are admitted, they will have another things like they may start with steroids, they may have surgical stress, they may have drugs like antiretroviral therapy, or they are on vasopressors, which are all, most of the times are anti-insulin and will need the requirement of insulin. So you must remember. And those patients who are severe hyperglycemic, above 300 milligram range, these patients are ideal for basal bolus therapy. As mentioned by Dr. Sanjay, critically ill patients or hyperglycemic patients, you need to do medical and surgical patients 100 to 180, continuous infusion, severe DKA, again you need a continuous infusion, mild to moderate DKA, you can have subcutaneous insulin with DKA protocol and other things which have been mentioned often. Various regimes with human analogs insulin formulation administered subcutaneously have been tested in non-critically ill patients with type 2 diabetes. So non-critically ill patients can have point of care glucose monitoring, and they may have basal plus boluses or basal plus boluses or premix insulin for the control of diabetes if they are predictable in their diet. Insulin regime, subcutaneous sliding scale insulin or the correctional insulin used to treat hyperglycemia after it has already occurred is widely used in some of the hospitals despite the condemnation by many clinical guidelines. The use of sliding scale insulin is associated with clinically significant hyperglycemia in many patients, and its use has been discouraged. Findings from the randomized trials have consistently shown better glycemic control with a basal approach than with sliding scale insulin alone in patients with type 2 diabetes. And the basal bolus approach was associated with a reduction of complication estimated with a composite outcome that included post-operative wound healing, pneumonia, bacteremia, acute renal and respiratory failure are the various things. So insulin therapy and hypoglycemia, which has been very elaborately discussed by Dr. Sandeep, so I would not go into the detail of these slides, but we must remember that hypoglycemia is very detrimental to the patient's outcome, and we must at any cost prevent the hypoglycemia. So our target should not be 100 to 140, but we must keep the target of 140 to 180 in non-critically ill patient for avoidance of hypoglycemia. If your target are 100 to 140, then you are more vulnerable to develop hypoglycemia than in comparison to 140 to 180 milligram target per deciliter. The non-insulin drugs, they are like metformin, sulfonylurea, thiazolidine. So out of all these things, many times when it is difficult to control diabetes with the only insulin regimen, and especially in obese patients, we may use metformin. Sometimes we use a small dose of sulfonylureas also, but usually we don't use thiazolidine in acute care setting because this drug takes longer time to act and will not have its effect. SGLT2 inhibitors obviously are not used for acute care setting because of various drawbacks like euglycemic ketoacidosis, urinary tract infections, and other things. DPP4 inhibitors, they are roughly reasonably safe, but then there are issues regarding the heart failure, so they are not good. And there are now newer studies which tells us that if patient can tolerate GLP-1 receptor agonist, you can still use GLP-1 receptor agonist, and there are various papers, especially the one with dulaglutide has been used in the acute care setting in non-critically ill diabetic patients. So there are various trials which you can see here, and I'm not going to return this just for the sake of mention that there are various trials which are seen here, and they tell us that the difference between the basal bolus versus premix, whether NPH and other things are seen, and from that every trial has got some message which we can, which you can see later on. In special situations, we have seen as ICU situations with parenteral nutrition, like hyperglycemia is common during parenteral and enteral nutrition, and data from a study, patient receiving parenteral nutrition suggests benefits of admixing short-acting insulin into the parenteral bag as opposed to subcutaneous insulin administration. So it is better if you calculate the calories, if you know the total daily dose, then you can add an appropriate amount of short-acting insulin in the bag, which may be more helpful in controlling the diabetes in this situation. For patients with diabetes and those without diabetes with sustained hyperglycemia on enteral nutrition also, you can think of giving basal insulin, which could be isofen or datamir or glargine, along with short-acting insulin with the boluses. And now we have very fast-acting boluses. So if you can calculate the feed with the calories of 300, 400 or 4 or 5 feeds if you give, then you can give short-acting insulins like aspart or fast-acting aspart along with the meals in this situation. So again, you know, glucocorticoid use is a very common problem, whether in a transplant patient or whether patients having collagen vascular disease or so many things where you need to use glucocorticoids or a part of chemotherapy. So these drugs produces with various mechanisms, hyperglycemia, which has been mentioned earlier, hepatic glucose output, insulin resistance, poor uptake by the muscles, and all those things are responsible. And it has been shown that it is better to give NPH insulin before breakfast, followed by monitoring, point of care monitoring, and give boluses before lunch and dinner after monitoring the blood sugar values. So this can be of help, and we can have good glycemic control in this situation. All perioperative management, we have seen that oral anti-diabetic drugs are usually not preferred during perioperative management. In perioperative management, we have seen that whether it is a major surgery or a minor surgery, long bed rest is required, long NPO period is required, or whether patient is undergoing general anesthesia or major surgery, then you have to put those patients, especially type 2 diabetic patients, on insulin infusion therapy. Sometimes in type 1 patients, you may need to give IV glucose with insulin as a part of nutrition plus insulin coverage along with insulin, along with potassium. So perioperative management is very important, and we must keep the diabetes under control during 140, 180. Under anesthesia, at any cost, hypoglycemia should be avoided. So the probability of keeping the sugar values above 150 milligram would be better than these things. And lastly, diabetes technology in the hospitals, which still yet to come in a very big way, but we must keep these things in mind. And these are the various algorithms and cartoons telling you that how you can control the diabetes with CGM device or glucometer with point of care glucometer and other things, which is seen here. Lastly, there are various guidelines from various society like consensus guidelines, endocrine society, ACE, Canadian, and that also has mentioned so many things in detail. So we can also think of these guidelines in management of diabetes. So in conclusion, I would say that hyperglycemia in the hospital is common, associated with poor hospital outcomes. For non-critical ill patients, insulin also remain the agent of choice for patients with severe hyperglycemia, high doses of insulin at home, type 1 diabetes, or those with steroid-induced hyperglycemia. In patients with mild to moderate hyperglycemia, the use of basal bolus approach with or without non-insulin agents might simplify the treatment regimes. The use of diabetes technology in hospital is rapidly evolving, but there is not ready yet for widespread use. The experience gained with the use of such technology in hospital setting during COVID-19 pandemic will be invaluable. Healthcare system should continue adapt and transform the patient's care of diabetes and hyperglycemia to provide cost-effective and patient-centered quality of care. And thank you very much for your patience listening. And I think this was the last lecture of the symposium. And I would say that good morning from Seattle, and thank you all for your kind listening. And I hand over the mic to the organizers for further deliberations. Thank you.
Thank you, Dr. Navneet Shah. Now, I don't see any questions in the chat box. Organizers, if there are any questions that you can, if there are to be asked.
There is no any question.
No questions. So, okay, so I thank all the speakers immensely for their wonderful deliberation and presentation. And I also thank organizers and Dr. Bansi for giving me the opportunity here to be with you. And I am in US too, and good morning to you. Here it is 6 o'clock now. Thank you and signing off.
Thank you, ma'am. Thank you.